A cheerful morning to one and all present here in this online forum. I am extremely privileged to welcome this galaxy of distinguished speakers, chairpersons, delegates, and my dear colleagues for the inauguration of this virtual CME on hepatitis can't wait, organized by the Department of Microbiology with the Scientific Society AVMC. On behalf of this organizing team, and with the divine blessings of our founder chairman, with the benevolence of Honorable Chancellor, Madam Chancellor, Management, Dean, Faculty, and other staffs of AVMC, we welcome you all for this national level CME. Today we are going to really release a series of talks on hepatitis, conveying the urgency of efforts needed to eliminate hepatitis as a public health threat by 2030. So let's start this occasion with Tamil Thai Valtu.
Good morning. May I now request Dr. Lata, Professor and HOD, Department of Microbiology, AVMC, and Organizing Chairman of the CME, to deliver the welcome address.
Thank you, Dr. Bharati. Good morning to one and all. I'm extremely pleased to welcome one and all present here in this virtual, a very important national CME on hepatitis. With the blessings of God Almighty and our founder chancellor, Dr. Shanmugasundaram, and under the able guidance of our young and energetic chancellor, Dr. A.S. Ganeshan sir and Madam Chancellor, Dr. Anuradha Ganesan, we are here to extend our hearty welcome to you all. With immense pleasure, we also welcome our constant pillar of support, our Dean Sir, Dr. P.F. Kotur. We also welcome our Dean HP Madam, Dr. Mahalakshmi, Medical Superintendent in charge, Dr. Deepa, Director Research, Dr. Vishnu Bhatt Sir, and Vice Principal, Dr. Rajan and Dr. Arunachalam. We feel immense pleasure in welcoming our guest speakers who are going to enlighten us with the latest updates on the hepatitis. We are also privileged in welcoming our college and hospital faculties, other delegates, postgraduate students, and other college and our college students and our MBBS students also. Once again, I welcome you all to refresh your brain with the latest updated knowledge on hepatitis. Welcome you all.
Thank you, ma'am, for enlightening with your words. I now request Dr. V.N. Mahalakshmi, ma'am, Dean HP, AVMC College and Hospital, to deliver the presidential address. Over to you, ma'am.
Good morning, everyone present. Welcome to AVMC. And we are very happy to host all the delegates, faculty members from AVMC and other colleges, as well as the students from both AVMC and other institutes in this lovely CME. And a warm welcome to all the resource persons who have been present today. I see Dr. Jayalakshmi ma'am has already logged in. Welcome, madam. And it's nice of our Department of Microbiology to organize this CME on the occasion of the World Hepatitis Day. As you are probably aware, it's one of the vibrant departments in our institute, be it in student educational activities, continuous professional development activities like this workshop, or being part of the medical education unit, or taking part in research. They have two funded projects. One of it is an international project, or more importantly, helping us with patient care activities. Their services during the COVID pandemic and setting up the virology lab and getting it going. All this needs to be documented, expressed, and appreciated very much. Kudos to the department and also to Dr. Lata for leading her team very well. And on this CME, I see a lot of interesting talks to keep us updated about what's happening in hepatitis front. And I hope that this will be very useful for all the. Okay. I hope it will be useful for. There is some echo going on. Can you please mute all the participants? Right. Thank you. So that this CME, I hope, will prove to be very useful for all the participants as well as for the students. With these few words, I'd say welcome to the CME and welcome to AVMC. Over to you, Doctor. Thank you.
Thank you, ma'am. I now request Dr. Vishnubhat sir, Director Research, Aravindhan Medical College, to deliver the felicitation address. Over to you, sir.
Good morning to everybody. It is a very nice occasion to conduct a CME program on behalf of management, administrators, and the organizer team led by Dr. Lata. I welcome you all for this important CME program. So there is nothing like transmitting knowledge and education to others, because it is the highest of dhanam which a human being can give. It supersedes all other dhanams when compared to educate others. And they have taken a very important topic, that is hepatitis infection, and identified leading educationists from all over the country and to deliver the topics, which will be, of course, will give wide range of knowledge to all the participants. When I was a student, initially there was only one hepatitis, so everybody will say hepatitis. Then hepatitis A became now. There are 5 types of virus, A, B, C, D, E. Now I am sure another 10 years we may filling up more and more alphabets and knowing more and more about this viral infection. And some of them are transmitted by food contamination or fecal-oral route, while some of them be transmitted through injection needs or through the body fluids. So we need to know about that, because some hepatitis virus infections are a little milder when compared to others. Others can cause, like as you know, chronic hepatitis or cirrhosis liver, carcinoma of the liver, various things can happen. And it's also important to know that we have vaccination, especially against 2 of these viruses, A and B, and adequate immunization at a young age, prevention of vertical transmission, improving the sanitation and hygiene, probably will bring down the prevalence of this disease. For some people, it may be mild. Various treatments have been tried: allopathic, Ayurveda, Unnani, Siddha. Everybody says I will cure this disease, but there is nothing very definite. Of course, some may work, some will become all right without treatment also. So we don't know much about the virus and the treatment. Only thing is immunization is there, and probably they will develop vaccination for all these viruses, so that in the long run we may be able to prevent. Prevention is always better than cure. When the disease comes, of course, we have to face it. So without taking much of your time and giving more time to the speakers and the participants to interact with them, I wish you all the best. Thank you very much.
Thank you, sir. Without taking much of your time, I would like to call upon Dr. Jayalakshmi ma'am, Dean University of IS, Sri Lakshmi Narayana Institute of Medical Science, Puducherry, for giving an overview of hepatitis. I request Dr. Mahendran sir, Department of Microbiology, AVMC, to introduce the speaker. Over to you, sir.
Good morning, everyone. Really, I'm very happy to introduce Dr. Jayalakshmi Madam, who is Dean, University of Affairs, Sri Lakshmi Narayana Institute of Medical Sciences. And she has completed her MBBS in the year 1981 in Madras Medical College and MD Microbiology in September 91 and MGR Medical University. And ma'am undergone her tutorship in May 1991 and assistant professor in 1980. Eventually, she has got promoted in timingly, and she is now an Dean, University of Affairs, and she is in SLIMS, Pondicherry. Ma'am obtained appreciation certificate from Collector Madurai for ELISA for the 6,800 samples in 3 sessions per day during dengue epidemic. And she has got awarded for the best teacher by TN Dr. MGR Medical University in September 2011. And she also got award for the best teacher awarded by University in the national conference in July 2014. And she has won the national award for best poster presentation in rheumatology in the October 2006, and won the appreciation of Honorable Health Minister for the best performance under CMCHS insurance. And Madam have many contributions as Dean of SIMS, and she has research publication more than 21. And with this thing, I'd like to call Jayalakshmi Madam for her talk. Ma'am, welcome, ma'am. Now, dice is yours. I'll share your presentation now.
Okay, thank you very much. A very good morning to everybody. Today, I'm going to give you a lecture on overview of hepatitis. First of all, I want to express my sincere thanks to AVMC, which is almost 8 kilometers from here, for giving me an excellent opportunity to share my views. And then my sincere thanks to Mahalakshmi Madam, Kotto Dean Sir, Vishnu Bhatt Sir, and all the faculties who has been organizing chairperson for the Lata Madam and Bhaskaran and everybody, K.Sethumadhavan, Department of Microbiology as a whole, and all the staff members of AVMC. Let me start my lecture by saying a very good morning, and this webinar will be very useful. On July 28th is the Hepatitis Day, but somehow it got postponed, and at least it is getting materialized, and we can have some overview of that. So being a national conference, national webinar, all the students and the faculties and the participants will be benefited by this. Let me start my topic. Hello? Can I have the full screen, please? Slide sharing, can I have the full screen, please? Magendran?
நம்ம ஷேர் பண்ணாம கேட்டுக்கோங்க. நம்ம ஷேர் பண்றது நம்ம பிபிடி அப்படி ஷேர் பண்ணிக்கலாம். அது கேட்டுக்கோங்க. ஓகே.
Hello?
Ma'am, can you see the PPT, ma'am?
Yes, I want the full share, full screen.
நம்ம ஷேர் பண்ணாம.
It is very small for me. Or otherwise I will share.
Okay, ma'am. If possible, you can share, ma'am.
Yes.
Just
I'll
stop
try.
sharing and I'll give the privilege of
It
sharing.
is quite well seen. Maybe.
Ma'am, now you will be able to share, ma'am.
Yes, I'm sharing. I'm trying. Previous. Just wait.
I think now you make it full screen. Yes, it's okay. I think.
Yes. Is it clear, sir?
Yes,
Is it
yes,
clear?
Yeah, I think
Yeah,
it looks
I say start.
Yeah.
Yes, sir. Hepatitis is one of the important topic. India is facing so many epidemics and outbreaks of hepatitis. It is one of the viral infectious disease. This hepatitis generally is referred to as group of a syndromic approach on some hepatitis viruses which have the tropism for hepatic cells. And the important viruses A, B, C, D, E. It is very simple to remember. Even the common man will remember. It is just the alphabet. And this is one of the infective cause. Apart from that, we have alcoholic hepatitis, which is very common nowadays because of the booze and abuse of alcohol. Then toxic hepatitis caused by this junk food, oil, reused oil, reheated oil, certain poisons, chemical fertilizers, medicines, overuse of medicines, and then supplements. All these things are also damaging liver. And apart from that, autoimmune hepatitis, this is also one of the important aspects. The chronic type, this will always be the chronic hepatitis, which your body's immune system will be attacking its own tissue. And then the history dates back. It is not the recent disease. It is approximately from the history, we can see that is, it dates back to 2,600 years back. You can imagine, even in the jaundice in Babylonia was written, Hippocrates has demonstrated, then after inoculation of human being in 1883, it was noted, in 1941, the post-vaccination jaundice in 28,000 USA soldiers was noted after inoculating the yellowpox vaccine. Then 1947, the names were given. There are two types of viruses, that is infectious hepatitis and serum hepatitis. One was transmitted by fecal-oral route and contamination of the food substance. So it was called as hepatitis A, and the other was found to be transmitted by blood and body fluids. So it was called as serum hepatitis. In 1963, hepatitis B surface antigen was identified, which was one of the remarkable discovery, and that was the landmark for hepatitis history outbreak. Then 1973, hepatitis identified by electron microscopy, The electron microscopy was very helpful in identifying the structure and determining the molecular genes and then the genomic structure. Everything could be seen, as well as it was very useful to find out the mutations and other things. In mid-1970s, hepatitis D was recognized, and mid-1970s, non-A, non-B hepatitis outbreak, especially in New Delhi, was noted. And then in mid-1980s, epidemic of hepatitis A, enteric hepatitis was noted. 89, C was cloned and the serological test developed. 1990, hepatitis E cloned and characterized. And nobody can forget the beautiful description and the remarkable discovery of Bloomberg about the Australian antigen and Dane particle, which paved the way into the history of hepatitis B invention. Then viral hepatitis, as you know, hepatitis, it is nothing but inflammation. Hepa means liver. So liver inflammation caused by several types of viruses that attack the liver. Hepatitis A, B, C, D, E. Then this is the general picture. You will be able to see how it is spreading. It is just the brief outline. A, it is fecal-oral route. And then E is also fecal-oral route. B, C, D, you have to separate into two categories. Fecal-oral route, A and E. So naturally, the symptoms will be fever, jaundice, nausea, vomiting, diarrhea. Here in hepatitis A, 6 weeks recovery time will be there. Hepatitis E, you have to be very careful. It will lead to fulminant hepatitis, especially in pregnant women. Otherwise, these infections will never produce any serious disease. Everybody will be infected and they will recover. Only in pregnant women and immunocompromised, they have their serious path. Then hepatitis B, C, D, we have to be very careful because the major economic drive of India is determined by these viruses, as India is prevalent with these viruses, and hepatitis B will lead to cirrhosis of liver. And then finally, at later stage, it might lead to cancer of the liver. Whereas hepatitis C will lead to chronic hepatitis and then hepatocellular diseases. And apart from that, it can lead to autoimmune hepatic diseases. And then finally, hepatocellular carcinoma. Hepatitis D is a greater risk of liver failure, acute attack, and then sudden onset of liver failure. Yesterday, the patient was nice. After hospitalization 1 week, the liver suddenly failed and massive turnover of events, death occurred. All that could be due to hepatitis D virus. So these three viruses, B, C, D, are very, very important. Then this is the overview. As you know pretty well, fecal-oral route, the source must be feces, and the route will be fecal-oral for A and E. And then chronic infection will never occur, and everybody will recover automatically. Whereas chronic infection possible B, C, D, and it is transmitted by blood and the blood products and body fluids. And the route, here it is fecal-oral, whereas here it is percutaneous and paramucosal. Then prevention, pre and post-exposure immunization is available. Ensure safe drinking water for hepatitis A and E. Pre and whereas for B, C, D also, C you can prevent. For B and C you can prevent because blood transfusion and blood products. So you can do the blood donor screening, blood screening, everything you can do. And you can do pre-exposure prophylaxis and post-exposure prophylaxis. Hepatitis C is common with the drug induced. So you have to be very careful. So risk behavior has to be modified. And then B, C, D will also spread by sexually transmitted. So you need risk behavior. And then you have to be very cautious in preventing all these viruses by taking necessary steps. For A and D, ensure safe drinking waters. Then, viral hepatitis differential features. you have to remember the only one virus, double stranded DNA is hepatitis B virus, whereas all the other viruses are single stranded RNA viruses. And then if you analyze the incubation period will be greater for hepatitis B virus. Please note 28 to 160 days. Approximately it is 1 month to 5 months plus. So approximately 1 to 6 months. Then if you see hepatitis C, it is also like that. Then hepatitis D, 3 weeks to approximately 6 months, almost 5 to 6 months. Whereas hepatitis E, it is little bit short-termed. And then fecal-oral transmission, as I said again and again, it will be by yes, and this is for no. Then parental transmission is not occurring by hepatitis A and E, whereas parental transmission will be by B, C, D. Sexual transmission also very common with B, C, D, but there is no sexual transmission for A and E. Then fulminant hepatitis, as I said previously, hepatitis D, it is very common. And then hepatitis E, don't forget, especially in pregnancy, it is common. Whereas fulminant hepatitis, it is rare. Then chronic hepatitis, then it is hepatitis C, 85%. And then hepatitis D, the chronic hepatitis will occur because due to superinfection, it is superinfected with the hepatitis B virus, and then it will produce chronic infection. And hepatitis B, it is 10%, whereas hepatitis A and E, they are mild and they will not produce such a serious disease. So what is the incidence? Viral hepatitis is a major public health concern. 10 millions have been affected worldwide, usually universal during childhood in developing countries. Almost every child in the India would have suffered and recovered from hepatitis A, whereas hepatitis B, very serious disease, no, because here the recovery is 100%, whereas in B, there are so many stages you will turn into, which I will be telling you in shortly. So it is preventable. It is one of the preventable disease. So everybody should be vaccinated before 18 years, and annually over 1 to 2 lakh Indians die due to illness related to hepatitis B virus infection. Worldwide, 170 millions are infected with hepatitis C virus. The commonest cause for hepatitis, the risk behavior like sexual contact. Apart from that, drug addicts because of the injection percutaneous route, and then the risk behavior that is associated. This is global epidemiology. You are able to see Africa, the highest incidence you are seeing the dark color, whereas in India, certain parts, especially in Pakistan area and in Burma, those areas are also affected, and low incidence is seen in India, but almost it is spread throughout India, and there are certain parts where there is no data available. In India, if you take, you see Maharashtra, Gujarat, and all these areas, Uttarakhand, so many outbreaks of hepatitis have been reported. And then the number and the color also I have mentioned in the PowerPoint. So you will be seeing the dark blue color, that is about highest incidence, and then the blue color will be showing little bit low incidence. And then Chhattisgarh, if you see, no outbreaks have been reported so far. Then what are the liver damage? What are the various stages? Once the viral inflammation automatically recover and the liver cells will come back to normal. Sometimes what happens, the infection will be persistent and it will lead on to chronic hepatitis. And this chronic hepatitis will lead to cirrhosis of liver. Cirrhosis of liver is nothing but nodular cellular structure without any function of the liver cells. And then this will turn on into hepatocellular carcinoma, one of the major havoc of this. Then coming to a small description about each viruses. Hepatitis A virus, I told you previously, It is a RNA virus, single-stranded RNA virus, and then it has got VP1, VP2, VP3 viral protein, and then there is viral protein VPG is also there, and then it is a positive sense RNA, single-stranded positive sense RNA. It belongs to Picornaviridae. First they said it belongs to Calciviridae, and then now they are telling it belongs to Picornaviridae, and then it is noted as enterovirus 72, and the genus it will be hepatovirus. It is a icosahedral particle about 27 to 32 nanometer in diameter, and the capsid has 3 polypeptides, VP1, VP2, and VP3. It is a positive sense linear single-stranded RNA genome of 7.5 kb, only one single serotype. Here you need not worry at all because the laboratory diagnosis will be complicated and the molecular diagnosis will be complicated if you have so many serotypes. Here we are very safe, only one serotype. Hepatitis A virus, it is non-enveloped RNA virus. That itself shows it will not be affected by alcohol solution at all. In COVID, we are washing and doing sanitization with alcohol. But here it will not be, as there is no lipid membrane. So you cannot. So what you have to do, only soap and water wash, and then hygienic measures, and then toilet measures like Swachhi Bharat, and personal hygiene and surrounding hygiene will prevent this. Family picorna mode of person to person through fecal-oral contamination. The incubation period, I told you back, 4 weeks minimum. So what is the pathogenesis? The virus enters into the body through fecal-oral route. So it enters orally. Then it enters into the oropharynx and then GI tract. It does not directly enter via the bile duct into the liver. I wanted to note this point. Once it reaches the intestine, it multiplies. After multiplying via the blood, it is transported to the liver. In the liver, it will be reaching the hepatocytes. From there into the nucleus, there the multiplication occurs. And finally, by exocytosis, the viral particles will be released. And then finally, it will be shed in the bile. Again, it will reach the intestine and comes back in the feces. So a brief viremia occurs because of through the blood, and cellular immune response will occur, and the clinical disease will manifest. And finally, it will be controlled with the prediction of IgM and IgG antibody. So the clinical features, first it will be asymptomatic, anectic, several days to several weeks it will last. You will not be able to find, they will be telling anorexia and no loss of appetite, no taste for food. And finally, full-blown jaundice will occur, leading to vomiting, elevated transaminase without jaundice. And then pathogenesis, prognosis, it is very good prognosis. We need not scare at all. Almost all of us have had this infection in our childhood and we have recovered. No chronic state, 10 to 15% may have prolonged course. Isolated hepatitis A virus infection has excellent prognosis, almost 100% recovery. But in village side, for this jaundice, they will be doing some tattooing and then they will say that serum will seep out and excess bilirubin will be removed. During that process, there is every transmission of hepatitis B and hepatitis C percutaneous, we have to remember. Hepatitis A virus diagnosis, IgM antibody. This our body will automatically make. Whenever you are exposed, first exposure will produce IgM antibody. How long it will stay in the blood? It will stay in the blood for 3 to 6 months. Then afterwards, the IgM will be removed and it will be replaced by IgG. Then once you suffer, it is lifelong protection, like smallpox. Once you suffer once, it will be lifelong protection. If you test positive for IgG, it doesn't signify it is a recent infection or something like that. The IgG will be persistent for long time. And then there are vaccines also for this. So treatment, only supportive management you have to give. You need not give antiviral drug and all. It's not necessary. Automatically it will be recovering. You will recover. And then personal hygiene, hand hygiene, very, very important. So post, then the vaccine is very important when you have to give the vaccine. There are two things. One is passive immunization and then active immunization. Active immunization, 2 doses, especially in the United States of America, it is given and it will be given 2 doses 6 months apart. Suppose if you are going to international travel, if you are coming from endemic area, they want you to have this vaccine before reaching that. And then, who others can have this? Those who are having chronic liver disease, receiving clotting factor concentrates, like some people will be having this factor X, factor Y, they will be having this albumin. These concentrates, they will be getting injected. And then homosexual males and IV drug users, for them you can give this. And passive immunization, not necessary, but very rarely it might be needed, especially in daycare centers. If they have been infected immediately for that child, immediately you have to give HIV immunoglobulin. Unimmunized household contacts within 2 weeks as a single dose. So having finished hepatitis A, shall we move on to hepatitis B virus? This is the hero for all the hepatitis A viruses, and it is grouped as Baltimore 7. Okay. And if you see the structure, it is so beautiful, like a sun, but it is not a beautiful virus. It is a very harmful virus. So if you see the outer layer, you will be seeing some mushrooming like structures. There are 2 types of mushrooming like structure. One is big and the other one is small. The big, which is having a flat surface, that will be the HBS antigen surface. So there are 3 types of HBS antigen: large size, medium size, and small size. So where do you see the large size? The large size will be seen on the big mushroom-like surface. Okay? Where you are seeing the medium size, there are a small mushroom in between the large mushroom. If you observe carefully, you will be seeing the medium surface protein. Then you will be seeing that the Dane particle, which will be like dumbbell shaped, how it originated. That is because of this only small surface protein. You are able to see some pink color in the outer round. You are able to see the pink color, that is small surface protein. Okay. And then if you observe a pink hexahedral shape, and that is the core antigen. You are seeing the green antigen, that is E antigen. This E antigen is very, very important. It is hepatitis E antigen. It is a soluble antigen. The antigen persistence will indicate that you are going into chronic infection and you will be ending in cirrhosis and in future fulminant hepatitis. Whereas the antibody to E antigen, disappearance of E antigen is a very good prognosis. You are recovering. Very, very important. This is the only virus, instead of RNA, it is having DNA. And that DNA is also double-stranded DNA. This DNA is very peculiar in that it has got DNA polymerase. That is very important. And then the multiplication and all those things, I think the laboratory diagnostic people will be explaining all those things, because mine is viewer view. I'm not touching, but it is one of the interesting topic, how this is going to multiply, how it is actually double-stranded DNA, but one circle will be incomplete, how it becomes covalently bonded complete circle, and then how it starts regenerating. All those things are very, very interesting. Every microbiologist will be enjoying the multiplication of the virus, how the DNA will be reverse transcriptase enzyme. It is the peculiar reverse transcriptase enzyme is also there. How it is going to decode and then the viral particle will be synthesized and how it will be released. All those are very interesting topic. Then the DNA polymerase will be there. These are the various lipid bilayer membrane. Please observe lipid bilayer. So it is susceptible to soap solution and alcohol. So it is one of the enveloped. That is why it is called enveloped DNA viruses and hepatnoviridae. So what are the mode of transmission? Parenteral, sexual and perinatal. Very, very important. From mother to fetus during perinatal period, intrauterine period, everything occurs. Sexually transmitted, and apart from that, parenteral by injection, tattooing and other things will occur. Then blood products will also transmit. It is a very complicated virus, as I told you. It has got 8 genotypes. The genotypes 8 are A to D. It is more common in North America, B and Z common in Asia. Genotype A is very good for favorable response to treatment. B compared with genotype C is more commonly associated with the development of childhood hepatocellular carcinoma. If the child is born with hepatitis B virus, every chance of getting hepatocellular carcinoma is more, especially with genotype C. So all these will be deciding the prognosis of the disease. Acute hepatitis B virus infection. As I told you, it has got a long incubation period. Even if you get infected by blood transfusion today, you will be manifesting after 1.5 months to 2 months only. So by the time you will forget, sometimes even it will take 5 to 6 months. So it will be prodroma, fever, anorexia, malaise, fatigue. 1 to 2 weeks later, you will develop jaundice, hepatosplenomegaly, pruritus, intense fatigue. Acute liver failure is rare, occurring in 0.1 to 0.5% of cases. And then what are the various methods of transmission? Intrauterine transmission, male sexual transmission, male infected will give it to female. Female, because it is present in the semen and vaginal secretions, female infected will give it to some male. And then IV drug abuse, that is also one of the commonest one. It can be heterosexual, male to male sexual partners will also get. Then male to homosexual, all those things, heterosexual, very common. And then in the child via placenta, it can be transmitted, or even it is secreted in the breast milk. So through mother also, during the perinatal period, the infection can be transmitted, but it is, they say it is, some people say it is present in the sweat, but there are theories, and some people are vehemently opposed it is not present in sweat. And then whether it is present in tears, there are also 2 schools of theories, present, absent. Will it spread? Yes, they say, and they say no. So, but by sharing in the same plate, and then by hugging, kissing, it cannot be transmitted, they are telling. And so the perinatal transmission, the mother with the child in close contact can transmit the infection. Then how you are going to, the symptoms will occur. Then what do you have to do? It is one of the immune complex disease. Almost HBsAg will be attached with the antibody, both IgG and IgM, and multiple antibodies will be binding with the one hepatitis, the surface antigen particle. So immune complex disease will occur. And then mother's milk, vaginal secretion, blood, semen, saliva. It is present, but how the saliva transmitting, nobody is able to tell. The same way tears also. Then chronic hepatitis B. Once you have suffered hepatitis B virus infection, if you are having this infection in the adult, 90% recovery, but 10% will proceed to chronic hepatitis, and then finally it will lead to end-stage liver disease, and then it will lead to, among the end-stage liver disease, some of them will be ending with hepatocellular carcinoma, 15 to 13%. Then perinatally acquired infection, the children Here 90% recovery in the adults, but whereas in children, if the neonates are infected, only 10% neonate will recover, 90% will have the risk of developing chronic liver disease and hepatocellular carcinoma. That is the two spectrum of the disease. Here, adults 90% recovery, whereas in children 90% chronic stage. So the maternal hepatitis B and E antigen will be positive because of that 90% risk. Maternal E antigen, if it is negative, only 20% risk. So how the mother is transmitting the disease? If she is having HBeAg positive, then the child will be definitely infected and it will lead to chronic hepatitis. If the mother is negative, the child will be able to recover. There are two phases we have to remember. One is immune tolerant phase and the other one is immune clearance phase. Immune tolerance phase, by no signs of significant liver disease. That is very important. They will be harboring the organism. They will be very normal. They will also be mingling with us. We will not be knowing unless we test them. That is very important. Hepatitis E antigen clearance, seroconversion occurs in approximately 15% by 21 years of age. Risk of developing chronic infection decreases with age. As I told you, the adults will not have, if they are infected, the incidence of developing chronic infection in the adult decreases with age. Whereas, if the children are infected, the chances of developing chronic infection is high. 25 to 30% infants and children under 5 years of age having high risk. Less than 5% of older children and adults. So you can imagine 6 times more common in children. What are the extrahepatic manifestations? This is very important. Here not only liver is affected, extrahepatic is also infected. Migratory arthritis. Arthritis will be there in the knee joint. Next day it will be in the small joint. And then again it will be moving on to the hip joint. So that is migratory arthritis, one of the characteristic feature. Some will develop angioedema. So sometimes the vascular inflammation with the edema they will develop. Then maculopapular and tricarial rash will be developing. Some will be proceeding to glomerulonephritis. Then papular acrodermatitis of childhood, which is called as Jayalakshmi syndrome. That is also very common in children. Confirmation of hepatitis B virus infection based on serological assays of the specific virus antigens and antibodies. This serological test for hepatitis B virus itself is one of the important topic for MD microbiology. One of the important question they will be asking in orals and they will be asking in all the international question papers. So very, very important because the clinical diagnosis and the interpretation treatment will all based on this only. So let us see the natural history. Once a person is infected with acute hepatitis B virus infection, how it will be proceed? As I told you, you have to divide into 3 categories. Adult first we will finish. Very simple. If you get, the adult is getting hepatitis B virus infection, 95% will be coming out of the infection. The infection will be resolved. Very happy. Only 5% will proceed to chronic infection. Okay. So adult we have finished. Now we will go to early childhood. Early childhood, less than 18 years and up to adolescent years. If they are infected, 20 to 50% will definitely go for chronic infection. So resolved, 50% will be infected, 50% will be resolved. Okay, it is medium. Then if you go to perinatal, only 10% will resolve in the early stage, neonatal And then in the first year of life, second year, perinatal, neonate, if the infant stage, if the child is infected, 90% will develop into chronic infection. Once you know this thoroughly, then the next, it will be very easy to understand. The chronic infection will proceed into 2 stages. Resolved, they will completely recover, you leave them. So whoever is developing chronic infection, they will go into 2 stages. One is immunotolerance stage. Other one is immunoclearance phase. Immunotolerance is nothing but they will be having the infection, they will not manifest any symptom, and they will be mingling with others. Liver function will be normal up to certain stage, and they will lead a normal life. And that is immunotolerance. And then immune clearance, some of them at later stage, because of the cell-mediated immunity, keep on clearing the hepatitis B, E antigen, and ultimately they will come back to the resolved phase. But those who are not cleared, they will join with the immune tolerance phase. So now we have to see some of them who have not cleared the antigen will leave the immune clearance phase. If they are not able to clear the antigen, they will be straight away going into cirrhosis. If you understand this point, then very, very easy. Now we are left only with immune tolerance. How they will proceed? Some of them will be going into resolved stage, or some will develop into inactive carrier state, and then finally spontaneous loss of surface antigen. That will be there, or this inactive carrier state will proceed to core mutation. Hepatitis C virus, the hepatitis B virus, there are X gene, S gene, and then core gene, C gene. This core gene, there are 2 parts. One is the pre-core and the post-core. The pre-core, from that, if it is transcripted, you will have E antigen. That pre-core, if it is going to be mutated, then you will get the reactivation phase. Now you have to dance to the tune. So what will happen? Finally, you will lead to cirrhosis. Once the cirrhosis occurs, it can proceed into 2 things. One is decompensation of liver failure, and you need liver transplantation. The other one is hepatocellular carcinoma, the other extreme, and ultimate death will occur. So this, we have to be very thorough. So the children are highly dangerous if they get infected. And then, what are the various antigen and antibodies? You have to remember, there are only 2 antigens you have to remember. The 2 antigens will be HBsAg and then HBeAg. One more will be hepatitis B core antigen. This hepatitis B core antigen is very peculiar. You will never get in the serum at all. It will be present only in the liver cells. That antigen you can never detect by blood. If you have one MCQ stating hepatitis B core antigen detected in saliva, detected in serum, cannot not detected in tears. If you have that MCQ, if you write, your answer should be not detected, should be there. It is not, though it will be present only inside the liver cells. It cannot be demonstrated by serum. So it can be demonstrated only by liver cells immunofluorescence. So the hepatitis B core antigen we have finished. So coming to the rest of the 2 antigen, one is HBsAg, other one is hepatitis B E antigen. These are the 2 antigens you have to remember. So these 2 antigen, as we know pretty well, once the virus enters into the body, it starts multiplying. So what are the antigens will be produced? Naturally surface antigen and E antigen, envelope antigen, E for envelope. Envelope antigen will be produced. So in early or acute phase, these 2 antigens will be positive. In the recovery phase, what happens? This will be neutralized by the antibodies. So naturally, these antigens will be absent in the recovery phase. In replicative phase, in chronic hepatitis B virus infection, what happens? Again, because it is replicating, HBsAg will be produced, E will be produced. So if you remember these points, it will be very easy for you to give the interpretation for the lab diagnosis. Then hepatitis B core IgM. The IgM will be early acute phase, it will be positive. I am telling core IgM. Just now I said core antigen cannot be detected in the blood. Then you will be asking me how this is detected. This is IgM antibody. Please note, I mentioned about the antigen. Whereas HBsAg and HBeAg antigen you can see in the serum, detect in the serum. Whereas antigen hepatitis B core you cannot detect, only in the liver cells. But the antibody IgM you can detect. So that will be positive in acute phase. Okay. Then the acute phase, this will have core IgG also. This will be present in the recovery phase, replicative phase, and then previous hepatitis B virus infection, it will be there. Then HBs antibody, recovery phase, it will be there. E recovery phase, it will be there. And then hepatitis B virus DNA will be there almost in all stages because that is molecular diagnosis. So now we are going to see the immune various phases. In chronic hepatitis B virus infection, I told you there are different phases. Immune tolerance phase, immune active phase, carrier state, all those things. Let us see one by one. Immune tolerance phase. Here it will be HBeAg positive. And then, or sometimes HBe antibody will be negative. So immune tolerance antigen will be positive and antibody will be negative. Hepatitis B virus DNA titers will be very high. I told you they will not have any symptom. So normal LFT. Liver biopsy also. LFT is normal, so no liver damage, non-specific hepatitis. So immune tolerance, once again I will repeat, antigen E antigen positive, antibody E antibody negative, DNA titers high, normal LFT. Immune clearance phase. Here, antigen positive, antibody negative. The same as that. Hepatitis B virus DNA titers will be very high. Elevated LFT. Remember, immune clearance. Elevated LFT. They are normal LFT. Here elevated. Liver biopsy shows chronic hepatitis, moderate or severe chronic necroinflammation. There you saw non-specific hepatitis, mild, here moderate or severe. So these points you have to remember. Then inactive carrier phase. Here antigen will be negative, but antibody will be positive. That means good prognosis. Hepatitis B virus DNA titers will be low. When do you call as titers low? Less than 2000 international units per ml, you call it as low titer. Normal LFT, liver biopsy, absence of significant hepatitis. Then reactivation phase, often associated with the pre-core or core mutation. Antigen will be E antigen negative, E antibody positive, DNA titers moderately high, elevated LFT, liver biopsy shows chronic active hepatitis. So if you remember these points, and then if you get the laboratory results, you can name them under different phases. So these are all formulas like resolved hepatitis, previous known history of acute or chronic hepatitis, and then core IgM will be negative, but IgG will be lifelong. It will be persistently HBsAg, IgG will be positive, HBsAg will be negative, HBsAg negative, and then undetectable hepatitis B virus DNA titers, normal, alanine transferase. Then resolved hepatitis B. Previous history, HB, again the same slide has come. Okay, then hepatitis B virus diagnosis, how you can do? Blood test. You can do simple ELISA, liver ultrasound, and then liver biopsy. By doing this, thin needle they will introduce and you will. The wide range of hepatitis B virus antigens, and there are so many immunoassays that are followed. Enzyme immunoassay, ELISA, then chemiluminescent immunoassay, then molecular diagnosis, serum or plasma using polymerase PCR, then focuses on the hepatitis B surface antigen by the presence of HBsAg immunoglobulin IgM antibody to the core antigen. During the initial phase of infection, patients also seropositive for hepatitis B antigen. E antigen usually a marker of high levels of replication of the virus. HBe antigen indicates that highly contagious, and at the same time, it also indicates high replication. So they will be. There are two things in hepatitis B virus. Carrier state. When the HBsAg is persistent for more than 6 months, you call them as carrier. And then whom do you call as super carrier? If they have persistent HBe antigen in their blood, you call them as super carrier. This is also one of the important questions in MD. Chronic infection is characterized by the persistence of HBsAg for at least 6 months. Persistence of HBsAg is the principal marker for risk for developing chronic liver disease and liver cancer later in life. Hepatitis B surface antigen. Common group antigen A, type specific antigen DYYR. WR, antigenic subtypes ADW, ADR, AYW, AYR. Our India is prevalent with ADR. Hepatitis B core antigen, antigen nucleoside core. E is nucleocapsid protein. Then, this is also again serological marker and virological marker. HBsAg, if you are seeing, it can be acute or chronic antigen. HBe, you are seeing high level of HBV replication, infectivity, and it is also negative to treatment. Hepatitis B virus DNA, then level of viral replication. Anti-HBC IgM, acute infection. Hepatitis B, E, IgG, recovered or chronic. Anti-HBs, recovered from hepatitis B virus infection. Anti-HBV, low level of viral replication. Anti-HBC, fast hepatitis B virus infection. Then hepatitis HBsAg, IgEg, and hepatitis B core antigen IgG, chronic. Then IgG, anti-HBs, then hepatitis B virus DNA PCR, latent or occult hepatitis B virus infection. Then diagnosis, hepatitis B virus antigen, DNA, then different antibody, again the tabular column. With this also, we have to give the interpretation. What I said previously, the same thing in the tabular column representation. The same thing, primary markers for the diagnosis of chronic hepatitis. What are the diagnosis for acute? What is the diagnosis for chronic? Again, you have to put, depending on the antibody, antigen, when it will appear, what antibody will appear, that tabular column you have to apply over here. This is the thing, you are seeing the HBsAg, like it's going, and then bell-shaped curve you are seeing, and then total anti-HBC, some one straight line, then anti-HBC, anti-HBs, the antibody is rising, and you are seeing the E antigen, and then E antibody, everything. Then in chronic, you are seeing the curve is deviated. You are seeing the total anti-HBC, and that and all you are seeing, and ALT level is increased. So this is again treatment algorithm. What is the thing? What is the thing? How you have to treat? I think the lab diagnosis people will be dealing it in great detail because my time is going to end. I can't be. So I consider the lab diagnosis people who will be giving as the last lecture, K.Sethumadhavan, Mangaiyarkarasi. They can cover all these topic because mine is overview. I'm skipping. Then acute hepatitis, supportive care, chronic, elevated transaminase, liver biopsy, therapeutic options, pegylated interferon, PEG interferon, then some antiviral drug like lamivudine, adafovir. That also treatment people can put an insight into that. Then post liver transplant, then immunoprophylaxis, you have to give active and passive immunization, then especially for the pregnant mothers, and then breast milking, breast milk eating child, everybody should be taken care of. Then the vaccine, 3 doses it will be given, and every person before 18 years, they must be vaccinated. It is also one of the national immunization schedule of India. Then recommendation, who all should be done, sexual partners, then the blood concentrate, those who are receiving, men who have sex with men, homosexuals, injection, drug users, susceptible household contact, healthcare, and public health workers. Hepatitis C virus. So I am proceeding to hepatitis C virus. You are able to see a positive sense RNA. This is also a single stranded icosahedral capsid. And then lipoprotein envelope is present. So enveloped single stranded flaviviridae. And then 6 genotypes. Most common in North America, genotype 1 is responsible. And then favorable response to treatment. Hepatitis C virus, highly prevalent, most important cause of chronic viral hepatitis in the US. Why the liver transplantation, the cause for liver transplant, indication for liver transplant in US, mostly due to hepatitis C virus. Mode of transmission, I told you already, percutaneous, non-percutaneous. Non-percutaneous, sexual workers, vertical transmission from mother to child, 2 to 3 times, and then with the hepatitis HIV and hepatitis C, HBS, hepatitis B virus, this co-infection is highly more common. How hepatitis C is spread? It is injection 60%, sexual 15%, transfusion by 10%. Then other hemodialysis, peritoneal dialysis, 5%, unknown 10%. Incubation period, approximately 1 to 2 months, off month to 2 months. Acute HCV, mostly asymptomatic, liver failure rare, but co-infection with other hepatotropic hepatitis B virus may proceed to rapid progression of the disease. Spectrum, minimum clinical symptoms, jaundice, elevated transaminase, extrahepatic manifestation, essential mixed cryoglobulinemia. It is also will produce autoimmune disease like symptom, autoimmune thyroiditis, porphyria, lichen planus, non-Hodgkin's lymphoma. Natural history, acute hepatitis C infection, it can resolve or sometimes proceed to chronic hepatitis, cirrhosis, then hepatocellular carcinoma, decompensated liver. Neonatally acquired associated with 25% spontaneous clearance rate. Then what are the initial tests you will do? Serum, HCV antibody, HCV RNA by RT-PCR. Infants born to HCV infected mother, HCV antibody testing performed at 18 months of age. Earlier diagnosis, HCV RNA testing may be considered 1 to 2 months of age. HCV genotyping should be performed. Why it should be? To determine the prognosis and the duration of the therapy. So recommended testing sequence and identifying at what stage. Suppose if it is reactive, how it will be positive or negative, not detected, no current. Then what you should do, this is something algorithm which you can get and you can paste it in the lab and follow these guidelines. Then HCV clinical, liver biopsy, then initiating therapy, present symptoms is chronic liver disease, liver biopsy will show severity of the damage, and parental or patient request for therapy. Cirrhotic patient, ultrasonography will be useful. Then hepatic MR imaging, that will also guide you. Then HCV cirrhosis is also universal. Then acute HCV, here also pegylated interferon, one of the treatment modality, and then combination with the ribavirin, one of the drug of choice for hepatitis C virus. Then what is this is also treatment algorithm. This from anywhere you can get and you can decide. Then virologic response during therapy. HCV RNA negative by week 4 of treatment by PCR allows shortening of the course for genotypes 2 and 3, viral load genotype 1. So early virologic response, that is EVR, you should get more than 2 log reduction. Suppose if it is 10 to the power of 8, it should be 10 to the power of 4 and 10 to the power of 2 log reduction. You should get HCV RNA negative at week 12 of treatment. Then it shows early EVR, predicts lack of sustained virologic response. Where do you get SVR, sustained virologic response? HCV RNA negative 24 weeks after cessation of treatment, best predictor of long-term response to treatment. Then we are proceeding to hepatitis delta virus. Small defective RNA virus. Why it is defective? In the presence of hepatitis B virus infection, the hepatitis B virus surface coat, HBsAg will be produced, and then only it will be leading to infection. So co-infection is very important, or sometimes even super infection will also be occurring. Then co-infection and super infection. Then HDV antigen, hepatitis B virus core antigen, hepatitis D virus RNA, more than double the rate of progression to cirrhosis than hepatitis B virus alone. Hepatitis E virus, non-A, non-B hepatitis, and then RNA. So this is the structure, lipid bilayer will be there, P24 capsid, GP120, GP41, all these things will simulate us about the HIV virus, reverse transcriptase, all these things. Then family calcivirus, mode of transmission, fecal-oral route, incubation period 2 to 9 weeks, affects mainly adolescent and adults. So clinical scores self-limited. Everybody will recover, may be severe in those with the pre-existing chronic liver disease. Especially you have to be very careful about this infection in pregnant women. 90% it will lead to fulminant hepatitis, especially in third trimester. Alcoholic hepatitis. So you see disease, inflammatory condition, heavy alcohol consumption, diagnosis, central blood count, then CBC, liver function test, ultrasound, CT scan, blood clotting, liver biopsy. Patient needs to stop drinking, very important. Autoimmune hepatitis, chronic inflammation, unknown cause, autoantibodies in serum, majority of the patients, especially all autoimmune antibodies are common diseases or common in females. Autoimmune reaction against normal hepatocytes, destruction of one's own hepatocytes, serological markers such as anti-nuclear antibodies, anti-DNA antibodies. So today, July World Hepatitis Day. So by this, we are celebrating day. Nothing is late, but never be late. That's all. And then, thank you very much for listening to me patiently. Before listening to this lecture, I think you all will be puzzled about the diagnosis and various phases. Now I think there will be some illumination, a bulb in your mental picture. So how to approach, how to do the lab diagnosis. I hope so you would have enjoyed with this I have exceeded my time limit. Very sorry for that. Thank you very much. Most of the points I was not able to tell because it was a general topic with overview. I couldn't cover many of the important ones. I hope the other people will cover in that topic. And once again, I congratulate AVMC for conducting such wonderful webinar. And I thank the microbiology department for organizing such a wonderful event. And I once again thank for those who have participated in this webinar and listened to my lecture. Thank you very much.
Thank you, ma'am, for your most informative introductory section. We are really overwhelmed to have with us Dr. Suresh, Professor and HOD of General Medicine, Sri Venkateshwara Medical College and Hospital and Research Center, Puducherry. Sir is here to enlighten us on the clinical picture of hepatitis. I request Dr. Pungodu, ma'am, Department of Microbiology, AVMC, to introduce the speaker.
Good morning, everyone. Good morning, Professor. I have been undergraduate from PhD Medical College, Coimbatore. Diploma in Thanjavur Institute of Medical Science, and he has some personal interest in diabetes as well as in the field of gastroenterology. He has got special degree of PG diploma in gastroenterology from American College of Gastroenterology. It was a certified program mainly covering the hepatology. He has done various researches in general medicine and he has done number of publications, 15 papers, both in national and international journals. And he has been a Rising Star Award in the field of medicine from Times of India 2020. Welcome, you, sir. The stage is yours.
Thank you very much for this nice introduction, madam. So before I like to start my talk, am I audible?
Yes, sir.
Am I audible, madam?
Yes, sir, you're audible, sir.
Okay. So before I like to begin my talk, I like to thank the administrator of the AVMC, as well as I am very much thankful to Professor Lata, Professor of Microbiology, and I am very much delighted with the communication of Dr. Anushila and Dr. Mahendran for this talk. So with that, I will begin my talk. I'm going to talk about mainly the clinical picture of hepatitis. It is a very vast area. I'm trying to cover in a nutshell manner. What I'm going to talk today about etiological and clinical classification of hepatitis, clinical feature of acute hepatitis, and clinical course of acute hepatitis, complication and sequelae of acute hepatitis, and clinical features and sequelae of chronic hepatitis to end-stage liver disease. So why should we need classification? Sorry for the overlapping with the previous presentations, but as a clinician, we divide hepatitis into infectious hepatitis, toxic hepatitis, radiation hepatitis, and the autoimmune hepatitis. In the infectious hepatitis, viral hepatitis is very common, and also there is bacterial hepatitis. If a patient present with jaundice only with hepatomegaly, there are a lot of differential diagnoses should come into the mind of a physician. So apart from the viral hepatitis, there are some bacterial infections like hepatospirosis, syphilis, and like amoebic liver disease, toxoplasmosis. All those things should come in mind. Apart from these infections, there are local hepatitis, drug-induced hepatitis, toxins-induced hepatitis, and radiation hepatitis. There are separate entities called autoimmune hepatitis. So all the things we are going to see in this presentation. So as far as the etiological classifications, first we see about viral hepatitis, because that is the most common cause of hepatitis when a patient comes, because the alcoholic hepatitis usually present in a late stage cause cirrhosis or portal hypertension or hepatic encephalopathy. So most of the time we receive a case of viral hepatitis. In that 40% are attributable to hepatitis B. So there are some other causes of hepatitis which should have been told by the previous speaker. Anyway, as a clinician, we should know the various causes of Epstein-Barr virus. So the causes of hepatitis, that is Epstein-Barr virus, cytomegalovirus, herpes simplex virus, Coxsackie virus, adenovirus, dengue virus, coronavirus, bacterial leptospirosis, fungi, parasites. Alcohol-related drugs and toxins, particularly the paracetamol poison, which is a very common cause of acute liver failure or fulminant hepatitis. So if you receive a case of fulminant hepatitis, you should ask a history of paracetamol intake. Not only that, the hepatitis may be a feature of drug-induced hepatitis. There are some common causes which produce hepatitis by idiosyncratic drug reactions, most commonly related to antibiotics, anticonvulsants, and NSAIDs, particularly statins will produce hepatitis. People will take herbal and nutritional supplements. Among the toxins, mushrooms called Amanita phyllide should be thought of. When the patient presents with a history of jaundice and presence of icterus, we should, all the etiological factors should keep in mind, so that we'll ask history and examination regarding the etiology we should look for. Apart from this, there are immunological and inflammatory conditions like autoimmune hepatitis, biliary hepatitis like biliary cholangitis or primary sclerosing cholangitis. And now one of the upcoming causes of metabolic hepatitis is non-alcoholic fatty liver. All of you would have been very familiar with the word called NASH. So NASH is becoming one of the common cause for the cirrhosis as well as the hepatitis. The other metabolic disease are hemochromatosis, Wilson's disease also can occur. So the one separate entity is that pregnancy-induced hepatitis, because of preeclampsia or eclampsia can lead to HELLP syndrome. Acute fatty liver pregnancy is not a complication in the pregnancy-related liver disease. So by keeping in all these factors, the clinician should think of the symptoms and signs regarding this etiology. So now from other systemic causes like cardiogenic shock, distributive shock, or hypotension, any cause of hypotension, particularly sepsis and cocaine, amphetamine, ephedrine, and Budd-Chiari syndrome, sinusoidal obstructive syndrome. These are the causes for vascular or ischemic type of hepatitis. And already we have seen that pregnancy-induced hepatitis and also Reye syndrome, you know that there is intake of aspirin will produce Reye syndrome, particularly in children. And there are primary graft versus post reactions also is one of the cause for. So you should keep all these differential diagnoses when you approach a case of hepatitis. So in the history of hepatitis, so you should include all these risk factors in the history. You should ask details about the alcohol usage. You should ask about the history of medications, particularly the herbal components, birth control pills, oral contraceptives, and over-the-counter medication, particularly NSAIDs. These history definitely should be asked in and sexual activity. That's been already told by the previous speaker that man-to-man sex, as well as the multiple sexual partner will leads to hepatitis B. Okay. History of travel to the endemic region, especially for the abroad people. Those who are exposed to high risk patients, that is mainly the healthcare workers. That if healthcare workers comes with jaundice, we should think of the hospital acquired cause of hepatitis, particularly the needle prick or the blood contact, all those history you should ask for. Is there any history of injection of drug abuse? That is very important in case of hepatitis. Recent surgery, because there should have been a sharp instrument which produced injury, and the surgeon may get exposed to the patient of HBsAg positive. So remote or recent use of blood and blood components, one of the way the hepatitis B or blood prick, which leads to hepatitis. There are some diseases which tells you about the family history, particularly Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiencies. Those, if you check any patients, they will be having hepatitis. The siblings also should be checked for the evidence of clinical manifestation of the metabolic liver diseases. So the history of risk factors to be remembered when you approach a case of the hepatitis. And regarding the personal history, never ever fail to ask the history of alcohol, how much they are consuming. Actually, in female, lesser than the male, the 2 drinks per day will produce 20 to 30 grams in women, which is supposed to be the high risk for developing hepatitis. And if it is men, it is 33 to 45 grams is a high risk for getting a hepatitis. There should be a history of alcohol dependence or abuse should be asked, because that leads to immediate acute hepatitis. And there is a questionnaire which is there for every alcoholic to predict the high risk of getting hepatitis, that is called KH questionnaire. Should be added in your history taking sheet. Now move on to the hepatitis. As far as the clinician is concerned, it is divided into 2 parts. That is, one is acute hepatitis, another one is the chronic hepatitis. The acute hepatitis, what is the difference? Mainly the durations, because it can be classified based on the histopathology, as well as the clinically we take that acute hepatitis is the period of inflammation or signs of hepatitis is lasts for less than 6 months. It is acute hepatitis. And chronic hepatitis, suppose the same thing persists for more than 6 months, we take it as a chronic hepatitis. So less than 6 months of clinical manifestation is acute hepatitis. More than 6 months, it is the case of chronic hepatitis. So why we ask whether to differentiate acute or certain etiological diseases will produce acute, certain more preferred for chronic hepatitis. So if you take in the case of viral hepatitis, the A and E is mainly produce acute viral hepatitis, and very rarely they go for chronic hepatitis or complications. Whereas B and C is mainly patient comes with chronic hepatitis. So there are toxic hepatitis like drug-induced chemical, metabolic hepatitis, ischemic hepatitis. They mainly produce acute hepatitis, and the patient will die because of the acute fulminant hepatitis, that is called acute liver failure. There are other causes. One of the emerging causes for the cirrhosis, previously there are entities called cryptogenic cirrhosis. So most of them are turned out to be a NASH, non-alcoholic fatty liver disease. Of course, the autoimmune hepatitis, all those are adding to the chronic hepatitis. So what is the clinical course? Actually, if you take any patient comes with jaundice, immediately you have to think that whether it's acute hepatitis or chronic hepatitis, or it's a state of cirrhosis or state of hepatocellular carcinoma, or in the state of liver cell failure. So generally, in all hepatitis, including viral hepatitis, they produce initially acute hepatitis. Then usually 90% of any hepatitis will be spontaneously recovered. That is one of the good news regarding hepatitis. And more or less the treatment is now conservative, so they recovered well. If they are not recovered, they will go for chronic hepatitis. It persists for some time, then lead on to liver cirrhosis. So this is the clinical course of any hepatitis: acute hepatitis, chronic hepatitis, liver cirrhosis. Some of them turned out to be hepatocellular carcinoma, or they go for the further complications. So we see a patient different stages. So the incubation period was already told by the previous speaker. Just skip it. So now move on to the symptoms of acute hepatitis. So mainly the acute hepatitis symptoms is mainly initially start with mild flu-like symptoms. The subsequent slide I will just explain it. So it starts with mild, short-lived flu-like symptoms, that but fever, arthralgia, or myalgia. Then it leads on to the classical jaundice. So they may present with the classical hepatitis, that is jaundice, that mainly the patient present with icterus. Then most of this acute hepatitis, they spontaneously undergoes resolutions even if you don't treat the patient, provided there should be adequate bed rest and less oil food and less physical activity, which leads out to spontaneous resolutions. And many of the acute hepatitis will be asymptomatic. They will not be having any symptoms. During the routine examination, the liver enzymes found to be elevated. So what are the clinical stages? Mainly 3 stages. First stage is stage of prodromal or pre-icteric stage. And other stages, stage of hepatitis, that is icteric phase, where the jaundice takes over the disease, where the icterus is the predominant symptoms, and another is this stage of recovery. So these 3 stages we can classify the stages of acute hepatitis. So what you get in prodromal stage, that is called pre-icteric phase, where patient will not have jaundice during that period. So there will be general tiredness or fatigue or muscle pain, severe myalgia, joint pain, arthralgia, nausea, vomiting, diarrhea, and loss of appetite. The diarrhea mainly occurs in 2 types, that is hepatitis A and E, because the fecal-oral route is one of the transmissions. So the diarrhea generally will be there in A and E hepatitis. So this is the constitutional symptoms initially the patient will have. Then they have an alteration in the olfaction and taste. There will be a parasmia, that any tasteful foods will look like a distasteful foods. Of course, it will be sometimes it will be benefit for the patient that they'll be having a distaste for alcohol as well as the smoke cigarettes. So usually they leave the cigarettes because of this poor taste and olfactions. So these symptoms are almost similar to COVID. So don't think that it's always going to be COVID. It can be due to hepatitis also. The fever is will be present usually in 100 to 102 degree Fahrenheit, usually in A and E, and very rarely in B when there is associated serum sickness. So don't expect that all the hepatitis patients should have a fever. No. So then we move on to the stage of hepatitis, that is icteric phase. Jaundice and icterus is one of the icterus, one of the characteristic and skins, and they pass urine in the rice and found out the color changes. They want to be yellow, they go for the treatment. And the jaundice is one of the treatment, and the color of the urine will be dark yellow. That is called coluria. So icterus, coluria, and the dark stools. So this is a typical manifestation of stage of hepatitis. I mean symptoms. So you should ask the color of the urine and the color of the stools. The color of the urine will be dark urine, color of stools will be dark yellow, and there will be icterus, you can say. Sometimes they present with polystatic hepatitis, that is clay color stools, which is a classical feature of obstructive jaundice. The as an initial presentation or an occasional presentation, it can be. Okay, don't think that always clay color stools will be a feature of obstructive jaundice. So examination wise, it's very easy to appreciate the acute hepatitis. Only 3 clinical signs that patient will have icterus and they will have hepatomegaly, which is a tender hepatomegaly. So if there is a icterus right hypochondriac pain, and if you see that liver is tender and there is a hepatomegaly, then you are dealing with the case of acute hepatitis, because the acute hepatitis only will present with the hepatomegaly and the tenderness. There are some differential diagnoses like Budd-Chiari syndrome, hepatocellular carcinoma, hemangioma of the liver, congestive hepatomegaly. These things should be ruled out before saying that it is a acute hepatitis. See, the jaundice, the icterus is one of the classical presentation in the hepatitis, where jaundice is a hallmark symptom, perhaps the most reliable marker of the severity of hepatitis. So usually patients report darkening of the urine before they notice clear icterus. So the presentation more of dark urine in case of hepatitis rather than icterus. The icterus usually found by the clinical examiner. Jaundice or icterus is rarely detectable when the bilirubin is less than 2.5. So to have icterus, then you should have the value of more than 2.5 milligram per deciliter of this. One very common question is asked in the Viva whenever student is having a hepatomegaly or a cirrhosis case. To see the icterus, which is the classical signs. So icterus is best appreciated when the sclera is inspected under the natural light. So whenever somebody is asked to demonstrate icterus, you bring the patient to the window in a natural light. The examiner will be very impressive that you are really appreciating the icterus, because if somebody is wearing a yellow shirt, which will reflect on the eyes, will misguide you as a icterus. So whenever the icterus is asked to demonstrate, we should bring the patient to the window side and expose the patient to natural light then. So in a fair skin individual, the yellow tinge skin is very much possible. So this is the picture showing that how do you elicit the icterus. It is mainly seen in the upper bulbar conjunctiva, that is called sclera. So why sclera is preferred than any other tissues like that? The sclera is having content of high elastin fiber, which is almost a friend of bilirubin, where it has the more girlfriend almost, you can say, that it is a high affinity with the elastin. The bilirubin has a high affinity, the elastin fibers, which is very much rich in the upper sclera or the upper bulbar conjunctiva, where it has the expressing the icterus. That is very, very important point to remember. Okay, in a fair skin individual like this, you can see even icterus in the skin. It's very, very difficult to see in the Indian population, where everybody will be having almost a dark skin, where you have to look it in the undersurface of the tongue. That is main important thing, because you see here skin is compared to less yellow because in the dark skin individual. In these cases where you can see the undersurface of the tongue, where even a lip you can see the icterus very well. So other than the sclera, the skin as well as the undersurface of the tongue, palms and soles, where you have to look for the icterus. That is very, very much important. And when the patient present with jaundice, especially dark urine, you should always ask the 3 important history. What is the color of the urine? What is the color of the stools? Is there any pruritus or itchings? These 3 history in every patient of jaundice you have to ask, because you have to first differentiate whether it's a prehepatic or hemolytic jaundice, or it is hepatocellular jaundice or hepatic jaundice, or post-hepatic jaundice or the obstructive jaundice. You see here very much in the urine color will be usually normal in hepatic jaundice. The stool color will be actually dark, and the hepatic jaundice, dark urine and dark stools. Actually, normal means yellowish stools. So if you have a normal urine, dark stool, that is hemolytic jaundice. If you have a dark stools and dark urine, it's hepatocellular jaundice. If you have a clay color stools with dark urine, it is obstructive jaundice or cholestatic hepatitis. This cholestatic hepatitis can also occur in the hepatitis. That's why it will misguide you towards the obstructive jaundice. You should be very careful. Unnecessary, you will evaluate the patient with a lot of imaging and invasive procedure. So think that the cholestatic hepatitis can also occur in the hepatocellular stage in a hepatitis. So that's what dark urine, dark stools, and no itching. Itching will be generally, or pruritus will be seen in obstructive jaundice, where you can see the scratch marks everywhere the patient will be having. So the right hypochondriac pain, that is liver will be enlarged due to which leads to stretching or irritation of the Glissen's capsule, which produce the tenderness. So mostly right hypochondriac tenderness. I told you about the icterus and where you should look for, why should we look for, what are the places you have to look for, and when it will be seen. Then you move on to the right hypochondriac tenderness, which is due to stretching of irritation of Glissen's capsule. Then you should look for pruritus markers. This mainly occurs in obstructive jaundice. I told you it is not the 100% rule, where you can see also in cholestatic phase of acute viral hepatitis. So you can see a scratch mark like a mosquito bite. You can see in the patients everywhere. So there are, apart from viral hepatitis, we should look for other causes also. So you should look for always KF ring. Okay, the KF ring is usually not be seen in a necktie generally. So you should suspect Wilson's disease, and you should look for the K-Flusher ring, which is the just inside the limbus. And that is, you see that differentiating between the arcus senilis and the KF ring is very important, because both are almost looks like same except the color. If you don't find any gap between the limbus and the golden brown segments, that is its KF ring. It should be confirmed with the slit lab examinations. You have to take any hepatitis, even if they give a history of alcohol, if they give a drug, it is routinely should take the patient to go for a slit lamp examination to rule out Wilson. And another hepatitis called Brunn's diabetes, that is one of the cause. It is called hemochromatosis. You see the hyperpigmentation of the hands and extremities and the bodies, where you can clearly differentiate both are white skinned people. This fellow has a hemochromatosis where he has a hyperpigmentation. He develops arthritis. You see the arthritis and hyperpigmentations. This patient will be definitely a diabetic. A diabetic with the hyperpigmentation, with arthritis, with the deformities, you should think of hemochromatosis. So history of diabetes should be asked during the evaluation of diabetes. That is very good. I just show you a picture of the KF ring. KF ring is mainly due to coming in the slide. Can you able to see the videos? Hello? If anyone gives a feedback, I will be happy. Can you able to see the videos, please?
It is playing, sir.
So you see a KF ring here, which is in the outer limbus. This just close golden brown pigment in circular manner. It's typical of KF ring. So it's also present in primary biliary cirrhosis. So when do you suspect the Wilson's disease is mainly whenever any patients comes with the involuntary movements. It can be chorea, it can be atheritosis, it can be a tremor. And then you have to think of the Wilson's disease, because one of the common presentation is neurological presentation. So it will have a presentation, 40% it will be a neurological presentation, and 40% it will be a hepatic presentation, and only 10% it will be showing a psychiatric symptoms. So particularly we should look for the wing beating tremor. This is a very a classical sign of Wilson disease. So any young patient comes with hepatitis, who's not an alcoholic, not having an episode of fever, having particularly involuntary movements, you should suspect the Wilson disease. See, this is called wing beating tremors. You are asked to maintain a position just opposing the hands. It's like a bird's wing which is going beating. So similar, this is a classical sign of the Wilson's disease, that is called wing beating tremor. It also, like any involuntary movement, particularly the chorea, ethetosis, hemibalismus, and neck dropping, present in various ways. Even in some cases, they might be having only neurological symptoms. They will not be having any hepatitis manifestation. That is the beauty of the Wilson's disease. So we move on to the other signs we should look for in the icteric phase of stage of hepatitis is, sometimes you may find splenomegaly and cervical adenopathy. It doesn't mean that patient is having a portal hypertension in this stage. Another very common findings we expect in a case of liver disease is spider angioma, that is called spider nevi. So it can occur in acute liver disease also. So need not to be always in a chronic liver disease. So you can see here the central dilated peripheral arterioles with the radiating peripheral arterioles, particularly in the SVC territory, shoulder, upper shoulder, and arm and chest. It will be very commonly seen. The reason why it is not very seen in this area is not clear, but it's highly seen in SVC territory. So spider angioma is and Palmer erythema can occur in acute liver disease, particularly when the patient is having cirrhosis. Can seen in a normal individual, particularly during the pregnancy. You can see normally the spider nevi, and it is a superficial tortuous arterioles, and unlike simple telangiectasis, you have to differentiate this from the telangiectasis. You see the assistant is compressing, you see the flow of direction from the center to periphery. You can see this is typical of a spider nevi in a patient. You can see very well the central dilated arterioles associated with peripheral arterial dilatation. So you can have the SVC territory. It's also very commonly seen in the SVC territory. So in Indian patients, very difficult to appreciate this. This is actually picked up in one of our patients in ICU, which is very classically showing the spider nevi. So you should look for spider nevi. It doesn't mean that should be a chronic liver disease. As Madam told the previous speaker, that they not only liver signs will be that there will be an extrahepatic manifestation. Particularly hepatitis C usually present as a extrahepatic manifestation. They might be associated with lymphoma. That's why I told you splenomegaly, lymphadenopathy you should look for in general examination. In CNS, there will be depression, fatigue, and neurocognitive impairment will be there. Sometimes you can see associated with Sika syndrome where all the glands doesn't secrete, you have a dry eyes, dry mouth, everything will be there. There will be evidence of hypothyroidism, and the hepatitis C is related to the metabolic syndromes. There are various reasons for told that is lead to increased risk of major adverse cardiac events. So they'll be having type 2 diabetes, insulin resistance, chronic kidney disease, porphyria cutanea, lichen planus, necrolytic acral erythema. It can present as autoimmune hemolytic anemia, at time thrombocytopenia, all those things, they might present with antibody. This is called APLA, antiphospholipid antibody, anticardiolipin antibody. They are very risk factor for hypercoagulable states. So whenever you come across a hypercoagulable state, or glomerulonephritis, or any arthritis, any lymphomas, it is always to evaluate the CV. The stage of recovery where your constitutional symptoms, all those fever, arthralgia, myalgia will be disappearing. There will be hepatomegaly, will be subsiding. Sometimes it may be persisting. The abnormal liver first tests are still evident. The post-ITRIT phase, the duration usually ranges from 2 to 12 weeks, where hepatitis B have maybe a prolonged stage. So in the stage of recovery, all hepatitis usually completely, clinically and biochemically recovers within 6 months at least. So the hepatitis A and E particularly completely recover from 1 to 2 months. And B and C usually takes little time from the onset of jaundice, that is 3 to 4 months. So almost all hepatitis will spontaneously recover. So how this acute viral hepatitis leads further? It becomes rarely severe. The fatigue will persist for more than a week. Almost acute symptoms takes time to resolve, about 4 to 8 weeks. So when there is hepatitis D, along with the hepatitis B, the progression will be increased, and the disease severity from acute to chronic can happen, or any chronic hepatitis B, if D occurs, it leads to acute exacerbations. So B and D is a very dangerous combination, which leads to reactivation of the previous chronic hepatitis, death, or exacerbation in a chronic liver disease. So the one of the thing we have to really afraid of is fulminant hepatic failure. Sorry for the interruption. So the one dreaded complication of acute viral hepatitis is fulminant or acute liver failure. That should be really afraid. So appreciation of acute liver failure is very, very important. The etiology, particularly any patient comes with acute liver failure, the cause could be a paracetamol poisons, any drug which produces, or ischemic hepatitis due to various sepsis due to septic shock, autoimmune disease, Wilson's disease. This all leads to acute liver failure. Okay. How to appreciate acute liver failure or fulminant acute hepatitis? This is the criteria. Actually, the onset of disease, it should be answered less than 8 weeks of 8 weeks manifestation, and should not extend more than 26 weeks. There should not be any prior evidence of liver disease, because it should be a fresh liver disease, and it will present with a hepatic encephalopathy, and the INR should be more than 1.5. So it is all these are criteria to say that this is an acute liver failure. Why should we bother about acute liver disease? The mortality is more than 80%, where we could not save the patient. So it produces encephalopathy to deep coma, and when you suspect in any liver disease with altered sensorium, particularly in deep coma, where the rapidly shrinking liver sizes, increasing bilirubin level, more prolongation of PT, and raised enzymes, along with confusion, disorientation, somnolence, which leads to acute liver failure. These are the symptoms. The complication will be cerebral edema, the brainstem compressions, the sepsis, GA bleed, respiratory failure. So it produces a multi-organ function state, dysfunction state. So you see the mortality is more than 80%. Okay. So ultimately any patients undergo going into a state of acute liver failure, the liver transplantation is the only treatment. Otherwise, the patient will have a 80% mortality. The one good news is in acute hepatitis is hepatitis A, B is very, very low case fatality rate, only 0.1%. Even hepatitis C, the acute liver failure will not occur. It's very, very rare, even though it is anictic. The only concern is here hepatitis C, where pregnancy it produces 10 to 20% of acute liver failure, where the mother usually die because of the acute liver failure. And when there is an injection drug use, the mortality is 5 to 10% is P plus T. So when there is a super infection with the hepatitis B and D, definitely the acute liver failure chance is very, very high. Okay. So what happens if the acute hepatitis? So mostly it is resolved. 90% of the acute hepatitis will resolve and spontaneously recover. Only very few will go for the relapse cholestatic in autoimmune hepatitis. Relapse, that means the 6 months the patient would have had a subsidence of the illness. Then they develop biochemical changes, which may last even up to 12 months. So this is a relapsing hepatitis. I told you the cholestatic jaundice, which is to be appreciated by the clay colored stools, that will be there. That will be the complication of acute hepatitis. Or the acute hepatitis may turn out to be autoimmune hepatitis. But majority of the acute hepatitis will recover spontaneously. So hepatitis E is almost similar to hepatitis A, where it produces acute liver failure. The only concern is in hepatitis E is that the pregnancy is it produces fulminant hepatitis in pregnancy. Definitely, it needs a concern where you have to treat the patients. Either you have to terminate the pregnancy many of the times and to save the mother and the baby. So what happens? This acute hepatitis B, the results come mostly in 90%. Very rarely they go for fulminant hepatitis, that is acute liver failure. When you call this acute hepatitis into chronic hepatitis, if the marker is more than 6 months and the illness is more than 6 months. So when it turns out to be in more than 6 months, they resolve 50% of the results again. They remain as a carrier state. They either produce a mild, moderate, this is the older term. Chronic persistent is mild, chronic active is severe. So these leads to these stages. So these will lead to cirrhosis and hepatocellular carcinoma, and sometimes having with the extrahepatitis. So most of the time they'll be resolved. What happened to hepatitis C here? The spontaneous resolution is very, very low in case of hepatitis C. The majority of them are move on to the chronic state, that is chronic hepatitis. Hepatitis C is danger in order to consider developing into chronic state. So they will develop a cirrhosis to 10 to 20%. Either they 50% develop decompensated cirrhosis. Some of them turned out to be hepatocellular carcinoma. So alcoholic liver disease generally initially it produces fatty liver, then it produces hepatitis and fibrosis, then ultimately leads to cirrhosis and its complication. This is the course where fatty liver as an intermediate stage occur in the as an initial stage in the alcoholic liver disease. Of course, there are very few clinical signs exclusive to the alcoholism. That is, you can see a parotid gland enlargement in this patient, and you can see a palmar erythema and the deep uterine contracture. So you see any signs of chronic alcoholism in a liver disease, these three you can mention. That is enlarged parotid gland, palmar erythema, and the deep uterine contracture. And where the alcoholic hepatitis can also diagnosed by the liver parameters will be told in the subsequent. So the another entity in the hepatitis is the NASH, which is mainly previously it is told that this cryptogenic cirrhosis, where we are not able to find out any cause for the hepatitis, where most of the cryptogenic cirrhosis is turned out to be a NASH induced cirrhosis. So when you suspect a NASH, whenever a patient with obese presents with feature of metabolic syndrome or diabetes with the feature of insulin resistance, you should think of a NASH-induced hepatitis. So patient will have a obese. The men it will be apple-shaped, and female it should be a pear-shaped obesity. And you can see the marker of insulin resistance. What is this? Is called acanthosis nigricans, where you can commonly seen in the neck and the axilla. This is one of the feature of insulin resistance. If you are obese, you are having this marker, that you are having a more chance of metabolic syndrome and major cardiac adverse events. we will be waiting for. So there will be associated PCOD, and there will be a obstructive sleep apnea. So all these features is suggestive of if the person is non-alcoholic, no evidence of infection, you should think of NASH hepatitis. Another entity is called severe preeclampsia, which leads to HELP syndrome. Just mainly common in the pregnancy, which do the devastating illness in case of pregnancy. It's called HELP syndrome. Why it is called? Hemolysis, elevated liver enzymes, low platelet count. So this is the procedure. They produce a lot of complications in pregnancy, especially coagulopathies, abruptio placenta, seizure, acute renal failure, maternal hepatic damage, retinal detachment also occur. So it's in the mothers. In fetal, it produces stillbirth, IUGR, and the preterm delivery. This is the most dreaded complication of HELP syndrome. So this is about the acute hepatitis. We'll move on to the chronic hepatitis. When it is mainly hepatitis B, and then there is a lack of complete resolution of clinical symptoms. It leads to chronic hepatitis. So whenever you see bridging or interlobular or multilobular hepatic necrosis in liver biopsy, and if the liver parameter is more than 6 to 12 months persistently present, and when the HBE antigen is more than 3 months and HBsAg is more than 6 months, you have to think of chronic hepatitis. So any acute hepatitis features which is persists for more than 6 months, you have to think of chronic hepatitis. Particularly in the marker HBeAg present more than 3 months, and the HBsAg is more than 6 months. So what the difference here? Here there will not be any tender hepatomegaly. Of course, there will be a hepatomegaly, and there will be ascites if it is an advanced disease. Generally, here a non-tender hepatomegaly with icterus, that is the most common present agent, along with the constitutional symptoms. Particularly, there will be icterus, and ascites may be because of the cirrhosis, not as a decompensated sign. There are different entities or autoimmune hepatitis where you don't find any cause, and particularly a female, 10 to 30 years of female or late middle age comes with the features of hepatitis. And if particularly if they have evidence of SLE or any autoimmune disease with ANA positive, anti-DSNA positive, you can go for anti-LKM1 antibody, which is a marker of autoimmune hepatitis. So you can think of autoimmune. So any young female, the non-alcoholic, came with the 10 to 30 years. One thing you suspect is autoimmune hepatitis. Another one you should always think of Budd-Chiari syndrome. Okay. They may be having other features of usual chronic hepatitis. So there will be a marker of other autoimmune diseases like autoimmune thyroiditis, Graves' disease, hemolytic anemias, ulcerative colitis, rheumatoid arthritis. So any patient with autoimmune disease present with the liver disease, liver manifestation, think of autoimmune hepatitis. When you say that acute hepatitis, chronic hepatitis, then ultimately it leads to compensated cirrhosis, and which leads to decompensated cirrhosis. There are many questions will be asked in the exam regarding decompensated. What is decompensation? That means it undergoes any complication. The icterus occurs because of the entire liver going for degeneration. See, what is compensated cirrhosis? There is a regeneration along with the degeneration. So it will not produce any complication because the liver function is intact. There is decompensated where you can see icterus due to degeneration of the entire hepatocytes, evidence of portal hypertension, particularly ascites, hepatic encephalopathy, varices, and hepatorenal syndrome. It is there associated with cirrhosis, it is decompensated cirrhosis. This is a newer classification to differentiate the compensated and decompensated. In stage 1, where you will not have neither varices nor ascites. That is only 1%. In stage 2 is you have a varices but no ascites. It is only 3% mortality. Stage 3 is where you can have ascites as well as varices. In stage 4 is mainly in the patient with ascites undergoing upper GI bleed. Mortality is very, very high, that is 57%. So the decompensated cirrhosis mainly presence of ascites, presence of varices, and presence of upper GI bleed. So complication occurs, it is decompensated cirrhosis. Only the signs of chronic liver disease is there. No signs of such complication. It's called compensated cirrhosis. So these are the chronic liver disease, even present in compensated liver disease. From head to foot, you can say the alopecia, you can see a gynecomastia, you have parotid gland enlargement, then you can have a spider nevi, then you can have palmar erythema, you can have a muscle atrophy, and this is due to mainly hypoalbuminemia. Asterix is the main sign of hepatic encephalopathy. T-Botrytis contractures, main sign of alcoholic hepatitis, and pedal edema due to hypoalbuminemia. So this is a stigmata of a chronic liver disease. In decompensated liver disease, many patients present with a CNS manifestation. They will be confused, there will be tremor, there will be hypersomnolence, and the altered sleep pattern is one of the earliest symptoms of hepatic encephalopathy. There will be muscle wasting. So there will be that means the circadian rhythm will be changing. That means patient will be sleeping in the daytime and night they don't get sleep. So that is the earliest symptom of hepatic encephalopathy. And you see a leukonychia, which is a sign of chronic. That means the liver function, synthesis of albumin is lost. So they looks very white. That's called milk spot. The leukonychia, and typical of this halitosis, that is sweet, musty to rotten egg breath odor. Okay, that is a very classical sign of hepatic encephalopathy. And there will be easy bruising and bleeding from the upper GI, and there will be decreased urine output due to hepatorenal syndrome. So there should be a features of jaundice, ascites, pedal edema, hepatic encephalopathy from confusion to coma, upper GI bleed, particularly hematemesis and melena, to say it is a decompensated cirrhosis. Where you can see here the signs of hyperproteinemias. This is typically called leukonychia. Whenever there is a leukonychia, it's evidence of decompensated liver disease. You can see your white nails, and you can see the ascites, and you can see a pitting pedal edema. It's all signs of hyperproteinemias. When the albumin is not synthesized in the liver, you can see that scratch mark also, even though it is not a sign. Then the patient will ultimately go for the hepatic encephalopathy due to increased toxin reaches the brain because of the increased ammonia production. You can see a hepatic encephalopathy. So you see here the elbow and the whole upper limb should be stretched. None of them should be flexed. The hand should be dorsiflexed. That is the position. You can see a flapping trip, a rhythmical downward oscillations.
What actually is happening is we are instructing the patient to keep the hand like this, as a horizon. But again, it is falling. So because of our instruction, the patient wants to keep the hand at the original position, but he is not able to control the falls. You can see. The causes of flapping tremors are hypoxic encephalopathy, uremic encephalopathy, and hepatic encephalopathy. This patient is having uremic encephalopathy. And the other causes are electrolyte imbalances like hypoglycemia, hypomagnesemia, and hypocalcemia, and hypokalemia. And certain drugs can cause flapping tremors like phenytoin, carbamazepine. Alcohol can cause flapping tremors, and Wilson's disease also can cause flapping tremors.
So this is the typical of flapping tremor, where you confirm there is a hepatic encephalopathy, where you can decide that there is a decompensated liver disease. So as you see any liver disease, you should look for signs of liver cell failure. There will be alopecia, okay, there will be stress, there will be engorged neck pains, there will be spider nevi, there will be gynecomastia, there will be clubbing, palmar erythema, deep drain contracture, pedal edema, and of course there is a ascites. And genital, don't forget to examine for the testicular atrophy. So any patient, anybody asks what is the thin hair, silky hair, wasting of temporalis muscle, icterus, pallor, cyanosis, fetal hepatitis, parotitis, congested neck veins, spider nubi, gynecomastia, palmar erythema, flapping tremor, clubbing, water amel pulse due to hyperdynamic state of cirrhosis, ascites, umbilical hernia, edema in the lower limb, femininity of hair, and testicular atrophy. So if this liver cell failure happened, that is the called end-stage liver disease. So this is the decompensated cirrhosis with the liver cell failure is classified as end-stage liver disease, where none of the treatment will work out. Only the liver transplantation is the ultimate choice. So one thing is that one more complication of this hepatitis is hepatocellular carcinoma. Mainly the patient with hepatitis B and hepatitis C will go for hepatocellular carcinoma. The symptoms are mainly unintentional extreme weight loss, loss of appetite in an existing cirrhotic patient, feeling full even after a small amount of food. There's a delirium, confusion, hoarse, jerking muscle movements. So particularly in examination, these very commonly asked questions where when you have a palpable liver, if you find it's very hard, if it is nodular differential diagnosis is macronodular cirrhosis. And also it's a differential diagnosis for hepatocellular carcinoma. Liver feels gritty, and there will be a bruit in auscultations and the pulsatile liver in the palpation. So if you have a hepatomegaly in cirrhosis, which is particularly hard in nature, nodular in nature, gritty sensation, there is a pulsatile liver by palpation, bruit by auscultation. There you have to suspect hepatocellular carcinoma. So this hepatocellular carcinoma is also called considered as an end-stage liver disease, where the liver transplantation is the ultimate treatment. So you should not allow patients from hepatitis to go for chronic as well as the. Now there are various treatments are available for hepatitis B and hepatitis C. The mini antiviral, anti-interferons, liver transplantation becoming one of the common surgery, so that patient can be treated. So thank you for the very patient listening for the past 1 hour of my lecture, and I'll be happy if you have any questions because I have to rush for another presentation. If any questions, you can just clarify. I hope I cleared all your doubts. So my summary is that acute hepatitis, which has 3 stages: the stage of constitutional symptoms, stage of hepatitis, the icterus is the predominant, then got resolved on its own. Then there will be a, if it is, you should look for evidence of alcoholic hepatitis, evidence of autoimmune hepatitis, evidence of NASH, apart from the viral hepatitis. Then if the person's persistent symptoms more than 6 months, then go for chronic liver disease, which ultimately leads to decompensation, which leads to ascites, hepatic encephalopathy, portal hypertension, and hepatorenal syndrome. And this leads to end-stage liver cell failure and hepatocellular carcinoma, which is where the liver transplantation is the ultimate choice. Thank you very much. And also I am very much thankful to the microbiology team of AVMC, Professor Lata, and once again Dr. Anishila, Dr. Magendra. I think a wonderful hospitality was maintained throughout these 2 weeks. Every step of the program they were me communicating, and I'm very much delighted with their approach towards me, which made me to present in front of you. Thank you very much, madam.
Thank you, sir. Thank you for your nice words, sir. Actually, we really thank you. That presentation was awesome and it was very informative, sir. And we would also like to have similar type of meeting in different topics with you, sir. Thank you so much, sir.
Thank you, sir.
And in information to the participants, we'll have a short tea break for 5 minutes and then we'll come join.
Sir,
Yes,
if
sir.
you excuse me, I have to go for another presentation. Shall I take
Yes,
leave,
yes,
sir?
sir. Yes, sir. Yes, sir. Thank you, sir.
Thank you, sir. Thank you very much. Exact-ஆ முடிச்சிருக்கணும்.
Welcome back, everyone. I'm really happy to introduce Dr. J. Aravindhan, MD Pediatrics, who is a Senior Assistant Professor of Pediatrics, working in Government Thanjavur Medical College. And he completed his MD Physician in Moscow Medical Academy, Moscow, Russia, and MD Pediatrics in year 2014 in Arpadevudi Medical College. And I'm really happy to introduce him. Since I know him personally, like he's my senior, who is a mentor also for me in doing many other extracurricular activities. And really welcome you, sir, to speak on viral hepatitis in pediatrics and immunization. Sir, dice is yours.
Thank you, Mahendran, for the kind introduction about me. And as he said, actually, AVMC is not new to me, and I am a product of AVMC, and I'll always say in any nook and corner of the world that I have finished my MD Pediatrics from AVMC, and I have no regrets in that. Even all my seniors and my co-batchmates, whoever has already passed out from AVMC are right now doing like a professional service in so many like well-versed institutions all around the world actually. And I thank the dean, the faculties, and the Department of Microbiology in choosing me as a speaker in this great CME, which is a national CME going on AVMC right now. Thank everyone for this opportunity, and without any delay, I would like to go on to the presentation. And I also like to emphasize the fact that both the previous presenters have done a really good job, like making my presentation a little easier, because all the clinical part and the microbiological part of the viruses and hepatitis are also covered earlier. And thank you. Today, I would like to enlighten a fact that viral hepatitis in pediatrics is also a big nightmare. Even though we are in a COVID-19 situation, still viral hepatitis poses a big threat to our population. Next. So as we know, hepatitis can be a result of infectious and both non-infectious causes like viral, bacterial, fungal, and parasitic agents, and non-infectious causes like drug, autoimmune disorders, metabolic diseases, and ischemic injuries. So as we all know, viral hepatitis is mostly commonly caused by hepatitis A in India, followed by hepatitis B and C. Other hepatotype virus are D and E. Mostly other less common cause of viral hepatitis can also be there with the cytomegaloviruses, Epstein-Barr viruses, and in neonatal herpes simplex virus. And most commonly, we'll have a and B looked upon in serious matter. So why we have the CME? First of all, I don't know why everyone know this fact that World Hepatitis Day is commemorated on July 28 every year. So actually, we have crossed July 28. Our CME was planned on July last week, I guess so. Every year that we are actually commemorating the Hepatitis Day to enhance our understanding about hepatitis and to eliminate hepatitis. So why we are actually celebrating this? Because of the 28th July was birthday of Nobel laureate Dr. Boris Bloomberg, who discovered the hepatitis B virus, as well as the diagnostic test and vaccines for hepatitis B. And in order, we are actually celebrating hepatitis Day every year. And the main motto of this year is hepatitis can't wait. That is, we cannot wait still more in understanding about this hepatitis virus and in eradicating this virus. And WHO targets to 2030 to eliminate the disease. I don't know how feasible it is, but we have to be optimistic anyway that WHO is planned to eliminate the hepatitis threat in any population by 2030. As I said earlier, world is still struggling to cope up with COVID pandemic now, but not be a reason are also on the cards, and it impacts our lives globally. And main thing is hepatitis B virus and hepatitis C virus combined are among the top 4 global infectious disease killers alongside tuberculosis, malaria, and HIV. So we should know the quantum, like hepatitis B and C collectively kill more people around the globe. So although the number of people in the world dying from HIV, tuberculosis, malaria have declined since 2008, global deaths from chronic hepatitis B and hepatitis C virus continue to rise still now. So we have to ask question to ourselves. At present, it seems that the World Health Organization have a target of eliminating it by 2030. Whether elimination of this is really feasible, and we have to move forward in a way, it should be done. So as we know, viral hepatitis is mostly because of these viruses in any age group. The transmission is mainly through food and waterborne and bloodborne. So A and E is transmitted eco-orally, that is food and water, and bloodborne are B, C, and D. So the incubation period also varies from each viruses. You can see around A and E there is no difference, much difference, 2 to 6 weeks. Hepatitis C 2 to 6 months. Sorry, B, hepatitis C 2 to 26 weeks. And hepatitis D is unlimited, like months and years. So next thing is mostly in hepatitis A and E, it affects acutely, and there is less chronic cases. In fact, very rare. But in case of B and C, you can see acute cases also, and chronic cases will be more in hepatitis C, as I already mentioned. So first we look into hepatitis A viruses. As I said earlier, fecal oral route. To give you overall idea, still around 60 to 70% of Indian population is defecating in open air. So there is a risk of contamination of and water still happening. Even the drinking water which we consume, average Indian, whatever water we consume has around 0.5 particles of percentage of particles of fecal matters. So you should now know the danger which it poses. So that's why hepatitis A poses a great danger to the developing countries. Hepatitis A continues to be a public health problem in India for so many years. You see the zero prevalence of hepatitis A, almost 75% in children under 5 years, and around 85% of children above 8 years of age have zero prevalence. That is, they are either being infected or already under the infection. Since hepatitis A vaccine is not covered under our government immunization schedule, you see only the hepatitis B is now covered. But hepatitis A is more common than B, but it is not covered in our schedule because of the price issues and some logical difficulties. So that's also a major reason that hepatitis A still poses a great danger to our Indian population. A recent study observed that almost half the total case of acute viral hepatitis in tertiary care hospital in Delhi was due to hepatitis A alone. So you should now know like the quantum of infection which is happening in India with hepatitis A. Among children admitted with acute liver failure in the same hospital, hepatitis A was the cause of around 45%. You see, 45% of children admitted with acute liver failure was associated with hepatitis A infection alone. Next. So there are there is 4 different genotype strains available for HIV. All 4 are 1, 2, 3, and 7. They do not appear to have any biological differences and all belong to single serotype. Most of the human strains are genotype 1, which has been further divided into subgenotypes 1A, 1B, and genotype 3. So like the subgenotype 3A have been reported to be a major HIV genotype in India, which causes infection in India. So epidemiology, if you see, HIV infection occurs worldwide. Approximately around 1.5 million clinical cases of hepatitis A occur worldwide, especially in Southeastern Asian countries, Africa and South American region, where socioeconomic status is little low. The incident rate is strongly related to socioeconomic indicators, especially with the access to safe drinking water and sanitation. So that's why still HIV is endemic in India. We have to if we have to eradicate HIV from India, so we should now know we should have access to safe drinking water, sanitation, and also hepatitis A vaccine should be available in our immunization schedule. Unfortunately, which is not there now. Next. So studies conducted in 2000s across India consistently found that more than 90% of adolescents and adults are immune. Majority of children acquire immunity during their preschool years. That means that they would have been already infected in the preschool age itself. So that early child is getting infected with the hepatitis A virus. So as soon as baby started on weaning, the baby will be exposed to this virus because of the contaminated food and contaminated water from 6 months of age itself. So with improvement in socioeconomic conditions lately in India, like for last 10 years, so many villages and so many population are now having access to clean drinking water and sanitation and toilet facilities. Now the early childhood exposure to the virus is coming down a little. And the peak age of seroprevalence, that is acquiring infection, is now shifting from first decade to second and third decade because of the government measures which improves our access to clean drinking water and sanitation. You can see the spread of HIV within our body with the oral acquisition. It crosses the intestine and then to the bloodstream. It colonizes in the liver, then in the bile, and it will excreted in the stools. Stool again, it will contaminate the water and food. Again, the cycle continues. That is fecal-oral contamination. So HIV infection is usually a self-limited disease. Actually, we don't have to do anything. It will resolve on its own, and mostly it has lifelong immunity. That's why most of the jaundice, when a parent goes to a native treatment, they will give some native medicines, but not because of the native medicine the jaundice is getting cured. The thing is that HIV gets cured by itself. Most of the jaundice in India, that is around 60 to 70% of the jaundice is caused by HIV. So it is a self-limiting diseases. It does not result in chronic infection, as I said earlier. The incubation period averages around 30 days. The prodromal symptoms, as Sir said already, not much difference between adult and pediatric age group. The patient will be fatigue, malaise, they have vomiting, abdominal pain, anorexia, fever, and mainly right upper quadrant pain, which disappears with the onset of jaundice. So all the predominant symptoms will disappear when the jaundice appears. Next, patients with HIV infection usually follows one of the following clinical patterns. It is mostly they will be asymptomatic without jaundice, or symptomatic with jaundice and self-limited after approximately 8 weeks of time. Sometimes the jaundice will be lasting more than 10 weeks or more because of cholestatic effects, or relapsing with 2 or more bouts of acute HIV infection, that is like refractory infections in between, occurs over a 6 to 10 week period. Most rarely, they will go for fulminant hepatic failure. Around, as I said earlier, 40% of the fulminant hepatic failure admitted in hospitals was due to hepatitis A virus. So symptomatically, there will be a great improvement in hepatitis A virus, like their self-limiting illness. Next. As I said earlier, the right upper quadrant tenderness, mild liver enlargement are found on physical examination in 85% of the baby. Splenomegaly and cervical lymphadenopathy are each present in 15%, around 15% of the patients. Less common findings include evanescent rash, arthritis, and rarely leukocytoclastic vasculitis. Sometimes vasculitis and arthritis can also be associated with hepatitis A. Complete clinical recovery is achieved in 60% of affected person within 2 months, and in almost everyone by 6 months, and there won't be any chronic patients in hepatitis A. As I said earlier, some patients will have jaundice like prolonged because of cholestatic hepatitis. Because of cholestatic effect, they will have prolonged jaundice. The clinical course is usually characterized by marked jaundice, pruritus, fever, weight loss, diarrhea, and malaise. You see biochemical and serological abnormalities. It shows earlier like marked increase in serum bilirubin, often more than 10 milligram per deciliter, and alkaline phosphatase also will be increased markedly, and minimal increase in serum aminotransferases, and peak bilirubin level may be reached in 8 weeks or later after the onset of illness. The jaundice and pruritus may last for 12 weeks or more, but are followed by complete recovery. Next is relapsing hepatitis. A relapse in hepatitis A virus can also happen in between around 3 to 20% of patients have relapsing hepatitis. The clinical course is usually predicted by an apparent full clinical recovery with near normal or near normalization of serum aminotransferases. Like lab markers we have to monitor, right? So in that, if serum aminotransferases will be marked normally, but again followed by marked increase in the both the clinical and the serological markers. The prognosis in relapsing form of hepatitis A is excellent, as complete recovery also be there in relapsing hepatitis. The duration will be generally short, although biochemical relapse may last as long as 12 months, that is 1 year. So you can see the events in hepatitis A virus infection, from the onset, you see the first week, the patient develops viremia, and the hepatitis A virus will be in stool from the first week itself. And it will be 5 to 6 weeks. The patient will be excreting hepatitis A virus in the stool. And viremia will be there also till 6 weeks of time. And with serologically, if you see, ALT will be peak by around 4 to 5 weeks, and it will start to decline. And the antibodies, IgM will be peaked by 5 weeks, and it will gradually decline. And IgG will be appearing by 2 to 3 weeks, and it will be peaked by around 10 to 12 weeks of time. Next. So as I said earlier, hepatitis A post a threat called fulminant hepatic acute liver failure occurs less than 1% of the cases. Very rare, but if you take acute liver failure patients alone, in that 40% of the patients will be associated with hepatitis A. So fulminant hepatic failure is a syndrome characterized by grossly impaired liver function in an acute, that is in an acute setting, that is as early as 8 weeks, like defined as onset of hepatic encephalopathy and liver failure within 8 weeks of development of jaundice. To grade the ALF according to O'Grady and Pulick's classification, ALF can be graded into hyperacute, acute, and subacute. So the how we are grading is we have to see the interval between the jaundice and the encephalopathy. So in case of hyperacute, you see the onset will be within 1 week of time, and acute it will be between 8 to 28 days, and in subacute it will be between anywhere between 28 days to 12 weeks, that is 4 weeks to 12 weeks. The hallmark of acute liver failure is these 3 triads. That is altered mental status, that is altered sensorium, you can see in hepatic encephalopathy. Next, accompanied by jaundice with marked elevation of serum aminotransferase. first time. APTT and PT will be increased. Next, we are staging the hepatic encephalopathy into 4 stages. You see the first stage, hepatic encephalopathy can present a slight alteration in mental status. It is only light altered sensorium will be there in the patient. Otherwise, hemodynamically, the patient will be stable. In stage 2, the altered sensorium will be worse, going in for confusion, drowsiness, and asterixis. And in stage 3, the patient will go in for stupor and agitation. And in stage 4, the patient will very well go to coma and the patient will be unresponsive. And the patient will be in celebrative posture. Next. Management of acute liver failure. So, like as I said earlier, HAV resolves on its own. Again, hepatitis B also actually we cannot do anything to the virus, but still, when so many things are going wrong in our body, we have to very well manage vigorously the patients with hepatitis A. When the patient goes for acute liver failure and they need ICU care setting management, we cannot manage them as OP or in MOD. So like multi-dimensional management is needed. So in view of nutrition, treatment of hypoglycemia, hydration, electrolyte imbalance, coagulopathy, prevention of the infection, like some infection itself, if it goes still further, the patient will go in to stupor or coma in 4th stage, right? So we have to manage the infection also. So we have to manage in a ICU setting. So serial monitoring of lab investigations, including ABG, lactate values, prothrombin time, liver by enzymes, factor V levels need to be done every 6 to 8 hours once in order to save the child. These are the things should be monitored regularly in a periodical time, that is 6 to 8 hours. So anything is varied, you have to treat accordingly. Close monitoring is a key in management of acute liver failure patients in ICU settings. Next, we have to closely monitor hyperammonemia because it is a critical factor in the development of cerebral edema and herniation. So we have to have a close watch in ammonium levels also. So atrial ammonia levels, when it goes over 200 microgram per deciliter, they have strong correlation with the cerebral herniation and death. So we have to monitor ammonia levels also. So cerebral edema, how we are managing, like as we do in any other cerebral edema management, close monitoring of pupils and papillary edema, mannitol, hyperventilation, use of propofol for sedation, and treatment is aimed at maintaining the central perfusion pressure at around more than 50 milligram per mercury. The difference between the mean arterial pressure and the intracranial pressure should be around 50, more than 50 milligram per mercury. And the IC and the intracranial pressure should be around at less than 20 millimeter per mercury. Next. Bleeding manifestation, as I said earlier, coagulopathy poses a big threat in any liver diseases, especially in acute liver failure and viral hepatitis. The PTINR should be always monitored regularly in 6 to 8 hours time. One of the most sensitive liver function tests available in setting of ALF. The prognosis and the course of the disease can be learned by the variation in our prothrombin time. However, the tendency to spontaneously bleed is low despite marked elevation of PTINR. So we shouldn't be threatened by increased PTINR levels that the patient will go for bleeding immediately. Not so. If it's not so, actually, most of the time bleeding won't be associated with high levels of PTINR. So unless if you see active bleeding, we have to transfuse FFP. Otherwise, it's not needed because invasive procedures should not be done. Any invasive procedures and transmission should not be done prophylactically. Next. So as sir already told, liver transplantation, any acute liver failure, permanent liver failure, or in sometimes in chronic liver failure patients, we will go in for liver transplant as a last resort of treatment. Same way, sometimes liver transplantation will be warranted in these cases also. There are two types of liver transplant: OLT, that is orthotopic liver transplantation, and LDLT, that is living related liver transplantation. With OLT in acute liver failure, overall survival rates are further improved from 20% to 60%. In case of LDLT, reduce waiting time and to provide better timing compared to deceased donor liver transplantation, that is DDLT. Living related liver transplantation is now preferred over DDLT. The 1 year survival rate following LDLT is approximately around 75%. And also there is some changes in liver transplantation technique also nowadays. In auxiliary liver transplant, the recipient's liver is left in place and use a partial left or right lobe from the donor, which acts as a temporary support for the recipient's injured liver. Immunosuppression may be withdrawn following native liver recovery, allowing the graft to atrophy naturally, or it is surgically removed after some time. Next. Note, liver transplantation has markedly changed the prognosis of HIV-induced or any hepatitis-induced acute liver failure. However, HIV-related fulminant hepatic failure resolves spontaneously more frequently. Mostly it won't go in till liver transplantation. Next. So outcomes of infection with hepatitis A virus, if you see children who has better outcome, around 80 to 95% compared with adults, and they will have around 5 to 20% of icteric disease. As adults will have more icteric disease, that is around 75% to 90%. Both will have excellent recovery rate, and both doesn't have any chronic diseases in HIV. And mortality around 0.1% in children and around 0.3 to 2% in adults. Next. Regarding vaccinations, hepatitis A vaccine, we have two vaccines as we all know, live attenuated and inactivated. Mostly we prefer inactivated with 2 doses, 6 months to 18 months apart. And live will be given as a single dose starting at 12 months of age. So minimum the vaccinations should start after 1 year of age, that is 12 months of age. If they are not vaccinated at all, catch-up vaccination, either of the two vaccine can be used in catch-up schedule beyond 2 years of age. Administer 2 doses of inactivated vaccine at least 6 months apart to unvaccinated person if they are not vaccinated at all. Only single dose if it is live. Next. Can hepatitis A vaccine be given on an immunocompromised child? Yes, almost to all immunocompromised child above age of 1, we can give a HIV vaccine. Even with the person living with HIV infection, irrespective, regardless of CD4 count, we can give hepatitis A vaccine. Next. Now we will see hepatitis B in children. The overall prevalence of HB surface antigen is reported to be around 3.5%. However, it varies depending upon the geographic area. The global prevalence is divided into 3 zones depending upon the carrier rate. So high zone, intermediate, and according to the risk. So high zone is around 85%, around 45% of global population lives in high zone. High endemicity, lifetime risk of infection is around more than 60%. That's how hepatitis B posing a threat to our global population. Early childhood infection is very common in these high zone areas. Mother to child transmission is predominant mode of transmission. Nowadays, apart from vertical transmission, horizontal transmission is also getting more transmissions nowadays. I'll come to that later. The high zone areas are South Asian countries, African countries, China, and we are in high zone area. Next. Intermediate zone, 43% of global population, that is around 7% risk. Intermediate endemicity, lifetime risk of infection is around 20 to 60%. Infections occur in all age groups. Horizontal transmissions, that is child to child, is more common in intermediate. Intermediate zone lies in Middle East, Central and South American, parts of Eastern Europe, and India again comes under intermediate zone. Next, low zone. Around 12% of global population, low endemicity. Lifetime risk of infection is around less than 20% only. And most developed countries like US, Australia, Western Europe are in this zone. Next. You see the transmission of hepatitis B, we all know it's a bloodborne, transmitted from infected patients to those who are not immune. The infective dose of viral hepatitis B virus is extremely minute, that is around just 0.0001 ml. That is around even 1 ml of blood contains 1 trillion viral particles. So less dose of infective blood is needed. That is even 0.0001 ml is needed to have a transmission in a healthy individual. That's why even a needle prick is posing a great danger for hepatitis B virus. That's why all the healthcare workers are at risk of developing hepatitis B viral infection. It has been shown that 10 or less viral particles is very sufficient to initiate a readily detectable HPV infection in a healthy individual. If you see the body fluids from blood, CSF, urine, breast milk, tears, blood is the highly which has high viral load, and least viral load will be tears. Even tears can spread hepatitis B virus. So if you see from blood to tears, tears is the last body fluids in transmission rates. Next. So as I said earlier, there are two transmissions, vertical and horizontal. Vertical from mother to the baby. Transmission from the mother to the baby may occur in utero, during delivery, or after birth. Most infections occur during delivery alone. The risk is as high as 90% if the mother is positive for both surface antigen and envelope antigen, and as high as a high HBV viral load. So HPV vertical transmission from mother to baby, it's a predominant transmission before. Now horizontal transmission is also catching up along with the vertical transmission. You see, HPV vaccine and hepatitis B immunoglobulin should be immediately given after the birth of a HPSAG positive mother. You shouldn't delay, because 24 hours itself is very much enough for the baby to acquire the infection. And there is no proof that hepatitis B transmission can be prevented by C-section. Thus, cesarean section should not be routinely recommended for HPSAG carrier mothers in order to reduce hepatitis B transmission. We can go for normal delivery also. Next. Horizontal transmission, that is child to child. This is very common in children in developing countries. It is because of close physical contacts, like the population density poses a big threat in horizontal transmissions. Children with impetigo, with bleeding, edemas, infected scabies, cuts, or wounds, if they closely move with each other, there is a risk of horizontal transmission. So in India nowadays, even horizontal transmissions are getting higher. Can also spread to the mother from the child also, not only from mother to child. Mother can also be infected with the child also. In India, around 1 million children, around out of 26 million born every year, are at risk of developing chronic hepatitis B infection during their lifetime. You see the magnitude of the problem which we possess with this virus. like around 1 million children out of 26 million born every year are having a risk of developing chronic hepatitis B infection. Next. If you see clinical presentation of hepatitis B, the incubation period varies around 50 to 150 days. After which the patient may develop prodrome symptoms of nausea, vomiting, fever, anorexia, arthralgia, and malaise. You can have asymptomatic and symptomatic hepatitis also. In symptomatic, you can see anictic hepatitis, icteric hepatitis, cholestatic hepatitis, fulminant hepatitis, chronic hepatitis, cirrhosis, and hepatocellular carcinoma. So if you see chronic carriers can very well go for chronic hepatitis, cirrhosis, and carcinoma. That's why hepatitis B should be treated and it should be screened at every levels. So you can see anictic hepatitis can also be there in hepatitis B, and inapparent hepatitis can also be there in hepatitis B. There will be no symptoms. There will be asymptomatic. Only accidentally you can diagnose by finding elevated transaminases and liver enzymes and bilirubins, etc. Next. Icteric hepatitis, the prodromal symptoms of hepatitis B are usually milder compared to hepatitis A. The duration of jaundice varies from 4 to 6 weeks. Usually clinical and biochemical recovery are also completed within 6 months of onset. Some patients may develop a severe intrahepatic cholestasis, but its incidence is less than that of hepatitis A virus. Again, fulminant hepatitis can be there in hepatitis B also, as in hepatitis A. It's about 1% compared with 0.1% in hepatitis A. The risk of fulminant hepatitis is high in patients, so we have to have a regular monitoring of liver enzymes and bilirubin levels in hepatitis B virus. Next. Chronic hepatitis is characterized by the presence of surface antigen for more than 6 months with or without concurrent envelope antigen. The age at the time of infection is most important factor in prognostic criteria. That is progression of chronicity reduces by the lesser the age when the child gets the infection, lesser the chances of chronicity. So about 90% of neonates born to mother who are positive for both surface and envelope antigen develop chronic diseases. Only 30% infected childhood and 5 to 10% infected adulthood develop chronic hepatitis. So the younger the age, there will be chronic hepatitis. So that's why hepatitis B vaccination is very important. We have to prevent the child by getting hepatitis B infection as early as possible. So extra hepatic manifestations can also be there in hepatitis B. It won't be there in hepatitis A. Sometimes arthritis can be there, as I said earlier, but here there will be more extra hepatic manifestations in hepatitis B, like serum sickness, like syndrome, which has rashes, polyarthralgia, and it can also have an effect on glomerulus, like glomerulonephritis. There will be minimal change diseases. There will be IgA nephropathy. There will be focal proliferative glomerulonephritis, and you can also see papular acrodermatitis, mostly strongly associated with hepatitis B. Antigens will be more in our blood levels. That is hepatitis B antigenemia in young children will be associated with papular acrodermatitis, manifest as symmetrical erythematous maculopapular rashes and non-puritic eruptions. And we can also have polymyalgia, polyarthritis also in case of hepatitis B. Next. So clinical outcome of hepatitis B infection. See, 84% there will be a good resolution. Around 1% they will land up in fulminant hepatitis, and 15% will have surface antigen more than 6 months of age, posing a threat of chronic hepatitis. So from that also there will be having a 50% resolution again. So there will be chronic persistent hepatitis and chronic active hepatitis. So they can very well land up in cirrhosis, carcinoma, or chronic liver diseases. Next. So if you see the course, serology course, from 4 weeks, the 3 to 4 weeks surface antigen will be developed, and it will be peaked by around 12 weeks of time. We seen till 24 weeks of time. IgM will be peaked by around 18 weeks of time, and it will gradually decrease, and by 32 weeks it will be decreased. And antibodies for hepatitis B will be found from 32. Anti-HBs, that is, will be found from 32 weeks. And throughout the course of the illness, from 8 weeks of time, you can see total anti-HBC will be found in the serological markers. Next. Progression to chronic hepatitis B virus infection. If you see the progression in this course, as we said earlier, around 6 weeks, HBsAg will be peaked and it will be maintained in our bloodstream. And total anti-HBC will be also be maintained from 12 to 14 weeks of time. IgM will be decreased and it will be at the lowest by around 30 to 35 weeks of time. Next. And you see in vaccinated person, you will always see anti-HBs, and we won't see anti-HBs in any other serological markers, only in the vaccination. In natural infection, we will see in anti-HBC, anti-HBE, and anti-HBs. Next. Treatment, as I said earlier, mainly supportive and directed to ensuring adequate nutrition and hydration. Patients should be regularly and carefully monitored for development of fulminant hepatitis. We should not entertain the patient and patient attenders to go for native medicines, as it will in turn be a hepatotoxic agent. So indication of hospitalization include deep icterus, that is when icterus is more, and persistent vomiting, coagulopathy, and encephalopathy. And we can also have antiviral therapy in acute hepatitis B in case of fulminant hepatic failure in ICU management. We can give antiviral therapy to patients with hepatitis B to decrease the viral load in our body. Drugs like entecavir, tenofovir, lamivudine, adifovir can be used as monotherapy. And the treatment may be discontinued when it is confirmed that the child has cleared HBsAg. Next. Hepatitis B vaccine is like only one thing which we have in our hand to eliminate hepatitis from 2030 is hepatitis B vaccination. So we have to ensure that 100% of the population gets hepatitis B virus. That should be our target actually. Unless until if we are not vaccinating all with hepatitis B vaccine, we cannot eliminate or we cannot discontinue this threat from our human population. And it is a adjuvant vaccine with aluminum salts, and it should be, as we all know, it should be stored at around 2 degrees Celsius. It should not be frozen. If frozen, we have to discard it. It uses recombinant DNA technology, that is hepatitis B surface antigen will be expressed in an yeast cell. It is very effective, induces protective antibody levels in more than 90% of the infants. Production lasts at least 20 years and mostly lifelong. Thus, WHO does not recommend booster vaccination for persons who have already finished 3 doses of vaccination. After 3 doses of vaccination, we will all have a lifelong immunity, so booster doses are not needed if you finish 3 doses of vaccination. So As I said earlier, it is a recombinant vaccine. You can see the gene of HBsAg is now embedded in plasmid of yeast. It acts as a carrier. It is recombinant, and the recombinant yeast will develop HBs antigen, HBsAg, and it will be released. Thus, we will have lifelong immunity. How SP vaccine induces synthesis of antibodies? You can see the vaccine is recognized and internalized by antigen-presenting dendritic cells at the site of injection. After processing the HBsAg, the dendritic cells migrates to the regional lymph nodes. There they interact with selected T and B lymphocytes at immunological synapses. There, HBsAg specific B lymphocytes and plasma cells are produced. These cells secrete anti-HBs that are detected in the serum, and that will be protecting us from the hepatitis B infection. So what is the vaccination schedule? When we deal with a HBsAg positive mother, all women should be tested for HBsAg at first prenatal visit itself. The baby should be given vaccine as well as immunoglobulin within 12 hours, at least within 24 hours of birth. The birth dose should be given as soon as possible, immediately after the birth, and immunoglobulin 0.5 ml IM to be provided immediately, thus protecting the neonate from getting the infection from the mother. In case if it is a negative mother or normal mother, we have to follow the immunization schedule, that is 0-1-6, that is at birth. Next, second dose by 1 to 2 months, third dose by 6 months of age. Below 6 months, we have to finish all the 3 doses. Giving the first dose within 24 hours of birth helps to prevent perinatal infection in baby born to HBs positive mothers who are not identified. Most of the mother still, like, we couldn't screen all the mothers for HBsAg. So many of the mothers will be a carrier, but we won't know that. That's why within 24 hours, we shouldn't take any risk. Any mother, we have to give hepatitis B vaccine at birth itself, along with the polio. Only 42% of children globally, if you see why I am stating again, we have to give as early as possible. We think that, okay, all the babies should get hepatitis B vaccine at birth. It's not like that. If you see, only 42% of children globally have access to the birth dose of hepatitis B vaccine. Almost half of the children doesn't have access to birth dose of hepatitis B. That's why hepatitis B poses a bigger threat in world population still. And as far as hepatitis B concerned, there will be a question whether HBsAg positive mother can breastfeed the baby immediately. Yeah, baby after immunoglobulin and birth dose of hepatitis B virus, we can very well give to the mother for breastfeeding, and they can feed directly, and there is no contraindication for that. Next, hepatitis C in children. While in the majority of children, hepatitis C infection remains asymptomatic, it has the potential to progress into chronic hepatitis, like hepatitis B, cirrhosis, and hepatocellular carcinoma can be there seen in HCV. The global prevalence of HCV is estimated around 2.5%, with a viremic rate of around 67%, whereas in India, it ranges from 1 to 1.9%. Nowadays, with modern blood bank screening practices, have nearly eliminated the risk of transmission of HCV infection. Around in 1980s, it was at the peak because of non-screening techniques of blood transfusions. Nowadays, we screen vigorously in blood banks so that there is a sharp decline in infection rates. Currently, mother-to-child transmission during perinatal period is regarded the most common mode of infection than blood transmission. Because of this screening we do. The transmission, as I said earlier, is either by vertical or horizontal. Vertical by mother to child, horizontal through blood transfusion or blood products. Mother to infant transmission is around 31% of transmission occurring in utero, 50 to 79% during the peripartum period. Risk multiplies with concomitant HIV infection, high maternal HCV viral load also. Those children requiring repeated blood transfusion and adolescents, if you see most of the adolescents nowadays in developing countries, even now in India, have access for IV drug abuses. They are also having high risk of developing HCV infection. That is IVDU, intravenous drug use, is a significant and common cause of HCV infection in adolescent and young adults. And there is 364%, not 50 or 100. There is 364% increase in IVDU among this age group over the last decade. 10 வருஷத்துல எத்தனை பேர் drug abuse பண்ணிட்டு இருக்காங்க நம்ம, even adolescents. Next. HCV infection is detected incidentally in more than 90% of individuals who are asymptomatic. Mostly it will be incidental diagnosis. If you go for a transfusion screening, they will diagnostic incidentally. Spontaneous resolution of viremia in 25% to 40% of children with mother to child transmission, usually by 2 years of age, mostly, and by around 6 to 10% they will be resolved by 7 years of age. Most rarely they will go for chronic liver failure. Majority of children, around 80% with chronic hepatitis, do not undergo spontaneous resolution but remain asymptomatic. But 14% may present with chronic hepatitis and 1 to 2% may progress to cirrhosis. Next. So diagnosis and management only with the history along with the examination findings, we can think about HCV. Presence and duration of jaundice, pointers of chronic lung disease like edema, altered sensorium, loss of unusual loss of weight or appetite, GI bleed. We have to think about this HCV virus and we have to screen for it. Unless until we screen, we cannot find HCV virus infection. Risk factors such as blood transfusion, if already there in the history, IV drug abuse, surgery, any surgery, needle pricks, tattoos, liver diseases in the family, we have to again think of HCV infection. A thorough clinical examination to be there to look for uterus clubbing, edema, nutritional status of the person, palmar erythema, liver size, consistency, sphenomegaly, free fluid evaluation, etc. should be done. And also we have to look for extra hepatic manifestations like arthralgia, arthritis, unusual unexplained arthralgia, arthritis, vasculitis, polyarthritis. We have to think about any liver, chronic liver diseases. Next. 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 Can we move on to the next slide? Next.
Sir, 1 second, sir.
So algorithm, you see, as I said here, we should always suspect HCV infection. Incidentally, only we can pick up HCV infection with the history, and we have to check HCV RNA PCR, do liver function tests, CBCs, RFT, coagulopathy investigations, USG abdomen, etc. And repeat the HCV RNA PCR 12 weeks after completion of treatment with our antivirals for confirmation of cure. Next. So we can use we can use antivirals also, as in case of hepatitis B. In C also we can use antivirals, and DAA, that is direct acting antivirals, have high efficacy in treating HCV. They target specific non-structural proteins of HCV, and the DAA which we use are well established and well studied, sofosbuvir and ledipsavir. They are polymerase inhibitor and N5-SA inhibitors. Next. Next. So So how to prevent SCV infection? Next. How to prevent SCV infection as the virus spreads parentally? Screening of blood, avoiding unnecessary needle pricks, tattooing we should avoid. Sharing needles among the IV drug users will be should be avoided, and we have to tell them, and we have to educate the adolescents so that only we can decrease the spread of SCV infection in our population. Vaccine for hepatitis C viruses is in development only. It's in the pipe. It's not at it doesn't have any cure at present, so prevention is a better cure for HCV. Next. Hepatitis E, first discovered in India, and there were two large epidemics which happened in India around 1950s in New Delhi and 1980s in 70s in Kashmir Valley. That time it was not known that hepatitis E was the cause of those epidemics. On later retrospectively analyzing the preserved serological samples, they came to know that those outbreaks were because of hepatitis E. Next. Incubation period is around 2 to 5 weeks. Again, it is mostly majority asymptomatic, irrespective of genotype. Sometimes they will go for acute hepatitis. Only less than 20% develop acute icteric hepatitis. Same as viral A hepatitis A. However, about 0.5 to 4% can progress to acute liver failure, which can lead to high mortality in the absence of liver transplant. Next. Can also go in for chronic hepatitis, generally known to be a self-limiting disease. However, in immune compromised patients like transplant recipients, it can be chronic hepatitis also. This is defined as presence of HEV RNA in stools of an infected person more than 6 months. If it is there, we have to term it as chronic hepatitis E. You can see the liver enzymes will be peaked by around 6 to 8 weeks of time, and the virus will be there in stools from 3 to 8 weeks of time, and IgG will be peaked by around 7 to 12 weeks time. Next. Again, prevention, since hepatitis C is essentially spread by fecal-oral route, it can be prevented by improving our hygiene, providing and accessing clean drinking water. Complete virus particles are susceptible to high temperatures, so boiling of water is recommended in all households in lower socioeconomic groups. Within 5 minutes, the virus will die above the temperature of 90 degrees Celsius. Avoid eating undercooked foods. Mostly in undercooked pork, SCV gets transmitted. Hepatitis E vaccine, actually, China only has hepatitis B vaccine. Apart from China, the other countries doesn't still approved hepatitis E vaccine. Only approved vaccine in China is HEV 239, that is Ecolin, which is developed in China, which contains 30 microgram of purified antigen. But Chinese are using it since 2011, but it has been not approved to use in any other countries apart from China. Next. Thank you. Hepatitis D is not actually a virus which causes infection on its own. It needs hepatitis A, so I didn't cover it separately. So regarding pediatric, from hepatitis A to C, I think I have covered clinically prevention and this course of the illnesses. So if you have any questions regarding this hepatitis, viral hepatitis in pediatric age group, you can free to ask. Thank you.
Thank you, sir. That was really a nice presentation, and we are very happy, sir.
Thank you, and I also like to thank again for microbiology department, Mahendran, you in person actually called so many times, postgraduates, HOD madam, dean, director, VP, And actually, I would like to say a little thing that I always miss AVMC, especially Annapurni Hall. Any CME will be there. Like we'll be having a great time. All our knowledges have been developed from Annapurni Hall, and it is very like proud for me also to know that my video will be played in that hall today. Thank you.
Thank you, sir. Next, I would request Dr. Madiha to give a brief introduction about the next speaker.
Good afternoon, everyone. I'm privileged to introduce Dr. Mangaiyarkarasi, who is a professor in Department of Microbiology, Sri Manakula Vinayaga Medical College, Puducherry. She's also the quality manager of the Central Lab Infection Control Officer, HICC Secretary, and also actively involved in NABH activities. She has done her post-graduation in Arupadi Vidu Medical College and also has 21 publications in Indian and international journals. We all would love to hear from you regarding the lab diagnosis of hepatitis. Over to you, ma'am.
Ma'am, now you will be able to share your slides, ma'am.
Mahindran, am I audible?
Yeah, ma'am. Now you are audible, ma'am.
Okay, thank you.
Ma'am, this presentation, you can make it full screen, ma'am.
Can I start now or I have to wait
Yes,
some
ma'am.
time?
No, ma'am. You can start actually.
Okay. Good afternoon, everyone. At the outset, Mahindran, can I start? Am I audible?
Yes, ma'am. You're audible, ma'am. But in your screen, we could see some blocks.
Some
presentation. Some in presentation itself, there is a block, ma'am. It is not correctly viewed.
What blocks? I don't know. 1 second.
In all the slides, it is there, ma'am. Something is blocking. Some other window is open, like
what is blocking? Now it is okay.
Side also we
Mahindran?
have, ma'am. Side also we have, ma'am.
Outside. Now it is okay.
Okay, ma'am. Now it is okay, ma'am.
Mahindran?
Okay.
Now it is okay, ma'am.
Now it's okay.
Okay. Can you continue?
Yes, ma'am.
Good afternoon, everyone. First, I thank the organizers and the management of AVMC for giving me this opportunity. And special thanks to Dr. K.Sethumadhavan, sir, for inviting me in this seminar. The topic for today's seminar is hepatitis B viral markers. What does it imply? As we all know, hepatitis exerts inflammatory actions, and also it causes fibrotic and carcinogenic effects. So when we think of hepatitis B viruses, we always know that it causes complications like hepatocellular carcinoma, fulminant hepatitis, and we have a vaccine. It is also a vaccine preventable disease. So we have a vaccine for prevention and also treatment also. We have a good drugs for treating hepatitis B viruses. And we also have liver transplant in the advanced cases. But when we think of what tests to order for hepatitis B, always it is overwhelming. That is what I felt when I studied in UG and PG. Okay, hepatitis B virus diagnosis means always it is overwhelming. We have various markers: hepatitis surface antigen, hepatitis 4 antigen, hepatitis E antigen, and also all antibodies. And sometimes we also have to talk about the liver enzymes, ALT, AST, and also non-invasive test. All the things are there. So what test to order when? That is overwhelming. I hope in another half an hour or 40 minutes, I can throw some light or I can do justification for this topic. What they have given me, that hepatitis B markers, what does it imply? So this graph, I think everyone will be familiar with this graph, that is which shows acute hepatitis marker, how it is expressed. Okay, so whenever a person get exposed to hepatitis B virus, the first marker which is appear on the blood is the hepatitis surface antigen, and it disappears in 6 months in acute cases. In chronic cases, it keep on secreting. Okay, so afterwards, immediately the first antibody to appear is the IgM anti-HBC, and this IgM and after few weeks, IgG anti-HBC starts appearing, and that we can measure as a total anti-HBC. And after some, most of the time, the acute hepatitis will resolve on itself, and rarely they go on to chronic progression. Okay, so once the anti-HBC has been disappeared in around after 8 months, anti-HBS, that is the neutralizing antibodies or protective antibodies, start appearing, which gives us a status of immune status of the patient. And always there is a window period between the disappearance of the hepatitis B surface antigen and appearance of anti-HBS, that is antibody to the hepatitis surface antigen. This period we call as a window period, which can be detected only with the surface marker hepatitis C, total anti-hepatitis C antibody. Okay. So this chart also everyone will be familiar with that, where we can, by seeing what type of seromarker is present, we can tell whether the person is susceptible, whether the person is on acute hepatitis B virus or chronic hepatitis B virus, whether they have, what is their immune status, whether they are protective, non-protected, whether they are in the infectious stage, whether they are having escape mutants, whether they are in the occult hepatitis. All those things can be identified by plotting the seromarkers in the graph. So before going into what the seromarkers, where we are utilizing the seromarkers, I just want to recap what are the different clinical manifestations of hepatitis B virus. So hepatitis B virus, first, whenever it enters into the body, it produces acute hepatitis. It will be there for 6 months. Most of the people spontaneously it will resolve, or some people who need treatment, mostly they need a symptomatic treatment only. And then In few people, it goes on to chronic hepatitis. That is, after 6 months, if we are able to see the seromarkers in the patient, and we turn them as chronic hepatitis. And this chronicity also depend upon where or which age the person gets infected. If a child gets infected, neonates get infected, they become chronic hepatitis. Quite a number of child will become chronic hepatitis when compared to the adult. In chronic hepatitis, we have certain stages called carrier stage, where we have immunotolerant hepatitis B viral infection, and next one is chronic inactive hepatitis B virus infection. In immunotolerant and all, I have put a graph, we'll discuss later. And then this chronic hepatitis patients, they may become a fulminant hepatitis whenever they have other hepatitis virus add-on comorbidities like that. They may develop into fulminant hepatitis. And most serious complication of hepatitis B virus is the hepatocellular carcinoma. And another type is the occult hepatitis, where we can't detect hepatitis seromarkers in the blood. Okay, so hepatitis surface antigen will be negative, all the markers will be negative, but we can able to detect the hepatitis B virus in the hepatocytes. That is called occult hepatitis. So people are telling this hepatitis is the one which is responsible for reactivation. So what are the markers which has been which have been helpful in diagnosing the stages of hepatitis B infections? We have antigen markers, hepatitis B surface antigen, hepatitis B pre-core antigen, that is E antigen, hepatitis B core antigen. This hepatitis B core antigen is not secreted in the serum sample. So mostly we won't include in our regular panel of diagnostic tests. And we have antibody markers, anti-hepatitis B surface, anti-hepatitis B, anti-hepatitis B C. In anti-hepatitis B C, we have two. We can measure IgM and also we can measure total. Okay, so total, which consists of both IgM and IgG, and anti-hepatitis B C IgM will detect only IgM. Okay, and we also have a molecular marker where we can quantitate the number of hepatitis B viral DNA which is present in international units per ml, where we use RT-PCR for that. And apart from this viral markers, we have other non-specific markers which are also helpful in identifying the stage of the disease as well as diagnosing, and they also guide us in treatment purpose also. So these non-specific markers are the liver enzymes and the serum bilirubin. Mostly the liver enzymes are alanine aminotransferase, aspartase aminotransferase. These two are the non-specific markers. This is what routinely we study in our UG things. And recently we had another two markers which are coming into field. That is hepatitis B virus core-related antigen. This is what previously we have only hepatitis B core antigen, but now they are telling this hepatitis B core-related antigen, CR antigen. This is nothing but combinations. It consists of hepatitis B core antigen, hepatitis B pre-core antigen, that's E antigen, and a truncated protein 22 kilodalton size 4 protein. So this is all these three combined together has been given a name as hepatitis B core antigen. This is for just information. And again, this hepatitis B virus RNA is also now people are detecting using chemiluminescent assay. Here this RNA is present as pre-genomated virion formation. So this also people are telling, even though there is a clearance of hepatitis B virus, this presence of hepatitis B viral RNA as a pre-genomic virion may be responsible for reactivation. So these are the new markers which are now work is going on. Okay, and then we have another type of test called non-invasive test, where the liver parameters can be tested without doing liver biopsy. So for this purpose, we have aspartase alanine transferase platelet ratio index, that is APRI. We can calculate putting a ratio between aspartase aminotransferase and platelet count. And if it is more than 2, it is cirrhosis, and less than 2, we can wait like that. And a transient elastography to identify the stiffness of the cirrhotic liver, and fibro test. These are the non-invasive tests which we can use for finding out the stages of the stages in the hepatitis B infection. So we have quite a number of tests which is available, or which we have to diagnose hepatitis B virus, and also to assess whether the person is responding to the treatment, and in what stage the person is, whether the person is in chronic stage, reactive stage, or whether the infection is resolved. All those things can be identified by using these markers. So this only in the few slides we are going to see what it is. So we have all the markers what we have studied. We have certain markers which will use as for particular purposes. So epidemiological marker what we use is a hepatitis B surface antigen. Commonly we use hepatitis B surface antigen, that is HBsAg, as a epidemiological marker to find out the prevalence. But in few cases, we also use past infection, means we can detect only with the presence of IgG core antibody. So hepatitis B surface antigen and anti-hepatitis C IgG both act as an epidemiological marker to identify the prevalence rate in the society. And the marker for active replication, that is whether the virus is actively replicating, this can be identified by 2 markers. One is hepatitis B antigen, and another one is, you can detect direct marker is the hepatitis B virus DNA. So these are the 2 for the active replication. And marker for high infectivity, again the same, hepatitis B antigen. So which marker represents the decreased infectivity? That is antibody to hepatitis B. That represents a marker for decreased infectivity. And which marker represents resolved infections? The infection once has been seen, the person goes on, and afterwards the infection has been resolved. This can be identified by calculating anti-HPC total, and also there is 2 markers, actually, presence of anti-hepatitis C total and absence of anti-hepatitis C IgM. These 2 define the marker as a resolved infection. IgM, hepatitis C core IgM represents recent infection. So the marker for resolved infection means presence of anti-HPC total and absence of anti-HPC IgM. Okay. And what is the marker for protection? The marker for protection is the anti-HBs. This is what we measure when we give a vaccine to find out whether the person is protected against hepatitis C antibody. This titer is available. When titer is more than 10 IU per ml, then the person is protective. And if it is less than 10, we call them, they are not protected. At the time only, we will give them immunoglobulins. Okay. So these are the markers which are responsible, which are helpful in identifying whether the person is protected, whether the person is having high infectivity, active replication, like that. So this is what the markers implies. So coming to hepatitis B as such, already I think previous speakers would have discussed this. But anyway, a little recap. Yearly, more than 2 billion people have been infected with hepatitis B. Among them, 240 million people are chronically infected, and every year 650,000 people die because of hepatitis B. And among the people who are having hepatocellular carcinoma, 45% of hepatocellular carcinoma cases is because of hepatitis B infection, and 30% of cirrhotic patient is because of hepatitis B infection. So this is about the seriousness of hepatitis B. Okay, so 45% of the hepatocellular persons and the carcinoma patients, and the cirrhotic 30% of cirrhosis is due to hepatitis B. And we have treatment options, that is nucleoside analogs, which we can treat, tenofovir and entecavir. But tenofovir is a very good drug which is also used for antiretroviral therapy. So for children, it is 300 milligram daily, and for adult, it is 600 milligram daily. just for information. So this is about the overall information about hepatitis B. And we already know that hepatitis B in less than 6 months, it is resolved, it is acute hepatitis infection. And when it will be present more than 6 months, it is chronic hepatitis B. So again, this chronic hepatitis B can be classified into 4 phases. We have immune tolerance, immune clearance, inactive carrier, and reactivation. These are the 4 phases we come across in the chronic hepatitis B. So since we have discussed all the markers, so why we have discussed about all the markers? These markers are helpful in assessment for indicate whether the person need any treatment, and also it is helpful in guiding choosing the management and to assess the severity of the liver disease, and also helps in the assessment of viral replication, and also the markers helps in the assessment of the presence of comorbidities. So whenever a person is having hepatitis B infection, only one test, that is hepatitis B surface antigen, is enough to tell that the person is having hepatitis B viral infection. But we have all the seromarkers, which is helpful for all these purposes. So the markers are helpful to save life, to improve clinical outcome, and reduce the incidence of transmission of the hepatitis B viruses. That is, persons who are like escape mutants where hepatitis B surface antigen will not be there. So at the time when you just screen the patient with hepatitis B surface antigen, and we won't tell that we won't do other markers, those person can spread infection to others. That is why in hepatitis, all the testing for all the seromarkers is important. And again, when you tell about the treatment for hepatitis B, most of the people will know, we all know that hepatitis B treatment is lifelong, but no, it is not as such. We can discontinue the treatment based on the seromarkers. And again, sometimes we can start the treatment again. For all these purposes, the testing for seromarkers or biomarkers is important for hepatitis B virus. So again, for diagnosis, we have different methods like immunochromatographic method. We can test for the presence of the markers by ELISA or chemiluminescence assay. And PCR also can be used, but RT-PCR is quite sensitive for detecting low level of HBV DNA. So these are the methods what we use, like rapid immunochromatographic test, ELISA test, for CLIA or RT-PCR. This ICT and ELISA, we have all the markers, hepatitis B surface antigen, core antigen, total core, also for hepatitis B envelope antigen antibody. For all the things it is available. So what test we have to do for the diagnosis of hepatitis B infection? We have to do all the tests. Okay, it is not that you have to do only one test, hepatitis B surface antigen, and leave. Additional seromarkers are a must. We have to, once that is hepatitis B surface antigen is for screening only. Okay, so once you screen for hepatitis B surface antigen and the person turn out to be positive, or the clinician suspects hepatitis infection, hepatitis B surface antigen comes out to be negative, maybe because of mutant or occult hepatitis, we have to perform additional serological markers. And these additional serological markers are helpful in identifying the stage where the person is. And also the liver enzymes, aminotransferase levels, are helpful in identifying liver inflammation. And HBV DNA helps us in finding out the infectivity, or it is the gold standard to find out the viral replication and infectivity. And also the non-invasive tests are helpful in identifying the stage of the liver fibrosis. There are 4 stages. I'm not going into detail, but these NITs are helpful because to find out the stage of liver fibrosis, mostly people go for invasive tests like liver biopsy. But this non-invasive tests also are helpful in identifying the stage of liver fibrosis. So better we can utilize that. So this graph depicts the chronic hepatitis, where we have immunotolerance, immunoclearance, reactivation, all those things. We have various markers, but mostly we can concentrate only on hepatitis E antigen. So in immunotolerance, we have hepatitis E antigen, and we can have a high level of hepatitis B viral DNA. And also we have this ALT is in a normal level, and there is very minimal hepatitis. So this immunotolerance person, we no need for treatment here. Okay, we can just monitor. I think in future slides we can able to see. And here in the immunoclearance stage, also hepatitis E antigen will be present, but the level of hepatitis B DNA is fluctuating. And also you can see the alanine level, aminotransferase level is also fluctuating. And also the person is in acute hepatitis. Here treatment is needed. Okay, so likewise, we can able to identify in which stage the person is, whether the person is in immunotolerance, immunoclearance, or reactivation. Like that, we can diagnose only by testing all the seromarkers. So here actually you can see mainly we can we identify for treatment purpose whether we can treat or not with the hepatitis E antigen positivity. So if hepatitis E antigen positive and the HPV DNA is, even though it is more, but ALT is normal, the patient is immunotolerant, no need to treat. We can wait. Okay. If the person is in chronic hepatitis and where the antigen is present and alanine is elevated, we have to treat. So likewise, depending upon the seromarkers, we can decide the treatment. So this, I think this graph will tell you where all treatment is necessary. Treatment is needed when there is immune active phase and also in the reactivation phase, and in any phase, wherever person is there, if a person has cirrhosis, we have to start. Whether the person is in immunotolerant phase or immune active phase or any phase, if the person is having cirrhosis, clinical evidence for cirrhosis, all the patient treatment has to be started. The only thing is if the person is not having cirrhosis, we can look in for the phase and accordingly we can start the treatment. So what are the assessments we have to do before starting the treatment? So before starting the treatment, we have to do an alanine aminotransferase level, HBV DNA level. HBV genome is also important. Why? Because B has various types. In that, B and C types are quite common in our country, where C is more has more severe infection. Family history of hepatocellular carcinoma and any cofactors such as alcoholic use, HIV infection or diabetes, all those things has to be assessed before starting the treatment. And whom to treat? So treatment has to be done to all adults, adolescents and children with chronic hepatitis B infection where clinical evidence of cirrhosis. If cirrhosis is present, we have to treat all the patients. But in adults with more than 30 years, persistently abnormal ALT and HPV DNA more than 20,000 IU per ml, again we have to start treatment even if cirrhosis is not evident, age is more than 30 years, persistently abnormal ALT and HPV DNA is more than 20,000, we have to start treatment. So here again, laboratory diagnosis plays the role in deciding whether treatment is started or can be started or not, more than 30 years. And whom treatment can differ. There is no clinical evidence of cirrhosis. That is, APRI score is less than 2, persistently normal ALT level, and HBV DNA is less than 2000 international units per ml. We can differ. That is, we can wait for, instead of starting antiviral therapy, we can wait and monitor the patient before starting this. Okay, so this here, the lab diagnosis helps us in decide we can differ or not. And where more monitoring is recommended, even the person is less than 30 years without cirrhosis, HBV DNA is more in number, but persistently normal ALT, again, more monitoring is needed. We'll defer treatment and we'll wait here. Hepatitis E antigen is negative without cirrhosis, age less than 30, and hepatitis B viral DNA fluctuates, intermittently abnormal ALT also, we'll wait. So when to stop treatment? For starting treatment, we have certain guidelines. But if a person is having cirrhosis or any cirrhosis or liver changes, lifelong therapy is recommended. Okay, there is no place in stopping the treatment there if a person is with cirrhosis. But where we can stop? When a person loses the HBE antigen, that is previously he has HBE antigen, and after some time HBE antigen is not detectable in its serum sample, but we were able to detect the antibody for HBE and persistent normal ALT and sustained undetectable HBV DNA. In this condition, we can stop. Again, we look for a antibody for surface antigen, that is HBs AG zero clearance. That is AG will be cleared, antibody will be seen. Very rare cases it will be occurred. But these cases, when we can stop? We can start the treatment after completing one additional year of treatment, we can stop. So when we treatment can stop, also the diagnosis only is helpful here. So here we test hepatitis B AG should come negative. Antibody to hepatitis B EAG should be there. Persistently normal ALT and undetectable HBV DNA and zero conversions or zero clearance of surface antigen. These things has to be fulfilled, then we can stop the treatment for hepatitis. Again, I'll tell, if a person is having cirrhosis, there is no guidelines is given that you can stop. If the person is having cirrhosis, they have to take lifelong treatment. If cirrhosis is not there and they fulfill these conditions, we can stop the treatment. So what are the monitoring we can do? Like where the lab helps. Okay, so that purpose on that points only I'm highlighting here. So annually we can monitor the patients for alanine aminotransferase level, aspartase aminotransferase level, and every year test for hepatitis B surface antigen, hepatitis B E antigen, HBV DNA if it is available, if the facility is available, and non-invasive test to assess cirrhosis. And if patient is on treatment, again adherence of the treatment also has to be monitored. Then only the person has to take treatment. Okay, you just prescribe the drug and the patient is not taking the treatment, then again it is a treatment failure. So annually, if you identified one person is having chronic hepatitis B, we have to monitor with these parameters. And we need monitoring every 3 months. If the person, we didn't start them on antiviral therapy. If we didn't start them on an antiviral therapy, we choose to defer, then we have to monitor them every 3 months with previous parameters. And if the person is on treatment, to find out whether the person is responding to the treatment, for that purpose also we have to monitor. And if a person has been discontinued the treatment, then we have to again monitor the patient to find out at what stage he is there. So monitoring is the frequency has to be increased every 3 months in these conditions. And again, before starting the patient on antiviral therapy, the toxicity monitoring also has to be done. So baseline renal function test before starting treatment, and every year we have to check the renal function test. So this is how the laboratory helps in the treatment of hepatitis B infected persons. And again, we can monitor the patient for hepatocellular carcinoma. So every year, if a person has history of family history of hepatocellular carcinoma or a long-term chronic hepatitis patients, every 6 months we can do an ultrasound abdomen to visualize the liver, and also we can check for presence of alpha fetoprotein. So these two helps in monitoring hepatocellular carcinoma. Why monitoring is important here? If hepatocellular carcinoma is diagnosed earlier, the prognosis is improved. Okay, so for that purpose, we can monitor regularly to identify whether the person is going in for hepatocellular carcinoma. So renal transplant or liver transplant, all those things can be planned. For that purpose only monitoring for hepatocellular carcinoma is needed. And we can monitor for the restart of the treatment, that is retreatment. So if a person they have stopped treatment by themselves, or we can assess after assessing that we can stop the infection, we have stopped. But those patients also we have to keep on monitoring whether they are reactivated. So for that, actually, we have to see for the consistent signs of reactivation. If the person shows consistent type signs of reactivation, like previously hepatitis surface antigen negative, E antigen negative, which has been turned into positive, and level of ALT increases, and the HPV DNA, which is not previously detected, turned out to be detectable. In these conditions, we can restart the treatment again. So for these purpose, restarting treatment also we have to monitor. So again, for diagnosing treatment failure, whether the person treatment failure can be diagnosed by measuring the hepatitis B DNA in the serum. So primary failure, we have two types of failure: primary failure and secondary failure. Primary failure is failure to reduce the number of hepatitis B viral DNA by more than 1 log 10 international units per ml in 3 months. So after starting 3 months of treatment, there should be a reduction in the hepatitis B viral DNA. If it is not so, then there may be a chance of resistance. So we have to change the treatment modality. So this is the primary treatment failure, which can be detected by measuring the hepatitis B DNA. Secondary failure is initially the person responded. Okay. So after 3 months, we found out that there is a decrease. But after some time when you measure, there is a rebound of the hepatitis B viral DNA. Then it is secondary failure, treatment failure. So measuring hepatitis B viral DNA is helpful in diagnosing treatment failure. But if that facility is not available, we can monitor with the serum aminotransferase level and also the evidence for progressive liver disease. So clinically, if the liver disease is progressing or the measurement of serum aminotransferase level is keep on increasing, then it implies that treatment failure is there. So we have to change the treatment, or we have to find out whether the person is adhering to the treatment, whether they have stopped by themselves. So for that purpose, laboratory helps. So with this, actually, I come to the end of my PowerPoint, my presentation. To summarize, normally we test for hepatitis B surface antigen, hepatitis B core antigen IgM, and hepatitis anti-HBs. So if all three is negative, then the person is susceptible to hepatitis B infection. So this person has to be vaccinated. So before vaccinating a person, it is mandatory to vaccinate everyone in endemic countries. But if we want to check whether we have to vaccinate or not, we can check these three parameters. And if all three turned out to be negative, they are susceptible. So we have to vaccinate. If antibody to HBC and HBs both are positive, that implies the immunity has come due to natural infection. Why natural infection? Hepatitis B core antibody can come only with the infection. Okay. So here these two antibodies are positive where immunity is developed due to natural infection. So no vaccination is needed in this scenario. And we can see here only anti-hepatitis B surface antigen. Magindran, can I answer the question later? Because I don't know where to open the chat box.
No, ma'am.
Okay. Okay.
Yeah, yes, ma'am.
So anti-hepatitis. So only anti-hepatitis B surface antigen is positive. No, this is because of immunity because of hepatitis B vaccination. So here also no need for vaccine. So here actually we measure the titer for hepatitis, anti-hepatitis B surface antigen. So here it is more than 10 is protective, less than 10 is non-protective. So here you can see only the IgM anti-hepatitis B C is positive. That means the person is having acute infection. So here that it just gives us a clue that the person is having acute infection. So we have to do more tests to find out what stage the patient is, and then accordingly we have to treat. And here, surface antigen is positive and hepatitis B core antibody is positive. So here it is chronically infected. Again, we need more tests. And hepatitis B surface antigen is negative. Core alone is positive. HPS is negative. Then here the interpretation is unclear. There are more possibilities for that. Okay, it may be a resolved infection. It may be a false positive. So the person will be susceptible. It may be a low level of chronic infection, resolving acute infection. It may be a escape mutant. It may be occult hepatitis. So more test is needed in this scenario comes out. Okay. And hepatitis B antigen is an accessory protein, which is the index for replication, infectivity, and severity. So when a pregnant mother, we all know risk of transmission is more. But if a pregnant mother HBe AG is positive, there is 90%, more than 90% of chance for the transmission of hepatitis B virus from mother to child. And again, hepatitis B viral DNA measurement is also important. It's also important. Questions in chat box. Okay. So I think with this summary, I have thrown some light to which test we can order at what scenario. If you have any doubt, you can ask now. With this, come to my presentation. Thank you. This is my institution where I am working, Vinoth Medical College. Thank you all for giving me this opportunity. Any doubts?
Thank you, ma'am. We'll wait for 5 minutes. If there is no doubt, then we can break for lunch, ma'am. But we'll wait for 5 minutes.
Thank you, sir. Thank you, Bhaskar, sir.
If there is any doubt, you can post in the chat box so that ma'am will be able to answer.
Madam Mangai.
Yes, sir. Yes, sir.
You have completed everything. Then
good
what
morning, sir.
Good morning. What I will talk in the afternoon?
I don't know, sir. They asked me only to prepare for hepatitis B. So I only prepared for hepatitis B, sir. I think other hepatitis you will talk.
Yes. Excellent.
Thank you, sir. Actually, thank you, sir. Thank you, sir.
Very nice. I think that students will like your discussion. Anyway, I will try my level best to do my justification in the afternoon. Thank you,
Actually, it is helpful for me also, sir. Like when to treat, I also will be confused with all the zero markers. This presentation helps me actually to understand even more better.
You are very clear. Your presentation is very good. If you give the copy to Mahendran, we will store it for the academic purpose in the department also.
Sure, sir. You can use it, sir. I have already given, sir. They are having one. Morning itself, I have given my PowerPoint to them.
Yeah,
they are having.
Very excellent preparation, madam. Thank you.
Thank you, sir. Thank you. Thank you for the opportunity, sir.
Thank you, ma'am.
Thank you. Mahendran, can I leave?
Yes, ma'am.
Thank you. Thank you. Thank you, Anu.
Now we'll break for lunch. Thank you, ma'am. Now we'll break for lunch, and we'll come back after for the post lunch session by 2:10. Thank you.
கரெக்டா இருக்குதா? இப்ப சரியா இருக்குதா?
have won. Because I have won. I've won. I've won. I've won. I've won. Look at it. Morning. Welcome aboard. I think you'll find that's mine. Thank you. These eyes are... Please, please. Thank you very much. Minibar. Drinky, drinky. Robert. Okay.
Good afternoon, everyone. Welcome back to the session. Now I would like to request Dr. Madhiha to give an introduction of the next speaker.
Good afternoon, everyone. For the next session, that is a continuation on the lab diagnosis, I kindly invite Dr. K.Sethumadhavan, sir, Professor, Department of Microbiology, Aravindhan Medical College. Over to you, sir.
Thank you, madam.
Good afternoon, sir. Yes, sir.
Good afternoon. Madam, it's the right time to start, or you have put to 2:15? We have to wait for some time more.
Sir, like I told them it is 2:10. Now everything, you can try sharing your PowerPoint, everything, and we'll start, sir, in 1 or 2 minutes. Sir.
Yes. Because all students will be joining by now.
Yes, sir.
So nobody will find fault with you afterwards.
Probably they must not, sir.
Yes. Now my video is clear.
Yes, sir. Video is clear.
You switch on your video, Mahendran. So please switch on your video. Your video, you please. Yes. No, what I wanted to know, to say yes, I will start. Because you are able to understand that everybody has joined.
Sir, we have given them time. And
1 minute, I will check up now. I will check up now. Ram Sudarshan.
Sir, yes, sir.
Yes, he is here. Neka Kumari. Not there. Naveen. Not there.
Sir.
You are here. Very
Yes,
good.
sir.
Bal and Nandita. Praveen.
Sir, now it is 2:15, sir. I think we can start the presentation.
Fine, very good. Good afternoon to all of you. First of all, I must thank all the faculty members who have put a joint effort and made a very nice program in which you have included the former director, Institute of Microbiology from Madras Medical College, Dean Dr. Jayalakshmi Madam from Lakshmi Narayana College, Professor and HOD Medicine, Dr. Suresh from Venkateswara Medical College, Paediatrics faculty, Dr. Aravindhan, who was for alumni from Thanjavur Medical College, Mangai Madam, Professor, Manakula Vinayakar Medical College. All have done a wonderful job. I believe that in the post-lunch session, I should take care that I am not making anyone to sleep. The topic today, what selected for CME is a very vital one. Because this is a, as per the WHO problem, this is a magnitude is very high. So they want to create an awareness. And every year that July 28th is considered as the World Hepatitis Day, in which we must discuss and we must try to understand more things about the this hepatitis problem. This year also we are just having this program, even though it is little slightly delayed and nothing wrong. But all students will understand this topic and they will try to update more and more information in due course, so that they will be very good that is capacity to deal the patients while seeing in their profession. The early speakers, they have done different topics in which they have told the clinical picture. Madam has told the overview of hepatitis, and pediatrics and immunization by Dr. Aravindhan. And Mangai Madam has covered the laboratory diagnosis of hepatitis B virus. No, the pending thing is that what are the things she has that included left for me is the other viruses, hepatitis viruses, which I will try to tell you now. And one more super specialty faculty, Dr. Vinoth, will be coming by behind me. That is 3:15, so that I will try to finish up in time. We are aware that practically that there are about 5 common viruses in viral hepatitis. Among the 5 viruses, B virus is the DNA virus, and all the other things are RNA viruses. This B virus is a DNA virus, which is a double-stranded virus, in which the positive strand is partly complete. It's not fully complete. There are some deficiencies there. The nucleotide is not fully complete. Positive strand. So these missing nucleotides are built up while during the multiplication, with the help of a DNA polymerase enzyme that virus carries in its course. Actually, this hepatitis A virus is the one that is called infectious hepatitis, and B virus is called as a serum hepatitis. All the others are considered as non-A, non-B hepatitis. So there were long time they were discussing only two things. One is infectious hepatitis, that is hepatitis A, and other one is serum hepatitis, that is hepatitis B. All the rest later coming are mentioned as non-A, non-B hepatitis. But now this virology, that international association has made a very good classification, and they have the characterization and all the things and all the properties we have understood in a better way. Contamination of food, water, that is the main problem with hepatitis A virus, through which it comes. When water is polluted, and if we are growing shellfish, prawn and all the things, crab, crayfish and all the things, and eating that one without proper treatment, viral hepatitis A can come. Whereas the viral hepatitis B, this serum hepatitis, mainly through the three modes, parenteral. The second one is by means of congenital, and third one is sexual. Now, parenteral, that is the main thing, is the blood transfusion. Before this tests are made mandatory, number of cases were very high. But after this drug controller who has made a strict rule enforcement, all these things should be tested for the transfusion transmitted infections. In this category, hepatitis B comes, hepatitis C comes. So all the blood banks, they are doing this testing, laboratory testing of these viruses. So mandatory. HIV is made compulsory. Now, hepatitis C is made this mandatory only in the 1990s afterwards. Before that, hepatitis C was not included in the testing list. So what to look for and what not to look for, all the things we should have an understanding. And this hepatitis B and hepatitis C, they are having a tendency for the chronic carriage. Chronic carriage. The malignancy potential is also there in hepatitis B. The number of people infected in hepatitis B is more than 350 million carriers. So this hepatitis B, it's a delta virus that is considered, that was initially Risotto, one scientist who have discovered this one from Italy, from drug addicts. This particular virus, they need the help of hepatitis B virus for its covering. It cannot make its own. It's a handicapped virus. It's a dependent. Hepatitis D needs the help of hepatitis B virus for the coat, viral envelope. So whenever there is an infection in hepatitis B, then only this hepatitis D can enter and then multiply and all the things. That is the thing that we will be seeing all these things and what to look for at the laboratory. So the last one is E virus. E virus is belonging to family Calciviridae, and that what type of thing? It is similar to the hepatitis A virus in the sense that it is non-enveloped. A virus and E virus, they don't have the envelope. Their mode of transmission is through the fecal-oral. Both are RNA viruses. Now, think that this hepatitis E virus, not only it causes a mild infection, except in pregnancy, 20% mortality is likely to occur. Hepatitis E is a complication, especially in tropical countries. In India, 1955. There are about 30,000 people were affected in Delhi because of the pipeline, sewage pipeline and drinking water pipeline. There was some problem and the mixing. So ultimately, a lot of people developed the infection. 30,000 people were infected. Hepatitis E virus. So we look at that one, that we have to find out how this virus, even though the clinical picture is more or less appears similar, there are some variations there. And what is more important? Which thing we have to check, where to test, to find out what exactly the virus has caused the disease. these having a tropism towards fever. Not only this thing, there are other viruses are there that morning itself they start very naturally. That they have been producing a systemic disease, even that bacterial infections are there, leptospirosis. The other viruses include the cytomegalovirus and all having this thing. They wanted to thing, but systemic problem also be these viruses A, B, C, D, E. F is mutant of hepatitis B, so that is deleted. G is included. The name G has been included as after thing. But the main problem is that it's what is in the site of infection is bone also. GB. Those who are affected with the HIV patients and the hepatitis G, there is some protection is there. I don't know whether it is protecting. Okay. Break. Yeah. Why? 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 People get can you hear now? Connected now? Can you hear now?
Madhu, is sir voice clear?
Yes. My friend. Okay. Okay. Whether anything happened, okay. Thank you. So, so we will try to understand events that are happening and where for that. Laboratory diagnosis, that's what we today our task. So we have mentioned that these are the viruses. A, B, C, D, F is not there. F is a mutant of hepatitis B. Deleted. The only DNA virus is hepatitis B virus. Rest all are RNA virus. And we are aware that this DNA virus belongs to the family hepatovirus, Papillomaviridae. So our primary concentration is on these 5 viruses. A, B, C, D, and E and produces either acute infection or chronic infection. Based on what? 6 months cut-off time. If 6 months acute, anything more than 6 months chronic. Now, these 5 viruses, E and E virus, these 2 are endogenously transmitted viruses. What happened to B, C, D? Parenteral. So, E virus comes with a pico-RNA. Pico-RNA means small virus, small RNA. Polio, like that, everything. Pico-RNA. E virus will come to hepatinoid. This is what I mentioned, double standard DNA. All other single standard RNA. In this double standard DNA, positive strand partly completes and carries DNA polymerase enzyme. And this fitness is correct by multiplication. 8.5 kg, 3,500 nucleotides. Virus that traveling through hepatitis C. Okay. Delta agent and E virus comes the virus. So genus hepatovirus, that is HPV. Orthohepatovirus, that is HPV. Hepatitis virus, hepatitis C. Delta virus. Again, it has become yeah. Okay. Okay. So this virus, A and E, B, C, A are whenever it comes to blood, always involved. It's not an involvement. That's through the tract. Now, what about this onset and progression? Clear? Is it clear? Okay. Now, when you say that acid stability, that is acid enters the GI tract, which is stable, A and E, which is not stable, B, C and D. Acute onset means A and E. All of a sudden, this kind of problem starts. Whereas chronic onset, the other things, parent, this A, B, C, D. Children and young adults are affected, that is A virus. Adults are affected, that is E virus. Any age, that is C and D. Young adults, babies, toddlers, they are all affected. That's why this hepatitis B virus vaccination to be given at birth, especially for hepatitis B. So when we see that cirrhosis, progression, hepatocellular malignancy and all, that happens in hepatitis B, C and D. This D virus is mainly drug addicts. So we are having vaccine for two things. One is for hepatitis A virus and other one is for the hepatitis B virus. Hepatitis B virus, we have to give 3 doses. Birth, then 6 weeks, then 6 months. Whereas A virus, we have to give vaccine after 1 year, not before. 2 years interval is over. 2 years, after 2 years we can give. The food, water contamination, that school, children go to school, then the problem. So the hepatitis A vaccine, we have to give 2 doses. B virus vaccine, we have to give 3 doses. So what is the vaccine available for hepatitis A virus is Havrix. What is the vaccine available for B virus is Engerix. Now both combinedly available for the age people more than 18 years, that is Twinrix, that is also available. So what is acute hepatitis? That below 6 months. Chronic hepatitis more than 6 months. So these are all the things that standards of sanitation, food hygiene, generally poor, especially this hepatitis A virus. Single stranded RNA, there is only one serotype. Subtypes are there. Only one serotype and subtypes are there. Source of infection, we have discussed this. Environmental cleanliness is very important. Water, food. Transmission fecal-oral. Same way the hepatitis E also. Fecal-oral. So incubation period is less around about 6 weeks time. Hepatitis B, it is 6 months. So initial symptoms are vague symptoms, feeling of tired, some kind of pain, right hypochondria pain, headache, like that. So last for about few days. The late symptoms means the jaundice will come. Jaundice we have to observe in the sunlight, not in the artificial light. The urine color will become more dark yellow, stools will become pale color, and this itching, right hypochondria swelling, all these things. It is not usually a serious illness, but in rare case only it will happen. Already some alcohol, that liver is affected like that, then only the problem comes. Otherwise it's not so. Hepatitis A recovery is very good, provided if we are giving plenty of carbohydrate and reduced fat intake. Not to take bakery items, then problem. Carbohydrate we can give glucose like that. Coconut water, tender coconut water, okay. So what to look for? That is the thing that we are trying to understand. Whenever there is an acute infection, IgM antibodies will come first. So this will peak after 2 weeks. Once a liver enzyme as a morning itself nicely talked, ALT, alanine aminotransferase. AST, aspartate aminotransferase. This earlier they used to call SGPT, SGOT like that, but now this is ALT and AST. This level will go high. Now IgM antibodies will appear acutely and then it will disappear 3 months time or 6 months. Whereas IgG, this will appear after this IgM appearance and that will be there for long period. So antibodies for the hepatitis A virus, IgM positive means acute infection. Antibodies to HAV, IgG means in the absence of IgM, that means past infection. So this point we have to understand. Now this level, how it rises and all the things that of course it first IgM comes and then IgG. So there is an immune electron microscopy is available and that we can check the stool before 2 weeks, after 2 weeks of jaundice. HAV particles. You can check the stool by ELISA. Among all these hepatitis virus, this is the only hepatitis virus where isolation has been attempted. Any specific drug is available for this? No. You have to give non-specific symptomatic supportment and all. Hand washing, prevention is after use of toilet also. Sanitary disposal of this infected fecal material properly with help of hypochlorites, 0.5%. Drinking water must be a treated drinking water, filter, chlorination, all. During outbreaks, we have to use the boiled water. Whenever there is a heavy rain outbreak, we used to tell, municipality will tell, you take care of the drinking water, everything. Vaccine available. Favorix, we are told that formaldehyde inactivated vaccine. You give only after 1 year, don't give before. But hepatitis B would start with the birth 6 weeks and then 6 months. The protective level of antibody titer in the hepatitis B is 10 international units. Because some people will not respond, that we will see. But hepatitis A vaccine, you have to give single dose, then a booster after 6 to 12 months. Live attenuated vaccine has come in China and all the things. Chinese people are always doing something much. Sometimes they are preparing that this unwanted also. Because always we understand that any outbreaks and all the things that come from China. COVID-19 comes from, you are aware that where it comes. Okay. So try to understand that, look for the IgM antibody for HIV for the acute infection. So after some period, IgG will come. IgM will disappear, but IgG will persist for a longer period. So this will tell you that the person has had infection earlier, that is IgG. Recent infection is IgM. So I think that there is no confusion with this. Okay. Come to hepatitis B. What is this? Morning itself they have mentioned that the scientist Bloomberg 1963 first discovered this. He found that serum of the patients, they revealed some 2-3 morphology, spherical taste, shape, tubular shape, and a complete particle. So this 22 nanometer, the spherical and the tubular particle, and this complete particle is 42 nanometer. It is having a surface outer envelope. What is that? HBsA antigen. Now this, whenever there is an infection occurs, this HBsAg will overspill production and spill over in the blood. That is what we are looking for, that HBsAg is present. This person is having this virus infection, multiplication. After some period, antibody for the HBsAg comes. By the time this antigen will disappear. So this is a HBsAg, that one is called Australian antigen because it was discovered by the Bloomberg. It is having a common antigen, group reactive antigen A, and other 2 sets of antigens, subtypes are there. That is DY, either D or Y. Similarly, W or R. Based on that, this permutation, the combination, you can find out this now these 4 types: A, D, and W. A, D, and R. A, Y, W, A, Y, R. This hepatitis virus is having some core antigen. This core antigen, it is not secreted in the blood. So we cannot search this antigen in the laboratory diagnosis. Only antibody to the core antigen, IgM, will be there in recent infection. And that is considered an important test. Antibody to the core antigen, IgM, for the recent infection. Antibody to the core antigen, IgG, that means that infectivity is reduced. Core antigen not seen in the blood. So what is seen in the blood? Antibody to the core antigen, IgM and IgG. IgM means the infectivity is very high. IgG means the infectivity has reduced. So we should understand that this core antigen is not there. Antibodies to core antigens, IgM and IgG, will come to the blood. There are various E antigen is there. One more thing, E antigen, hepatitis B E antigen. That presence shows high infectivity. Virus is still multiplying. That's all. Now this antibody to the E antigen means that person is not infective. So isolation and precautions, contact precaution, everything has to be done. There are 8 genotypes are there. In India, A and D. These are present. So I think that we understood this one. And ADR is in the South and East India. ADR. South and East India. ADR. AYW in the other parts of the country. ADR, South and East. AYW is in the North and the. So we have mentioned all these things. There are various genomes are there. I am just not going to the detail because that is a different thing. We will not discuss now. What is important we will talk. So virus is a double stranded DNA, 3,200 nucleotides. A virus is 7.5 kb. So the positive strand is partly complete. Only 80% is there. 20% is missing, so that the DNA polymerase will take care while its replication. There are various S, pre-S1, PS2 like that it is there. So mode of transmission we have already discussed. If you compare the HIV and hepatitis B, this hepatitis B infection is more, 30%. HIV is not so. So 30% hepatitis B, 3% hepatitis C, and 0.3% HIV. 30% hepatitis B, 3% HCV, 0.3% HIV. So how much blood required for the infection? 0.00000 and 1. You have to put after the 0.40. This infection, this blood can be infectious. So other things are there: blood, birth, sex. 3 things. So who are the risk for this thing? Hepatitis B. Already 350 million carriers are there. So surgeons, paramedical workers, this commercial sex worker, recipients of blood transfusion and organ, drug addicts. These are all the people who are affected. Blood bank nowadays they are testing the blood is mandatory. So reservoir of infection is a asymptomatic carrier. So what is more important? The HBsAg level is very low and no E antigen, simple carrier. HBsAg level is low. There is no E antigen, simple carrier. Then what is super carrier? This person is highly infective. Virus will transmit efficiently and effectively. There is a high level of HBsAg. There is HBe antigen is there. DNA polymerase enzyme is there, and DNA also is there. Simple carrier and super carrier, 2 things are there. Simple carrier means no E antigen. Super carrier means E antigen is there, DNA is there, DNA polymerase is there, all the things are there. So that other person is highly infective. Now what is the first marker comes for blood? HBsAg. By the time the enzyme also, biochemistry department will see that enzymes are there. Presence of HBsAg indicates the onset of infectivity. It may remain for some period, and after the onset of jaundice and all the things, it may become undetectable, and the antibody to the HBsAg will come in that place. So rarely it is seen beyond 6 months. More than 6 months, if you are seeing, then it is chronic stage. It's an epidemiological marker. There is a viral replication. There is a spillover of this envelope HBsAg. We are looking that one. HBsAg is there. The number of people around 350 million people are carriers. So we are all expected to have the hepatitis B vaccination properly done. All medical people. So chronic hepatitis can happen, cirrhosis can happen. Cirrhosis in 30%. 100 people are infected, 30 can go for if not proper. Hepatocellular carcinoma can happen. Post-transfusion hepatitis can occur. All the things are there. So HBV is said to be infectious as long as HBsAg antigen is present. It becomes non-infectious once the antibody to the HBsAg comes. Maximum infectivity is seen in when the HBe antigen is elevated. So these are all viral markers. Today morning, Madam Mangaiyar has told everything in detail. There are two things we have to see: antigen markers. It's surface antigen, E antigen. E is highly infective. Surface antigen also. Now, if you look at that, their antibodies, surface antibody to HBsAg, antibody to HBe, if it has come, okay, now things are improving. The core antibody will be there in the blood, but the core antigen will not be there in the blood. It is there that you have to do some FNAC like that and all. Molecular markers, hepatitis B virus, DNA. So we need molecular methods of detection, PCR and real-time PCR like that. Non-specific marker, liver enzyme and serum bilirubin. So ELISA, immunochromatography testing, all the things we are. You can do the quantification by the real-time PCR. Can we culture in the laboratory? Hepatitis B virus does not grow in the culture system. It is conventional. So these are all various markers that comes into the picture and all. So what is highly infective? E antigen. Surface antigen will come in the initial stage. E is there. Their respective antibodies, when it has come, things are improving. So high viral infectivity is there. Look for the E antigen, surface antigen. Now low infectivity and patient is improving. That means antibody to HBe antigen, antibody to the hepatitis core antigen, antibody to hepatitis surface antigen. Core antigen doesn't seen outside because it is hidden, non-secretory nature. Then where to look? Hepatocytes. How to look? Immunofluorescence microscope. So these are all the things we are talking. Antibody to hepatitis B core IgM. So once it comes, that means that recent infection, acute infection has occurred. When it IgG comes, okay, patient is improving. Antibody to hepatitis C core IgG. E antigen, infectivity, clearance, antibody to the hepatitis C. Morning, everything is told. I am just recalling all the things. How to interpret the markers. Suppose if you say acute hepatitis, in that the liver enzyme may not be very much high, but you will find the DNA as well as you will find the surface antigen. Okay, early stage. DNA is there, surface antigen. Okay. When the acute hepatitis is high infectivity is there, then what we are seeing? We are seeing now the liver enzyme has started increasing. DNA is also there. Then HBe and E antigen is there. The antibody to hepatitis core IgM also is there. So when you carefully look at that, this is the first antibody to come to picture. What? Hepatitis B core IgM. The surface antigen continues to be there. Then what happened to chronic hepatitis B? There are two things are there. One is highly infective stages and other one is low infectivity. High infectivity means the DNA is very low, load is high, liver enzymes are elevated. Symptoms are there or not? Yes, it is there. What is seen? This anti-HBe antigen is also very high. But at the same time, this antibody to hepatitis core antigen becomes IgG now. So only in acute hepatitis, this hepatitis core antibody IgM is a very, very important clue. It shows acute hepatitis. Keep remember, hepatitis B antibody the DNA level is lowered, liver enzyme as such it is elevated. Then what happens? Symptoms are still there. Now the antibody to the hepatitis E comes. That means low infectivity. So already antibody to the hepatitis E core antigen, that antibody IgG has come. Then what is next? Chronic hepatitis. Sometimes, sir, you can you please unmute yourself, and we'll have a question at the end. So this tabular column, if you try to carefully understand, you will be able to interpret the laboratory result clearly. I think our gastroenterologist sir will talk on that. I'm not dealing much. This acute hepatitis B is self-limiting, no specific treatment required. There are many options are there. All this pegylated alpha interferon therapy plus lamivudine. These drugs are there. Now there are some changes have happened. I think sir will explain all. Alpha interferon and lamivudine for the hepatitis B. For hepatitis C, this alpha interferon plus ribavirin. There are some recent advances have occurred. I think it is left to solve. These are all the drugs included. Tenofovir, telbivudine. Tenofovir, telbivudine. This drug is there. Lamivudine and other things, HIV, antiretroviral. That drugs are also useful. But earlier, but things are changing. Tenofovir, telbivudine. Complications hepatitis B. Rarely this can happen. Fulminant hepatitis, cirrhosis, hepatocellular carcinoma, and all. Some patients may develop serum sickness. Antigen antibody complex forms, and then this kind of things will deposition. Then this kind of problems will result. So if you look at that injection clinic, this kind of things, maybe the hepatitis B vaccine and all the things. There are three formulations are there. Engerix B. Avrix for A, Engerix for B, and Twinrix is for this both. This is after 18 years, I think we have. Newborn born to hepatitis B carrier mother, you have to give hepatitis B vaccine and passive immunization. Hepatitis B immunoglobulin. If you fail to give after 20 years, this child may develop hepatocellular carcinoma, and it is a mistake on our part. So we have to give both active immunization and passive immunization together in different sites. Not later than this 12 hours. Before that, we have to give. C virus is RNA virus. We have already talked. DNA virus only one, that is hepatitis B. That also double standard, but all others are RNA and single standard. Family is Sapasi. We have already mentioned size is the biggest one, 60 nanometer size. Enveloped, all blood-borne viruses are enveloped. Gastrointestinal, that is non-enveloped. So these kind of things are there. Non-structural proteins are 6 in number. NS non-structural 2, 3, 4, 5. 4 there are 2 subtypes, 5 there are 2 subtypes, A and B. 2, 3, 4, 5. 4 subtypes A, B, 5 subtypes A and B. NS1 is not there. Please understand. There's no NS1. 2, 3, 4, 5. 4 and 5 crossover. Now, genotypes are further subdivided, subtypes more than 100 things are there, but 6 major you please do understand. This non-structural protein, the current system that ELISA kits are made to detect this. So genotype 1, 2, 3, 4, 5, 6 are there. In India, genotype 1 and genotype 3. 1 and 3. Parental transmission is more common. Blood transfusion, blood products, organ transplantation, needle contamination, never recap the needle. Vertical transmission may occur but low, 6% compared to hepatitis B, which is more 20. Sexual transmission more rare. It doesn't spread through breast milk, food, or contact. So incubation period and all the things are there. It is a long one. Worldwide infection is there. Only after 1990, this testing system has come. Testing system. Hepatitis C virus. Before that, people die because it's a very silent virus. It doesn't produce much clinical picture like that our hepatitis B or A. The first generation, second generation ELISA were used previously. In that, non-structural 3, 4 for detection of antibodies. But this 5 region, that is now in the third generation ELISA, NS5. Third generation ELISA is considering that NS5. So please do understand, non-structural protein, that antibody NS5, third generation ELISA. Quantitative antigen test is available. What company has made this particular one? HCV RNA PCR is there, and this automated quantity is tested by the Abbott company. This RNA PCR is slightly higher, price is high. So diagnosis of acute or current infection, monitoring the response for treatment. Because hepatitis C virus at times that treatment is warranted. So alpha interferon therapy and ribavirin were the treatment in the earlier part. Now what is there? Our gastroenterologist will come with that. So real-time transcriptase, reverse transcriptase PCR, real-time RT-PCR, 6CV RNA, confirmation, quantification, genotype determination, all the things can be done. So early stage of hepatitis C, mostly it is silent, asymptomatic, directly to the chronic infection stage after 6 months. So people, we can understand that IgM, they may persist for a variable time. IgG will persist for a long time. So what is the thing we have to see that non-reactive and all the things? Test outcome. Then reactive. Reactive means current HCV infection. Past HCV infection that has resolved, sometimes biological cause. Go for RNA PCR. If antibody test is giving positive, then go for RNA. That real-time PCR you can think of for RNA. So thing is that treatment of that thing, interferon alpha plus ribavirin. Earlier, other thing what I told is alpha interferon, pegylated interferon, which has been recent advancement has occurred. Here interferon alpha plus ribavirin. Combined therapy. There is no effective vaccine for hepatitis C virus. Then what is that vaccine available? Hepatitis A vaccine is there, 2 doses. Hepatitis B vaccine is there, 3 doses. When you have to give hepatitis B? At birth, 6 weeks and 6 months. Okay. Hepatitis A, you give after 1 year, not before. Then Delta virus. So we have mentioned that it resembles a viroid. Small size. They in fact viroid means planned negative sense single strand RNA. Drug addicts. Italy it was first discovered. Risotto, even scientist. Italy it was discovered. Transmission is similar. Now main thing is hepatitis B virus infected. In that patient, this will go and get infected. And then this needs help for that envelope. Hepatitis D cannot make its own envelope. So it needs help. B virus supports. Parenteral. So we have to think whether co-infection or super-infection. What is co-infection? Both people have entered. Hepatitis B as well as D virus enter simultaneously, then co-infection. And what happens? Super-infection. Already hepatitis B virus is infected. On that top, then this D virus enters. Defective virus. Negative sense. Transmission similar. It can cause fulminant hepatitis. So any vaccination, if we are doing vaccine, if we give the vaccination for hepatitis B, that will take care of this hepatitis D virus. So we have to look for the certain things. What to diagnose? HPS-AG is there in co-infection.
Can I give you one mic?
In super-infection also, this is present. What? HPS-AG. In super-infection, you will find that HBA-E antigen is there, but here antibody to hepatitis 4 IgM will come. Little difference is there. HDV RNA is there, but here is anti-HDV and all. So co-infection and super-infection, where the problem cirrhosis is more, chronicity is more, fulminancy is more, that all happens in super-infection. Vaccine for hepatitis B virus automatically will take care of the hepatitis D also. Preventive measures essentially the same for. Come to the this hepatitis E virus. What is this? This E virus is an enterically transmitted virus. Just like the A virus, enterically transmitted, non-enveloped. Size of the D virus is 35, we mentioned. E virus is 30. C virus we have mentioned 60. So please try to understand what is the relation. E virus is a positive sense. D virus is a negative. Single genotype. Type 1 and 2 more virulent. Type 3 and 4 attenuated. Who is more problem? Pregnant individuals, if they develop, the mortality rate is up to 20%. RNA virus, single stranded, non-enveloped. In India, Middle East like that, 1955, 30,000 people are infected. So we have already mentioned that during pregnancy, mortality is very high. So what to look for that? You look for the IgM antibody, look for the IgG antibody. So incubation period is about 60 days. So we have already talked, pregnant women, 20% fulminant hepatitis. Zoonotic disease, hepatitis E virus is zoonotic disease. Young adults are affected. There is no treatment for the hepatitis E virus, no specific antiviral drug. General measures for prevention, containment of infection, same described as for the HEA. China has produced one hepatitis E vaccine, 2-3 names, but not yet available globally. G virus, we have already mentioned GB, that one surgeon from his blood that they have first noted. It co-infection with HIV is about 35%. The fact is that hepatitis G virus infection has got a protective against HIV. The people are living a longer time. So what to look for the hepatitis A virus? Look for the antibody IgM, recent infection. Look for the antibody IgG for the remote infection. Two things. For hepatitis A virus, antibody IgM and IgG. Okay. Hepatitis B virus, what to look for? You look for the surface antigen, recent infection, antibody to the HBsAg. That means after support. E antigen is highly infectivity is there. What about this one? Antibody has come to the HBe, infectivity becomes low. Now the most important thing we have already mentioned is antibody to the hepatitis core antigen IgM. That shows very important thing. Patient started recovering. IgG means that already infection has occurred and is all right. Come to the hepatitis C virus. What you wanted to do? This antibody IgM and IgG both can be seen. D virus. This antibody hepatitis D virus IgM, it stays for some period, long period. What about the E virus? Mainly the IgM and IgG. So ELISA kits are available. Hepatitis C virus RNA can be qualitatively detected, quantitatively it can be estimated. So please do understand there are 5 viruses common in which A and E, these two things are enterically transmitted, non-enveloped virus. They are icosahedral symmetry. They are checking that IgM is there or IgG like that. The E virus is a problem only for pregnant women. 20% of the pregnancy mortality possibility. In Delhi, it occurred in 1955, 30,000 people died. E virus is a very simple one, mild one that everybody, children are getting infected and they recover well. But please see that water must be treated and piped system. Pollution of the water has to be prevented. That is the main thing. People cannot contaminate the water and all that. Sometimes they will just take elephant and they wash in the drinking water source. Sometimes this laundry work if they are carried out, or the factory water if it is allowed to go inside, then this drinking water will get affected. Shellfish, all the things which are grown up in the polluted water invariably can spread this hepatitis A virus. We have told that B, C and D. In that parenteral, B is the only DNA virus. So this DNA virus carriers is very high, 350 million carriers. So who is having the infection, who is not having the infection, we do not know. So always we should understand that these transfusion transmitted viruses are being tested in the blood bank so that it is certified. There is no blood-borne pathogens. As per the drug controller direction, it's mandatory to test hepatitis C virus after the 1990s. Before that, nobody bothers, nobody knows. So this, please try to understand all the details pertaining to the hepatitis viruses, and you should do wonders while doing your professional work in the future. I believe that I have tried my level best to simplify the things. Even though I am given the last but one speaker to talk, and before that people have done, I have just I have to recollect certain things which is no other way to understand that if I am talking only laboratory diagnosis, it will be a rough, that's a dry, monotonous. That's why little bit background also I have taken inside. Finally, read the chapter, as many books possible, especially Tropical Medicine by Manson. Very nice, Tropical Diseases by Manson. Mandel's infectious diseases. Excellent writing. That English standard, when they are writing this developed country people, very super. You will enjoy to read all the things. Please refer the standard books. Our library is having the entire set of books available. Whenever you are free, you please try to visit, see the book, read the chapter, and thoroughly master the topic viral hepatitis. Thank you for the patient listening. Only few minutes more. If any questions, any doubts, I think that Dr. Mahendran will allow you to speak. Now I stop sharing. Mahendran.
Sir, சொல்லுங்க sir.
I think that whatever I wanted to tell is over. 3 minutes more.
So if at all any doubt, they can post in chat box, sir.
Chat box. And another thing, I believe that there are this batches, this viral hepatitis theory class we can avoid taking again, isn't it? Because we are dealing for one day with excellent people from outside as well as our people also. And what I feel is that hepatitis virus they will read, and only by reading more and more they will understand. And if they start a discussion, then it will be very nice. So all the things that I am sure that these people nowadays, people they are all merit students, and they will do more things. So thank you for the patient listening.
Thank you, sir.
Thank you. Thank you.
Thank you, sir,
Yes.
for inviting us to the session. So I'm privileged to introduce the next speaker, Dr. B. Vinoth, consultant gastroenterologist, Aravindhan Medical College, Puducherry. Good afternoon, sir.
Good afternoon. Can you hear me?
Yes, sir.
Yeah. Okay.
I'll be introducing you, sir. He has did his MD General Medicine in Kastuba Medical College and DM in Madras Medical College, Chennai. And he has published over 17 research articles till date. So we are overwhelmed to have you with us, sir, for the CME. Sir will be sharing us his knowledge on the management of viral hepatitis. Over to you, sir.
Yeah, so now okay. You will be able to share your slides, sir.
I think you can. No, I had sent my PPT again. You can open it up.
Yes,
okay, sir. So we'll be sharing the slides, sir.
Yeah, because I have some problem. Yeah. Can we start? Yeah.
Start your presentation, sir.
Yeah, can I start? Yeah.
Yes, sir.
So my topic will be management of hepatitis, viral hepatitis, and I would like to thank all the organizers for giving me this wonderful opportunity. And the overview will be the management of hepatitis A, B, C, and D and E infections. 1 minute. Usually, it was hepatitis management of hepatitis B and C used to be very complicated previously. All the speakers might have told all the pegylated interferon-based and ribavirin-based managements before, but nowadays everything has been simplified due to the introduction of directly acting disease antiviral drugs (DAAs), and the duration, everything has changed. And this is based on recent AASLD guidelines. and topics will not be covered. I mean, topics not covered or treatment in special situations, complicated treatment failure cases, transplant situations, because it will be way beyond the scope of this topic. And to move on, next, first we will see the management of hepatitis A virus. As we all know, there is no specific antiviral drug available for hepatitis A, and thankfully, usually it is self-limiting disease, and patients will go on to develop acute liver failure only in less than 1% of the patient, and usually the treatment is only supportive care. Most of them, almost everyone will clear the virus, and no one will go for chronicity. Hence, the management of hepatitis A is just supportive care, and no antiviral therapy is required for hepatitis A. Next, management of hepatitis B. Here, actually, only few drugs has been approved for US FDA approved for treatment of hepatitis B currently after 2016. Previously, as told, pegylated interferon based, ribavirin based treatments were available, and it was very, very cumbersome. Patients had so many side effects, and the duration was quite long. Patient could not able to complete the treatment duration. But with the advent of direct acting antiviral drugs like entecavir and tenofovir with very high potency and very high efficacy and very few side effects, nowadays most of the treatments are based on these two drugs, entecavir and tenofovir, and pegylated interferon is almost outdated actually. But there are some special indications where you can try pegylated interferon, but nowadays we use only either of these two drugs, entecavir and tenofovir. I could not move the cursor, but so it will be very difficult for the people to follow what I'm going to say. Previous slides. One minute. Actually, I'm trying to join through another link. Can you find out? Hello? Hello?
Yes. Yes, sir.
I'm trying to join through another link. Can you find out?
1 second, sir. Sir,
the other one, Dr. Vinoth at gmail.com. 1 minute.
sir, this one is Dell something. Your
Yeah.
video is there.
Yes.
You want to make that presenter, sir?
Yes. And I have to share my slides, sir, so that I can use this one.
I think you can share your slides, sir.
How to share this one? Share, yeah. Content. Can you just help me out? Hello?
Sir?
No, can you just help me how to share file?
Sir, like there will be a share button below the screen.
Yes.
You have to click it.
Hmm.
And you can
Yes.
see some windows, sir. If you have
Yeah.
that open the PowerPoint, if you're just clicking it, it will be enough, sir.
Yeah. Now you can see.
Yes, sir. We can see the windows. You
Yeah,
can see
okay.
your presentation, sir.
Okay.
Okay, so can we proceed?
Yes, sir.
So, okay, so
Sir, please unmute, sir. You are not audible.
Yeah. Now, am I audible now?
Yeah, now audible, sir.
Yeah. Okay. So sorry for the inconvenience. I thought it will be better to explain if I use my screen. Okay. So now going on to the management of hepatitis B. These are the recent drugs which are approved by FDA for treatment of hepatitis B. Previously, as I told, pegylated interferon and ribavirin-based treatments were used. It was very cumbersome. It was having many side effects. Patient could not complete their treatment course. And thanks to the recent inventions of directly acting antiviral drugs like entecavir and tenofovir, we are purely moved into monotherapy-based treatment regimens. Okay, so one has to know about all these drugs in detail. Coming to pegylated interferon, it has a finite duration of treatment of only 1 year. You can give pegylated interferon only 1 year. That is the biggest advantage of pegylated interferon, though it has so many side effects. Either it can be given as alpha 2A preparation or 2B preparation. 2A preparation is given for adults and 2B preparations is given for children. The dose is 180 microgram weekly for adults, and children more than 1 year, the dosage is 6 million international units 3 times weekly. The side effects are more, as I told, it has flu-like symptoms, fatigue, mood disturbances, it has psychiatric manifestations, cytopenias, autoimmune hepatitis disorders, weight loss and other things in children. And you have to monitor the patients on pegylated interferon with the complete blood count, as it can cause cytopenias, and TSH should be monitored every 3 months. And patient can develop autoimmune problems, neuropsychiatric problems, and infection problems in patients receiving pegylated interferon. And in pregnancy, it is belong to category C. So it's difficult to treat the patient who are pregnant. Coming to entecavir, the dosage is 0.5 milligram daily. Usually given even in children more than 2 years of age. It is weight based if they are less than 30 kg. And if they are more than 30 kg, you can give 0.5 milligram as adults. Again, category C drugs in pregnancy. The main side effect is lactic acidosis, and hence you have to monitor lactic acid in decompensated patients especially. And if patient has HIV co-infection, then treatment adjustment has to be made. Coming to tenofovir disoproxil fumarate, it has the dose is 300 milligram daily. It should not be given for children less than 12 years, and it is safe in pregnancy. It has nephrotoxic and bone defects. Fanconi syndrome can occur. Patient can develop lactic acidosis, and hence you have to monitor renal parameters if you are giving patients with tenofovir disoproxil fumarate. The recent addition is a variation of the molecule of tenofovir, which is called tenofovir alafenamide. It is has lesser side effect and less dosage is required, and hence it can be safely given in mild to moderate CKD patients. However, lactic acidosis side effect and nephrotoxicity side effect is still there, but the side effect is less when compared to tenofovir disoproxil fumarate. This is regarding the drugs which are used currently for treatment of hepatitis B. If you see, we mostly give only entecavir and tenofovir, and either of tenofovir disoproxil or tenofovir alafenamide based upon patient's preference, because it is cost effective when compared to tenofovir alafenamide, though it has very less side effects. And if you take pregnant women, the drug of choice is tenofovir. If you take children, the drug of choice is entecavir. So this is just an outline of the drugs which are used for management of hepatitis B treatment. Next, you must know the efficacy of all these drugs. Efficacy of all these drugs: pegylated interferon, entecavir, tenofovir. The aim of the treatment should be, these are all the aims of treatment. You must be able to suppress the HPV DNA, and you should be able to clear the HBeAg antibody and HBeAg antigen
must be able to clear the HBeAg antigen, and you should be able to produce HBeAg antibody. This is called HBeAg zero conversion, and the aim is to normalize the ALT, and the aim is to clear age, not a treatment outcome, but it is very less. So these are the 5 outcomes or the goals why we are treating patients with hepatitis B. And if you see the efficacy of these various drugs, the efficacy is almost equal, or if it is superior with entecavir and tenofovir when compared to pegylated interferon. And hence, instead of cumbersome pegylated interferon, US FDA has approved these 2 drugs as monotherapy for management of hepatitis B. As you all know, chronic hepatitis B patients are broadly classified into HBeAg positive and HBeAg negative category, depending upon whether they are HBeAg positive or not. And the response, if you see, the response is quite good in both of the categories, but the response is very much higher in terms of DNA depression in patients with HBeAg negative group. Okay, however, the HBsAg loss is very less in patients with HBeAg negative group. HBsAg loss is to the tune of 2 to 8% in patients with HBeAg positive group. So based on this criteria only, US FDA has approved, we can go ahead with only entecavir or tenofovir instead of pegylated interferon. This is very important tabular column. We have been told about all the phases, various phases of chronic hepatitis B. But this is very important. I would like to stress the point again, because based on this phases of hepatitis B infection, one will decide the treatment plan. Usually there are 4 phases: immune tolerant phase, immune active phase, inactive chronic hepatitis B, and reactivation. So only 2 category of patients require treatment. One is immune active chronic hepatitis B, the other is reactivation. Only these 2 group of people requires antiviral therapy. Immune tolerant phase and immune active phase will not require antiviral therapy, and just they can be watched and they can be followed. To define what is chronic hepatitis B, HBsAg should be present for more than 6 months, and HBV DNA will be detectable and varies between undetectable to several billion international units. And either based upon HBeAg, it is divided into either it is positive or negative. You have to know that if HBeAg is positive, the viral load is usually high. If HBeAg is negative, the viral load is usually low. And ALT level can vary based upon the phases. But liver biopsy also can show variable amount of necroinflammation and fibrosis. So now how will you pick up the patients in each phases? Immune tolerant phase, this is the first phase. The virus enters, okay, it keeps on replicating inside the liver, but our immunity doesn't do anything. It just keeps watching. The HBeAg will be positive because of replication. HBV DNA level will be very high because it keeps on replicating. We are not doing anything against the hepatocytes infected with viruses. So there is no inflammation going inside the liver. So there is no elevation of ALT and AST. And if you do biopsy, there won't be any inflammation with, there won't be any fibrosis with very minimal inflammation. So based on all these criteria, you can make a diagnosis of immune tolerant chronic hepatitis B. In this phase, there is no need for any treatment. Then the patient goes into the next phase of immune active chronic hepatitis B, where our immunity starts to fight against the viruses which are infecting the hepatocytes. So it tries to destroy the hepatocytes infected with viruses. So the viruses are reduced. So you can see that the virus level will come down. It won't be in lakhs. It will be only in thousands. If in HBeAg positive category, it will be more than 20,000. In HBeAg negative category, it will be more than 2,000. And since there is inflammation going on inside the liver, trying to remove the virus, you will have elevation in ALT. And if you do biopsy, because inflammation is going on, you will see inflammation and there is little bit of fibrosis. So after this stage, then we go to the next stage where we succeed in fighting against the virus. So everything becomes calm. So nothing happens inside the liver. You are succeeded in reducing the viral load. So the viral load is reduced. Okay. and then HBAG becomes negative, there is no replication. Anti-HBAG becomes positive, so there is immunity developed inside our body, and there won't be any inflammation at present. ALT will be normal, and there will be minimal fibrosis, but no significant necroinflammation. So this is the case of inactive chronic hepatitis B. Mostly we will be picking only this group of people in our adult population. If they come to us, mostly we will be dealing with inactive chronic hepatitis B. If you do HBsAg, it will be positive. HBAg may be negative, anti-HBAg positive. HBV DNA will be less, or with normal ALT, and liver fibrosis or other studies with non-invasive studies for fibrosis will be normal. Again, these groups need not require any treatment. Again, the other group is reactivation. So after this group, patient can develop again elevation of HBV DNA levels, or if you had cleared the HBsAg, again HBsAg will appear again. This category is called HBV reactivation. Usually it occurs in when you are treating the patients with immunosuppressive drugs or immunocompromised. If they go for immunocompromised state, our virus will again come. So this is a stage of HBV reactivation. Again, this group requires treatment. So this algorithm is this tableau column is very important. We need to treat immune active chronic hepatitis B, and you need to treat HBV reactivation. No need for treatment in immune tolerant and inactive chronic hepatitis B. Having said that, according to the latest guidelines, the cutoff of ALT has been reduced. For males, it has been reduced to 35 international units, and females, it has been reduced to 25 international units. And again, as I said, tenofovir alafenamide has been recently included, and it is preferred drug for therapy because it has less nephrotoxic effect and less bone side effects in the form of osteomalacia when compared to tenofovir disoproxil fumarate. However, the cost is high. So now coming to the very important algorithm, the main algorithm of treating patients with HBsAg. As I told, you can divide the patient into HBsAg positive or HBsAg negative. Sorry. So the patient comes to you, you are doing HBsAg. If it is positive, then you have to look for HBsAg. The second thing you have to look is HBsAg, to divide the patient into whether HBsAg positive category or HBsAg negative category. Next thing what you should do is you have to look for ALT levels, because the most important thing which is going to tell you to going to help you decide based on decide the treatment plan is ALT levels. Only if ALT level is more than 2 times the upper limit of normal, we need to treat the patients. So the third thing what you want to see is ALT levels. Okay. And the fourth thing what you want to do is HBV DNA level. So first test HBsAg, then HBeAg, and then ALT level, and then HBV DNA level. So in HBeAg positive group, the first group, if ALT is more than 2 times the upper limit of normal and HBV DNA is more than 20,000 international units, directly you can put the patient on treatment with either entecavir or tenofovir. Okay. And if ALT is normal and HBV DNA is less, then no need to worry. If it is more than 20,000, you can just monitor the patient every 3 to 6 months. And if ALT is between 1 to 2 times the upper limit of normal, and if it is more than 2 times of the upper limit of normal, but HBV DNA level is less than 20,000, this constitutes a gray area. And based on few other additional aspects, you need to decide treatment plan. The additional aspects are, you need to do non-invasive investigation or liver biopsy to look for inflammation and fibrosis. If there is A3 or more inflammation and F2 or more fibrosis on liver biopsy, or with non-invasive investigations like fibroscan, you can find out the fibrosis score if it is more than 12.5 pKa, or if the age is more than 40, then you can treat these gray areas with antiviral therapy. And again, in these two areas, you need to be very careful to rule out other causes of hepatitis like autoimmune hepatitis, drug-induced hepatitis, metabolic hepatitis, and things like that before starting on antiviral therapy, since it is a gray area. Coming to the HBH negative group, you are seeing the ALT levels. If the ALT levels is more than 2 times the upper limit of normal and HBV DNA is more than 2000 international units per ml, you can start treatment. And if the ALT level is normal and if it is less than 2000 international units per ml, then no need to worry, you can follow them. All the other groups are again comes under gray area, and based upon the additional findings, you can decide on treatment plan. Additional findings are similar to the one discussed with the HBAG positive group. Rule out other causes of viral hepatitis, rule out seroconversion, and you can monitor LFT and HBV DNA every 1 to 3 months of it. And if it persists more than 6 months, ALT persists more than 6 months elevation, then you can start this group on treatment. So this is the treatment algorithm for chronic hepatitis B, HBAG positive group and HBAG negative group. Having decided the treatment drug and this next thing is you have to decide the duration of treatment. For that, you need to monitor HBV DNA level and LFT every 3 months till the HBV becomes undetectable. So HBV DNA level has to be monitored. Our aim is to clear the virus. Hence, HBV DNA has to be done. In HBAG positive group, you can try to stop the treatment because there are certain endpoints to the treatment in patients with HBAG positive category. That is, seroconversion is one of the endpoint. That is, HBAG becomes negative and anti-HBAG becomes positive. So this is one endpoint. Till that, you have to continue the drug. And after attaining HBAG positive, you have to continue for 1 more year. That is 12 months. That is called consolidation phase. And after this, if there is persistent undetectable HBV DNA, you can try to stop treatment. Or the other endpoint is until HBsAg is clearance. This is the ultimate endpoint. If you are able to clear the HBsAg, then it is well and good. Then you can try to stop treatment. But if you come to HBAG negative category, this is quite a difficult group. And many studies have shown this HBAG negative chronic hepatitis B group has higher risk of progression to cirrhosis, hepatocellular carcinoma, decompensation, etc. And hence, most of the studies advocate usually lifelong therapy for hepatitis. HBAG is negative chronic hepatitis B, but some says that you can consider stopping the treatment even in this category if there is HBsAg loss. But irrespective of whether you are stopping the drugs or not, one has to monitor every 3 months for at least 1 year for viremia, ALT flats, seroconversion, and clinical decompensation in this category of groups. So after putting the patient on treatment, you are monitoring HBV DNA level. Then you are not able to completely clear the virus. Hence, so this is this is called as persistent low-level viremia. It is defined as failure to achieve undetectable HBV DNA level after 96 weeks of therapy, or you are able to reduce the HBV DNA level to some extent, and then it doesn't come to 0. Instead, it comes it maintains a plateau level. Again, it is called as persistent low viremia. In this category, you will not be able to stop the treatment, and most of the studies advocate continuing the therapy or either discontinue the therapy. Most of the studies advocate to continue the therapy to prevent complications. So what is treatment failure? So once you have achieved the treatment response of HBV DNA undetectable level and the ALT normalization, and if during the course of treatment, if there is sudden increase in HBV DNA from the baseline to the tune of 1 log, that is 10 times increase in HBV DNA level, then it is called viral breakthrough. Biological breakthrough is again elevation of ALT levels. This is called treatment failure. In this category, you need to decide based upon whether patient what the patient has received previously. It looks very complicated, but it is very easy. Any drug other than tenofovir, if you had given previously, you can put the patient on tenofovir. If you had given tenofovir previously, you have to give them on entecavir. That's all. It's very simple. Any drug given before except tenofovir, you put them on tenofovir. If you had already given tenofovir, you have to put the patient on entecavir. That's all. It looks complicated, but it's very simple. So with that, we have finished chronic hepatitis B. This is a simplified treatment approach. There are so many subdivisions, subspecial categories, etc. But I'm not touching all those things. Now coming to acute hepatitis B infection, as everybody told previously, it is very well self-limiting disease. Only 5% goes for chronicity, 95% clear the virus, and less than 1% develop acute failure. Patients do not require treatment with acute hepatitis B, but there are certain special conditions wherein you can give antiviral drugs. So there, here the condition is the patients with acute liver failure or who have protracted severe course, as indicated by total bilirubin level of 3 mg with direct bilirubin more than 1.5, INR more than 1.5, encephalopathy and ascites. This group of people can be given entecavir or tenofovir. How long to give? It should be given until HBsAg clearance is confirmed or indefinitely in those who undergo liver transplantation. Here, pegylated interferon is contraindicated. This is also quite simple. I would like to touch chronic hepatitis B in pregnancy because this is quite common and we used to see in our day-to-day practice. Chronic hepatitis B in pregnancy, you need to, our main aim is to prevent the transmission of virus from mother to baby. This is our primary aim. So what you should do for that, you have to see for HBeAg, the viral replication capacity, HBeAg, and HBV DNA level at 28 weeks. If the patient has HBeAg positive status with HBV DNA level of more than 2 lakh, you need to give the patient antiviral drugs. As I told, tenofovir is preferred because it is category B. It will be started from 28 weeks till delivery or can be continued till 3 months postpartum. Okay, breastfeeding is not contraindicated in patients. One has to watch for decompensation in the first 6 months because most patients are prone for decompensation only during the first 6 months. And as discussed earlier, both active and passive immunization should be given within 12 hours of delivery. So check for HBeAg, HBV DNA at 28 weeks. If HBeAg is positive and HBV DNA level is more than 2 lakh, you can start tenofovir from 28 weeks till delivery or can be continued till 3 months. Breastfeeding is not contraindicated. Watch for decompensation in the first 6 months. And immunization within 12 hours of delivery, both active and passive. Coming to prevention, this is often neglected topic, but it is very, 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 very important because if you sit in your private practice, this will be the questions asked to you, whether I can get married, whether I can have sex with my partner, whether I can touch my son, whether I touch my daughter, so many things, whether I can use soaps and other things, towels, etc. So you will be asked so many questions regarding this tabular column. One has to know everything about this. Okay, so person who are HBsAg positive, we should have household sexual contacts vaccinated, especially the spouse. Spouse has to be vaccinated. You have to check the spouse if he or she is HBsAg negative and anti-HBC negative, then you can vaccinate the spouse. And the patient has to use barrier protection if they are sexually active. They should not use share toothbrush, razors, injection equipment, glucose testing equipments. They should cover their cuts and scratches, and they should clean the blood spills with bleach solution. Bleach solution is obtained by combining bleach 1 part and water 9 part. They should not donate blood, organs, and sperm. Children and adults of HBsAg positive state can attend all activities, including contact sport. They can participate in daycare and school participation and should not be isolated from other children. They can share food and utensils and kiss others. This is very, very important. And you need to educate the patient. This only you can be able to educate the patients with HBsAg positive state. So with that, we have completed the management of chronic hepatitis B and acute hepatitis B. Now we will move on to management of hepatitis C. ASLD has clearly come out with the guidelines that antiviral treatment is recommended for all adults with acute or chronic HCV infection, except for those with short life expectancy that cannot be remediable by HCV therapy, liver transplantation, or another directed therapy. Hence, you need to treat any patient with HCV infection, acute or chronic. Successful treatment also confers improvement in extrahepatic manifestation of HCV in the form of cryoglobulinemic vasculitis, non-Hodgkin's lymphoma, and lymphoproliferative disorders. And the quality of life is also improved. Hence, one has to be treated. Now, again, I'm moving on to the simplified treatment plans for hepatitis C. You can divide the patients into 3 categories: patients without cirrhosis, patients with cirrhosis, compensated, and patients with cirrhosis decompensated. First, we will see the simplified treatment protocol for patients with without cirrhosis. They are just detected to be HCV positive. They have not received any treatment and they do not have cirrhosis. These are the eligible patients. Again, you need to rule out, before starting treatment, you have to rule out prior hepatitis C treatment. Cirrhosis should not be there. End-stage renal disease, HIV, HBsAg, pregnancy, hepatocellular carcinoma, prior liver transplantation has to be ruled out. You need to do a bunch of investigations because you need to rule out all these things. It's very simple. Fibroscan to rule out liver fibrosis, ultrasound abdomen to rule out cirrhosis, and a drug history to rule out drug interactions if you are giving antiviral drugs. Then you need to, before treatment, you need to do complete blood count. LFT and GFR should be done before before starting the treatment. Again, you have to do HCV RNA viral load, HIV and HBsAg to rule out the coexisting viral infections, and you have to rule out pregnancy. So these are the bunch of investigations you should do before starting the patients on antiviral therapy. So the drugs recommendations for patients with hepatitis C and without cirrhosis is glycaprevir 300 mg, piperantazvir 120 mg given with food for a period of 8 weeks, or sofosbuvir 400 mg, velpatasvir for a duration of 12 weeks. Only these 2 regimens can be given. And this is pan-genotypic, irrespective of the genotype. As previous speakers, many of them have told you have to do genotyping for hepatitis C before treatment. But nowadays, you need not do genotyping for patients with you need not do genotyping for patients with hepatitis C. And you can, this is pan-genotypic, and you can start the patients on glycaprevir, piperantazvir, and sofosbuvir, velpatasvir, either for 8 weeks or for 12 weeks. After putting the patient on treatment, one has to watch out for hypoglycemia in patients with diabetes because there is drug interactions, and patients who are put on warfarin, you need to monitor them because there may be suboptimal response for warfarin. So after treatment, one has to ascertain treatment response. At the end of 12 weeks, you should do HCV RNA to make sure that the HCV RNA viral load has cleared. Okay, and if it has cleared, and even then, if there is elevation of transaminases, then you need to look for other causes. So after achieving the viral response, there is no need for further follow-up since the patient has not cirrhosis. If the patient is high-risk group like sex workers and healthcare workers, then you need to monitor them with HCV RNA once in a year, and then LFT also. And they should not take alcohol. Thing is, if the patient do not achieve a viral response, what to do? The most simple thing is you can refer the patient to a specialist. But if the patient are not to be retreated, then you should be assessing these patients for disease progression every 6 to 12 months with LFT, CBC, and INR. And again, advise the patient to avoid alcohol. So next category of compensated cirrhosis. Here, who are all the patients fitting into the categories? Recently detected hepatitis C with evidence of cirrhosis during routine investigations. Again, patients who are all contraindicated is patient with decompensation. Patient should not have decompensation. That is, the patient should not have ascites, hepatic encephalopathy, elevated bilirubin, low albumin, or elevated PTINR. Liver function should be normal. It is called compensated cirrhosis. They should not have decompensation. Patient should not have associated hepatitis C. Prior hepatitis C treatment should not be there. Patient should not have end-stage renal. All these things are similar to the one we discussed earlier. Pre-treatment assessment is almost similar to the one we discussed earlier. And before starting treatment, here you can do genotyping, because for genotype 3, if you are planning to treat sofosbuvir and velpatasvir, then genotype 3 patients you need to give a little adjustment. So here HCV genotype can be done if you are planning to put the patient on sofosbuvir velpatasvir. Otherwise, even here genotyping is not required. So the preferred therapy is glycapravir, peparantazvir, as previous, like the previous one, without fibrosis, without cirrhosis for a duration of 8 months, and all the genotype except genotype 3, sofosbuvir and velpatasvir for 12 weeks. In genotype 3, you need to do RAS mutation. If the RAS mutation is present, then you need to add ribavirin, weight-based ribavirin to this, or you should add oxalipravir. Okay. Otherwise, genotyping, if you are planning to give this one, genotyping is again not required. Okay. Again, you need to, here you need to be careful because there is a risk of decompensation when you are treating the patient. Because the patient is having cirrhosis, patient can develop decompensation, and you should watch for decompensation in the form of LFT, PNR, PTINR, and other things. Again, in diabetics and patients with anticoagulation, you need to be careful regarding the drug interaction. At the end of 12 weeks, you need to do viral clearance study and follow in patients with, even if you are able to give us sustained virological response in the form of viral clearance, since the patient has cirrhosis, one has to be followed up for development of HCC and development of esophageal varices. Okay. Again, here, if you are not able to achieve virological response, if you are not able to clear the virus, the easy thing is you can refer the patient to a specialist, and you have to follow the patient because patient is having cirrhosis. You need to do the ultrasound surveillance for HCC and endoscopic surveillance for esophageal varices, and you need to follow them for disease progression every 6 to 12 months and ask them to abstain from alcohol, as said earlier. Now, moving on to the third category, patients with hepatitis C and decompensated cirrhosis. Here the regimen is decided based on whether the patient is ribavirin eligible or not. If the ribavirin, you can give ribavirin in this group. You can start sofosbuvir and velpatasvir for 12 weeks along with weight-based ribavirin, or you can start ledipasvir or sofosbuvir in 1, 4, 5, and 6 genotype with weight-based ribavirin. If you are giving ribavirin, the duration is less. It is for 12 weeks. If you are not able to give ribavirin, then the duration is more, 24 weeks, and the response is less. That is the importance of ribavirin. If you give ribavirin, the duration is less and the efficacy is more. The success rate is more. So in a patient who are not eligible for ribavirin, again, sofosbuvir and velpatasvir should be given for 24 weeks instead of 12 weeks. And ledipasvir and sofosbuvir should be given for genotype 1, 4, 5, and 6 for 24 weeks. Now moving on to hepatitis B. We have completed hepatitis C. Moving on to hepatitis D. It is the least common cause of hepatitis, but it is more severe and very difficult to treat because they lack viral enzymes. So we do not have any target for therapy. The only drug to have proven benefit is conventional interferon or interferon alpha, which is given as 9 million units 3 times a week for 1 to 2 years with a success rate of only 22 to 25%. Pegylated interferon with various DAS has been tried, but the success rate is very less. And there are many drugs which are in the pipeline, especially the one promising is lonafarnib, which is prenylation inhibitor, but all these things are in pipeline and it has not been FDA approved. Hence, management of hepatitis D is quite cumbersome and less successful. And this is my last slide regarding management of hepatitis E. Hepatitis E is again usually self-limiting, and usually supportive care is the one which is needed. Most of them won't go for chronicity, but there has been studies, so many studies which shows patient with hepatitis C can also go for chronicity, especially in the setting of immunocompromised state. Only patients with immunocompromised state will not be able to clear the virus and they will go for chronicity. If the virus persists for more than 3 months or 6 months, then you can start the patient on treatment with 3-month course of ribavirin monotherapy. If you are successful, then it's well and good. If you are not successful, if the relapse again, then you have to retreat the patients with 6 months course of ribavirin monotherapy. If there is no response with the 6 months of ribavirin, then you have to go for pegylated interferon based therapy for 3 months. This is regarding management of hepatitis E. So to conclude, previously the treatment of hepatitis B and C were very cumbersome and it was very confusing whether to do genotyping for hepatitis C or not, and many side effects were there for patients with the treatment, patients put on pegylated interferon. But now everything is quite simplified and it is quite very clear that patients can be started on monotherapy of either entecavir or tenofovir in patients with chronic hepatitis B, and patient can be put on, any patient can with hepatitis C can be put on safely with a pan-genotypic drug therapy of sofosbuvir and velpatasvir for 12 weeks, except genotype 3 with with cirrhosis. In that case, you need to add ribavirin based therapy, or you can add oxalipravir. So with this, I would like to thank the organizers for giving me this wonderful opportunity, and I would like to answer the questions if there are any. Thank you.
Thank you, sir.
Thank you.
So if there is any doubt, you can ask, sir will be able to answer. We have shared the feedback link in your mail, and you are expected to fill the feedback form. Thank you, sir.
Thank you.
Really, it was a very enlightening speech.
Okay.
And now we have come to the end of the CME, and I would like to call Dr. J.K. Pungade ma'am, Assistant Professor, Department of Microbiology, to give vote of thanks.
Good evening, everyone. It gives me immense pleasure to extend vote of thanks on this wonderful CME on hepatitis on behalf of the Department of Microbiology. At the outset, we express our sincere thanks to the Almighty to conduct this CME in a grand, successful manner. We would like to express our gratitude to our founder chancellor, late Dr. Shanmugasundaram sir. We convey our grateful thanks to our esteemed chancellor, Dr. A.S. Ganeshan sir, and the woman behind him, Dr. Anuradha Ganeshan, for their constant guidance and encouragement and support us in all our endeavors. We also convey our sincere thanks to our Dean sir for his constant support to bring out this CME in a successful manner. Our sincere thanks are also there for our beloved Dr. Vishnu Bhatt sir, MS sir, Dean HP madam, and VP sirs, both academic and students of us. Our fruitful thanks to all our speakers of the day, Dr. Jayalakshmi ma'am, Dean Slims, Dr. Suresh sir, DMS and HOD of General Medicine, Dr. Aravindhan sir, Senior Assistant Professor Paediatrics in Thanjavur Medical College, and our Senior PG student of AVMC, Dr. Mangaiyarkarasi ma'am, Dr. Vinoth, Consultant Gastroenterologist, AVMC&H, for that speech and spend the precious time to enrich us with all about hepatitis. We extend our sincere thanks to all our internal speakers, Dr. K.Sethumadhavan sir, for updating our knowledge on lab diagnosis on hepatitis, and also Dr. Vinoth sir, gastroenterologist, for his enlightened speech to update our knowledge on hepatitis. We thank the delegates for spending their time with us for this day to update their knowledge on hepatitis. Our thanks to all our HODs, faculties, and to our beloved UG and PG students. I'm extending my heartfelt thanks to my HOD, Dr. Lata Madam, for giving me an opportunity for vote of thanks. We also extend our thanks to the EDP people, audiovisual people, and the MU people for their effort in bringing out this session in a grand manner. Once again, I thank you everyone. Thank you all.
Thank you, ma'am. Now we can stand for national anthem. Thank you everyone for participating in this CME, and we are ending the session now. Thank you.